have breakfast. Greet your neighbor. How are you? How is Togo? How is Zimbabwe? The only country I'm missing is America and Britain.
Bonjour, Mawawati, Mawakaweni, Mawakapanji.
Good morning, good morning.
Good morning. Cyber.
The quorum is formed.
4 ministers in the polio room.
Okay, no, that's fine.
Good morning. Good morning, ladies and gentlemen, my colleagues. Quorum is formed. Business starts. Thank you for your participation yesterday. It was so live, learning a lot and sharing a lot. Today is day 2 of our business agenda. Honorable ministers, ladies and gentlemen. Excuse me, please, excuse me. Order. Could you please take seats? Take seats. Could we take our seats, please? The corner here on my right side, please, can you organize? Yeah, I believe they're preparing, but they should be quiet. And if you are doing your own job, please be quiet. Here, business has already started. By the door side, by the door, please. Excuse me, by the door. Do your job quietly. Order. Good morning once more. Prime Ministers, ladies and gentlemen, welcome to the second day of this 7th session of the Regional Committee of Africa. We shall start today's session with agenda item number 4, report of the Committee on Credentials. And therefore, give the floor to the chairperson of the Committee on Credentials, Dr. Makosi Ranyali. We have the floor.
Thank you very much, and greetings to the honorable ministers, the delegates. This is the report of the Committee on Credentials. In my capacity of a member of the delegation of Lesotho and as elected chair of the Committee of Credentials, I have the honor to report on the work of the Committee on Credentials to the Regional Committee. The regional committee appointed representatives of the following 7 member states as members of the Committee on Credentials: Botswana, Burundi, Guinea-Bissau, Lesotho, Mozambique, Niger, and Uganda. The Committee on Credentials met on the 25th August 2025 and elected me, Sidibe Mochovorane, from the delegation of Lesotho as its chairperson. Botswana, Burundi, Guinea-Bissau, Lesotho, Mozambique, and Niger attended the meeting of the committee. The Secretariat reported on the credentials received so far from the member states attending the 75th session of the Regional Committee. The committee mandated its chairperson to report to the Regional Committee on its behalf on the credentials submitted to the Secretariat as of the meeting of the Credentials Committee, and to examine and report to the Regional Committee on its behalf on any credentials received subsequently. As from this morning, 45 member states out of 47 have submitted credentials which were found to be in conformity with applicable rules and practices of the Regional Committee. The following member states have not submitted credentials and are therefore absent: Cameroon and Eritrea. As chairperson of the Committee on Credentials, I'll continue to report to the Regional Committee developments occurring in this regard, if required. I thank you, Mr. Chairperson.
Thank you very much. That's the report of the Committee on Credentials. In accordance with Rule 3, Sub-Rule C, the chairperson of the Credential Committee shall consider on his own behalf the acceptability of any credentials subsequently received and make recommendations thereon to this committee. That is, if some credentials have not yet been received. Are there any comments on the report on credentials? Any comments on the report of the Committee on Credentials? If there are no comments, I would like to propose that the Regional Committee adopts the report and therefore accept credentials of the member states as reflected in that report. Are there any comments? Are there any comments? To take it, the report adopted. Ladies and gentlemen, we shall now resume agenda item 10. Framework to advance universal access to safe, effective, and quality assured blood products in the WHO Africa region, 2026 to 2030, which is contained in document ASR/RC 75/7 with member states statements. We shall give the floor to member states in the order in which they raise their name plates. Yesterday, we are resuming from the order. Yesterday, we ended up with the Angola just finished. Now we are beginning with Benin. After Benin, it will be Seychelles. Benin, you have the floor.
Je peux commencer. Merci, Monsieur le Président.
Thank you, Chairperson.
Félicite le secrétariat.
Benin would like to congratulate the Secretariat on the quality of the report and the proposal of a framework to enable access to safe, efficacious, and guaranteed blood products in the African region. Benin notes with satisfaction the kind of delicate framework that exists in the WQ African region for the production of blood products, that 50% of blood products are still not met in the region, and this leads to serious health consequences. In Benin, since 2016, measures have been undertaken to improve infrastructure and qualified human resources and equipment, and to improve the experience of users in terms of blood products with the support of several partners. And so 85 of blood products were made in 2024, and blood products are integrated into the National Essential Medicines list. However, challenges still persist, the inadequate stockage facilities, especially in rural areas. New areas for new plans for blood transfusion include building 10 blood transfusion centers by 2027, the training of 10 clinicians in good transition practices, the objective of having 7 blood donors by over 10 by 2030. This framework will be a real roadmap for the African region to accelerate our progress towards universal health coverage for blood products, safe blood products in Africa. And therefore, Benin encourages countries of the region to adopt this framework. Thank you, Chairperson.
Now, Seychelles, followed by Tanzania.
Thank you. Mr. Chairman and distinguished delegates, the government of Seychelles warmly welcomed the WHO AFO framework to advance universal access to safe, effective, and quality-assured blood products. Blood transfusion remains a critical component of life-saving care, particularly in maternal emergencies, trauma, and chronic conditions. Seychelles acknowledges and commends the progress highlighted in this report, especially regarding strengthened governance, donor mobilization, and achieving 100% screening for transfusion-transmitted infections. While the supply of blood in Seychelles remains insufficient to fully meet demand, robust quality assurance systems in place ensure that all donor blood is rigorously screened and safe for transfusion. National standards and protocols are available and strictly observed, with patient safety as our utmost priority. Nevertheless, greater focus is required, notably on sustainable local donor recruitment, dedicated investment in infrastructure, and enhanced regional collaboration to address shortages and ensure the timely availability of blood products to save lives. Henceforth, Seychelles fully supports the proposed priority interventions and remains steadfast to actively working alongside WHO and member states to build resilient, equitable blood systems that protect and improve health outcomes for all. I thank you, Mr. Chairman.
Thank you, Tanzania, followed by Niger.
Yeah, thank you very much, Chair. United Republic of Tanzania support the proposed framework. Tanzania operates nationally coordinated blood transfusion services through the blood transfusion services following the WHO of 1972 resolution. In the financial year 2024-2025, the country has attained the blood collection needs as per WHO recommendation, 1% of the country population. Chairperson, the government fully funded national blood transfusion service operation since 2015, ensuring free blood transfusion services in all hospitals. Cost recovery strategy are still in the development stage. We are still expanding the regional blood centers to enhance donor convenience and outreach. In 2024-2025, voluntary blood donation contributed 55% of all donations, while 45% were from family replacement donors. Community sensitization continue via campaigns, mainstream media and social media. Chairperson, the NBTS, or National Blood Transfusion Services, screens all blood from transfusion transmissible infections in all 8 zones. 6 zone blood centers out of 8 are accredited at the step 3 full accreditation of stepwise accreditation program. Chairperson, Tanzania recognized the national blood use. Studies show less than half of transfusion are inappropriate indicated. Capacity building is ongoing through in-service training with plans to integrate into formal training curriculum in colleges and universities. We look forward to continue collaboration with regional and global partners in this important journey. Thank you.
Can we have Niger followed by Mozambique?
Thank you, Chair. Nigeria congratulates the WHO for a well-crafted report on the framework to advance universal access to safe, effective, and quality-assured blood products in the WHO African region, covering the period 2026 to 2030. We affirm the universal access to safe blood is a cornerstone of resilient health system and a critical enabler of UHC. Over the years, Nigeria has made notable progress in strengthening its national blood transfusion system through the foundational reforms of the National Blood Service Agency. Despite the strides, we acknowledge that the persisting high level of unmet needs for blood and blood products across the African region, including Nigeria, this gap continues to contribute to preventable mortality. Challenges including low voluntary blood donation rates, cultural misconceptions, limited public awareness, workforce shortages, and inadequate infrastructure and regulatory oversight continue to constrain equitable access to safe, effective, and quality assured blood products. Backed by political commitment and a result-driven roadmap, Nigeria's vision for 2030 is a universal, equitable, and sustainable access to quality assured blood for all Nigerians, fully integrated into a resilient health system and contributing to the regional leadership. By 2030, Nigeria aims to reach at least 15 blood units per 1,000 population, maintain a 100% voluntary non-remunerated blood donation rate, and ensure at least 70% local plasma product availability. Nigeria reaffirms its commitment to the framework and calls upon member states, development partners, and the global health community to adapt, and implement the priority interventions in the framework, endorse and adequately fund national strategic plans aligned with WHO's regional framework, integrate blood services into emergency care and health insurance schemes, support enabling legislation and innovation for blood products development, and collaborate to build regional capacity and resilience in blood services. Together, we can close the gap at the blood access gap and deliver on the promise of health for all. I thank you, Chair.
Thank you, Mozambique. From Congo.
Thank you very much, Chair, for giving me the floor. Firstly, I would like to take the opportunity to welcome the very competent report that has been published and relating to blood products. Now, blood is vital. It should be a priority in our country in the epidemiological context. So in Mozambique, what we have seen is that we have worked towards a blood-related health system which is robust. We are also developing strategies on a national scale to provide trans-border services. And relating to donors, unfortunately, we are below the average in the region. However, what I can say is that campaigns have been done in communities, schools, churches across the country. The goal there being to increase the number of donors. And what we have done on a systematic level is increase the ability of tests on a national scale. We've also increased the quality thereof. We also ensure that these services are high quality, standardized, And in terms of blood products, what we have implemented is continuous ongoing training for healthcare workers in clinics across the country. In Mozambique, the burden of illnesses means that there is an emergency on our hands when we need to ensure that blood transfusions are available all the time. I'm thinking of NCDs, trauma injuries, malaria. All of these diseases require urgent action. This is why Mozambique is supporting this initiative to promote access to safe, high-quality blood products. This is why we are looking to work hard together with you. Thank you very much.
Thank you, Mozambique. Congo, followed by Zambia.
Merci, Monsieur le Président. Monsieur le Président.
Thank you, Chairperson. The government of the Republic of Congo congratulates the WHO Secretariat for the work done to develop the framework that has been developed to advance universal access to safe, effective, and quality-assured blood products. Congo has a blood transfusion center whose key mission is to ensure self-sufficiency in blood products, and the transfusion activities are tailored to technological and medical solutions. Despite the strengths, practice quality blood products and a nice guide, and the opportunities presented such as technical and financial partners, we are faced with challenges, including lack of regulatory framework, a lack of blood service personnel and clinicians, a low percentage of blood donors, a low geographic coverage for the distribution of blood products, and lack of information on the products. Strategic guidance in this framework respond to our perspectives and to ensure the availability of quality blood products in the African region. Congo invites member states to implement the priority interventions that are part of the framework based on their national context. Thank you, Chairperson.
Thank you, Zambia, followed by Togo.
So thank you for the opportunity to respond. Zambia endorses the strategy to improve access to safe, effective, and quality-assured blood and blood products. What is Zambia doing? On policy, Zambia has developed a national framework to domesticate the World Health Organization strategy for access to safe blood. On blood products, Zambia needs about 400,000 units of blood each year. To meet this demand, Zambia is doing the following: donor recruitment, donor retention, and negotiating to leverage technologies from technology owners to increase the supply of plasma-derived products such as factor VIII, immunoglobulins, and albumin. Blood safety, Zambia targets to place apheresis machines, automated blood processing technologies, and pathogen reduction technologies at all major blood storage hubs. Access, Zambia has established storage hubs across the country. Zambia is also exploring the use of drones to increase access to blood and blood products. We are actually learning lessons from our colleagues in Rwanda. We also have a lot of challenges. One related to paucity of select technologies like the ones that I spoke about, religious norms, low pool of donors, and inequities between urban and rural populations.
our request is that the World Health Organization facilitates the leveraging of technologies between countries to improve access to plasma-derived blood products. I thank you. Togo, followed by Blake.
Merci, Monsieur le Président.
Thank you, Chairperson. Togo would like to thank the Secretariat for the framework to advance universal access to safe, effective, and quality-assured blood products in the WHO African region spanning 2026 to 2030. Togo adopted its blood self-sufficiency in blood products. Regarding the organization of services, we have a national blood transfusion center in Lomé and another regional center in Socoré, and within other areas. The activities of all these blood transfusion centers that service the entire territory are under the coordination of the National Blood Transfusion Center. We are trying to ensure universal access to blood products, and this is one of the things that has been added to the essential medical list. We have 8.2 personnel for a huge number of population, and this is not appropriate. We have a clear budget line which was about $25 per each blood donation. With the support of WHO, we have a clinical guidance on the use of blood for optimal use of blood products, which are an important factor in universal access to blood products. Togo is calling for the strengthening of governance, infrastructure, human resources, for the implementation of priority actions identified in the framework, and we support the proposed actions therein. Thank you.
Thank you very much, Chairman, for the opportunity to respond to the framework from the Cabo Verde's position. We'd like to thank the Zambian people and their government for the opportunity. I am as daughter of Zambia, so I feel very much at home. Cabo Verde has several specific programs such as legislative schemes which aim to increase regulation of the blood-related product sector. And we have 6 blood banks. We have various health points or clinics which ensure that everyone has access across the country to these products. The state is a major funder of these initiatives in Cabo Verde. Donation of blood is non-remunerated and voluntary. Last year, 80% was spontaneous and 11% was done by relatives. Cabo Verde achieved 7 donations per 1,000 inhabitants last year, and we have various campaigns such as of donors, and many people in civil society participated. And when it comes to quality and safety, we ensure that 100% of processing of the donations is done. And Cabo Verde also has guidelines, donations of blood. Workers are well in the know regarding the practices in the clinics. And in the future, Cabo Verde is going to create national Transplant and Transfusion Institute. This will only strengthen the sector. Despite the progress, challenges continue, such as ensuring that donors are regular and the transporting of blood samples and across our different islands. Cabo Verde reaffirms its commitment to achieving access to safe, affordable, and effective blood products. Thank you very much. We support.
Thank you. Ethiopia followed by Gabon.
Thank you, Honorable Chairperson. Ethiopia thanks the Secretariat and welcomes this comprehensive framework to advance universal access to safe, effective, and quality-assured blood products in the region. Ethiopia has established the Ethiopian Blood and Tissue Bank Services as the national authority under the Ministry of Health and is finalizing the national blood policy and legislation. In the last 10 years, blood collection has dramatically increased from 25,000 to 420,000 units annually, with nearly all donations now voluntary and non-remunerated. The number of blood banks has also doubled. For quality and safety, we have adopted the national standards and standard operating procedures in line with WHO guidance, automated testing and expanded blood safety information systems, and core government funding is also in place, and transfusions are provided to patients free of charge. Despite the significant achievements, there are gaps in having a full hemovigilance systems and nationwide digitalization. Sustainable financing also remains a challenge. We call on WHO and other partners to collaborate on the following priorities: capacity building in safety, inspection, and quality assurance, expansion of a comprehensive nationwide hemovigilance system, strengthening digital traceability for all donations, cultivating a regular donor base, investing in infrastructure, and improving emergency preparedness, particularly in underserved regions. Ethiopia supports the adoption of the proposed framework and looks forward to its effective implementation. I thank you.
Gabon followed by Niger.
Merci, Monsieur le Président.
Thank you, Chairperson. Allow me, on behalf of the Ministry of Health of Gabon, to read out the statement from Gabon. Chairperson, Ministers of Health, firstly, on behalf of His Excellency, the President of the Republic, Head of State of Government of the Republic of Gabon, our sincere gratitude to the Zambian authorities and in particular the President of the Republic of Zambia for the warm welcome and the exemplary organization of this session. We would like to laud the WHO African region to their work they've been doing on strengthening health systems on the continent. I would like to thank all the previous speakers for the good quality of their interventions to build a more resilient and equitable Africa facing health challenges. Regarding access to universal access to safe, effective, and quality-assured blood products, Gabon supports the 2026-2030 framework. It is a roadmap to strengthen blood safety in our region. In this regard, Gabon has engaged in several structural reforms. The National Blood Transfusion Center has been strengthened institutionally and technically. We have a policy, we have professionalization of teams and the modernization of infrastructure. This center has been renovated and we have procured new plasma and other products. We have put in place a secure cold chain system. Over 120 agents have been trained on blood safety and vigilance, hemovigilance. We have an increased number of blood donations being collected, and we have renewed certification. We have also been rolling out transfusion centers in Gabon to ensure the services are close to the population. Community mobilization and campaigns with the support of the local authorities have been conducted. All these efforts demonstrate Gabon's we are convinced that kindly conclude.
Merci, Monsieur le Président.
Thank you, Chairperson, honorable ministers, distinguished delegates in numerous countries. The demand exceeds supply, and blood transfusion services are faced with challenges consisting of providing adequate blood products while ensuring that they are quality assured and effective in the area of public health. In my country, we look for voluntary and non-remunerated blood donations, and we're not able to reach self-sufficiency. And that is why we go to families requesting for donations. Efforts need to be deployed, and we need to raise awareness on volunteer donations. In 2022, the National Blood Transfusion Center got support to strengthen the capacities of regional and national agents. We have the institutionalization of the World Blood Donor Day and the support for the preparation of blood products. We had an increase of blood donors, and Niger adopted its national blood policy, and the objective is to care for patients who require blood products. A national blood safety product spanning 2022 to 2026 has been developed, but despite the significant efforts, there's several challenges, which include lack of regulation, lack of technical platforms in the devolved blood transfusion centers, and then a lack of research capacities among the personnel. We want to have universal access to safe, effective, and quality assured blood products in the world, Africa, in the WHO African region through their framework. We are requesting the WHO and partners for financial support to ensure that the country attains its objectives. Thank you.
Zambia followed by Eswatini.
Thank you, Honorable Chair. Eswatini, like other countries in the African region, are facing a high demand of blood and blood products, mostly due to high prevalence of life-threatening conditions, such as postpartum hemorrhage, sickle cell anemia, chronic diseases, and trauma. While WHO recommends a minimum of 10 blood donations per 1,000 people, most of our countries fall short of this standard. Some of the challenges in the access to safe, effective, and quality assured blood and blood products include insufficient skills and workforce, funding limitations, poor regulatory oversight, and inadequate data information management systems for blood safety. Eswatini has established the National Blood Transfusion Service Department to provide accessible, safe, and quality assured blood and blood products. Following a drastic decline in the number of blood units collected during COVID-19, the collection has rebounded. However, the demand for blood continues to increase, thus making it difficult to satisfy the demand. In order to improve the blood collection, the ministry has established partnerships with entities such as Bapalali Eswatini Red Cross, who are engaging in public awareness about the importance of blood in life-saving circumstances and addressing issues regarding cultural beliefs and misconceptions on receiving and donating blood. Through this partnership, Red Cross has been impactful in increasing the number of blood donors. Chairperson Eswatini appreciates and endorses the framework that has been drafted and is in agreement with the priorities highlighted in the document. I thank you.
Eswatini?
Yes.
DRC. This what is. DRC, those of Kenya. DRC and Kenya. DRC present. Kenya. Kenya followed by Mali.
Thank you, Chair. As we are taking the floor for the first time, Kenya takes this opportunity to congratulate you on your appointment and also take the opportunity to congratulate and reaffirm our support to the regional director in advancing the health agenda for the continent. Kenya endorses the World Health Assembly resolution advancing universal access to safe, effective, and quality-assured blood products as part of the universal health coverage agenda under the Taifa Care. Blood transfusion plays a vital role in saving lives and enhancing health outcomes for patients in need of blood and blood components. Kenya is implementing strategic objectives outlined in the World Health WHO Africa Regions 2026-2030 framework and is in the process of developing a governance framework supported by policies and legislation for managing and regulating blood transfusion sector. Consequently, Kenya has established and continues to strengthen a nationally well-coordinated blood transfusion ecosystem and is on track to meet the WHO targeted milestones by 2030. The adopted hub and spoke approach to the management of blood transfusion services consisting regional satellite blood centers has further enhanced safety access to blood transfusion across the country. Additionally, Kenya has increased equipment for blood component storage and preparation in blood establishment, reaching 70% conversion of whole blood collected into various blood components. The country is leveraging technology through homegrown track and trace blood banking information management system to enhance visibility of blood products and improve data quality. Kenya is also implementing strategies to in its national vigilance system. Chair, to advance universal access to safe, effective and quality blood products in the Africa region, Kenya requests the WHO to mobilize resources to support member states in technical assistance, capacity building and development of policies and regulatory framework. Kenya is committed to translating the WHO framework into action to ensure increased access to safe, effective, quality assured blood products. Asante sana.
Asante sana. Mali followed by Mauritania.
Merci, Monsieur le Président.
Thank you, Chair. On behalf of the Minister of Social Development, Mali congratulates the Secretariat for their excellent report. Blood transfusion is an essential pillar, and it's particularly important for the most vulnerable amongst us. Mali thinks that the RC 75 is an opportunity for us to increase our commitment to universal access to safe blood products. Mali has adopted a strong legal framework with political commitment and has implemented hemovigilance structures in hospitals. National transfusion services are making efforts, but significant challenges persist, such as stockouts, which are frequent, and a low rate of participation by non-remunerated blood donors. So what we would like to do is to increase governance, to modernize our infrastructure, to guarantee sustainable supply, and decentralize our blood transfusion services to reach the whole country. Mali is calling for technical and financial support and more of it from our partners. We'd like to invest in our transfusion services because this is an investment in the lives of thousands of women and children who depend on these services. Together, let us make progress to make this dream a reality. Mali will accept this framework. Thank you.
Merci, Monsieur le Président.
Thank you, Chair. Mauritania thanks and congratulates the Secretariat for their excellent work on the RC75 document. And in this framework, Mauritania has made substantial progress. As you know, Chair, universal access to safe, effective, and quality-assured blood products is an essential part of any country's health systems. In this way, we need to ensure that we continue progress because last year, Mauritania benefited from technical and financial support of the WHO to implement the strategic national plan. We also received funding from AFD via a project. And in terms of achievements, supply depends on availability across our national territory. This is why we've aimed at building capacity of our services across the country and extending the blood transfusion network in recent years has allowed us to increase availability of blood products in hospitals, particularly in Nouakchott, our capital. Our country has a national transfusion center where we collect blood, and we have increased our amount of blood donated per 1,000 inhabitants. And we are continuing this upward trend. The national transfusion effort will produce 40% of our country's needs, but we want to increase this. We have implemented further structures to increase the amount of blood that we receive from donors. We want to ensure that each hospital has a blood bank. We have around 14 blood banks so far that are collecting blood. And when it comes to safety of transfusion, we have adopted a policy on the quality of blood products. The goal is to improve safety and the quality. We've also invested in training healthcare workers on operational standard operating procedures. This includes selecting the right donors, and we also look at how to store the blood products correctly. And in recent years, we have benefited from WHO's support to develop national guidelines and directives for blood products. And these directives have helped us promote the safe use of blood products to prevent unsafe blood transfusions. Clinicians and healthcare workers have been trained by the National Blood Transfusion Center. Thank you.
Thank you. Colleagues, we have to manage time. I'm remaining with about 5. South Sudan, Senegal, Central African Republic, Mauritius, Uganda, Zimbabwe, Gambia, and Rwanda. And after this, we close. We have to proceed to another session. What one is that? We run it? Huh? Burkina Faso. Who else? Last. Burkina Faso. Okay. One of us will be the last. Thank you. And I have South Sudan, followed by Senegal.
Thank you, Chair, for giving South Sudan the floor. I'm presenting our statement on behalf of our minister, who is attending to another meeting. South Sudan thanks WHO Afro for presenting excellent framework to advance universal access to safe, effective, and quality assured blood products in the WHO Africa region. This will help address blood safety situation in the continent in general and South Sudan in particular, where there are a lot of challenges such as major gaps in coverage and quality of blood services, reliance on family replacement donor instead of, and there is limited voluntary blood donation. Annual collection is far below the required needs. High prevalence of transmission transmissible infections, infrastructure challenges, human resource shortages, absence of updated national blood policy legislation, and hemovigilance system. This framework has come at an opportune time, at a time when efforts are being gathered by Ministry of Health and WHO through the health system strengthening component of health sector transformation project towards developing national blood transfusion strategic and operational plan, updating guidelines, SOPs, and procurement frameworks, and other activities. We have key priorities for South Sudan, such as transition from family replacement donors to voluntary, non-remunerated blood donor, establish a national coordinated blood service underpinned by policy, legislation, and quality management, among other things. We appeal for technical support to accelerate reforms, and we encourage regional solidarity and knowledge sharing. We affirm our commitment. Safe blood is not a privilege, it is a precious resource and life-saving right. South Sudan stands ready to work with WHO and regional partners to make this a reality. Thank you.
Senegal, followed by Central African Republic.
Thank you, Mr. Chair. Ladies and gentlemen, ministers, distinguished delegates, Senegal welcomes the work done and congratulates the Secretariat for this report and the framework on advancing universal access to safe, effective and quality assured blood products in the WHO African region 2026-2030. And in Senegal, we've noticed that challenges across our region are serious. We need to ensure that political commitment remains high because we have to improve legislative frameworks. There's a lack of funding, and this has made access to blood products insufficient. We've also seen issues such as unsafe transfusions, incorrect clinical procedures, and all of this weakens the system of collecting blood donations. Therefore, Senegal has a national health development program, and we've included in it increasing the availability of blood and blood products. This is a priority intervention for us. It feeds into developing our guidelines, such as increasing how we promote blood donations. We also want to ensure that we incentivize people and donors to be loyal. We also want to improve screening for TTIs. We also focus on various activities such as quality assurance, implementing a national digital system is underway. This ensures that healthcare workers will have access to data on an easy access basis. Also, Senegal has implemented a law and it has been enacted. We want to ensure that we increase equality and equity regarding blood products and transfusions so that any person can have access without discrimination. We invite member states to adopt this framework and we recommit ourselves to achieving safe, effective and quality assured blood products in the WHO African region. Thank you very much, Mr. Chair.
Central Africa, followed by Mauritius.
Thank you, Mr. Chair. The Central African Republic congratulates the Secretariat
qui offre des orientations stratégiques claires afin de favoriser l'accès universel à des produits sûrs, efficaces.
to advancing universal access to safe, effective and quality assured blood products in the WHO African region. This strategic framework deals with several essential issues for our country, such as governance and good governance and management, also equipment and increasing our capacity to collect blood, as well as sustainable funding and human resources. We welcome efforts and progress made in our region on the topic of blood and blood products, including the safety of transfusions. The CAR is committed to increasing the number of donors that we have when it comes to VNRBDs. Similarly, we want to increase the logistical capacity of our services, our blood transfusion services in all institutions, healthcare institutions. I think this is indispensable because it'll help us achieve the required number of donations per 1,000 inhabitants. We have a national strategy and its goal is to create synergies with partners. In this way, it'll be more effective and have a high impact. However, the CAR still faces severe challenges, particularly when it comes to issues such as access. Unfortunately, supply is still lacking. The CAR reaffirms its support for the framework and we encourage member states to adopt it. Thank you, Mr. Chair.
Thank you, Chairperson. Mauritius has a centralized blood transfusion service, namely the National Blood Transfusion Service. Blood donation activities carried out throughout the country, but testing, processing, storage, and distribution is done centrally. At the hospital level, blood banks maintain a blood stock for patients. The NBTS strives to provide timely and in adequate quantity the safest blood and blood products to patients. The activities of the NBTS includes the motivation, recruitment, and selection of safe blood donors, blood collection procedures, preparation of blood components for testing, grouping, antibody screening, and transfusion transmitted infections such as HIV, HBV, HCV, syphilis, storage and distribution to public and private health institutions for patient use. In line with the WHO framework for universal access to safe, effective, and quality assured blood and blood products, Mauritius has taken appropriate measures to implement the framework. The national blood policy that addresses all the key processes of the blood include blood collection, preparation of blood components, testing for transfusion transmitted infections mentioned above, storage and distribution to patients of public and private institutions. The National Blood Transfusion Service works in collaboration with various NGOs, socio-cultural groups, educational institutions, companies, and enterprises and community at large to create awareness on the importance of blood collection, donation, and organizing blood donation activity throughout the country. There has been a constant increase in the number of blood units collected, and the number of voluntary donors present stands at around 90%. However, Mauritius faces a series of problems such as, although there is a national blood policy in Mauritius, there are no regulations and defined governance structure or standards currently in place to regulate the blood sector. Aging population and high prevalence of chronic diseases such as diabetes, cardiovascular disease, and cancer impacts on blood donation and makes it challenging to meet the rising demand. Plasma production in Mauritius is safe, currently in surplus of the use. However, there is no framework agreement with any of the plasma fractionation centers for contracting out plasma for fractionation purposes, leading to wastage of this valuable national resource. Mauritius also is facing difficulties in attracting technical staff such as laboratory technicians for its laboratories. Mauritius supports the proposal. Thank you very much.
Thank you, Uganda, for advice.
Thank you so much. Uganda associates itself with the report, and Uganda's blood transfusion services has expanded in its network of regional blood banks and collection on different regional centers. Uganda has achieved 100% voluntary non-remunerated donor base, and the blood transfusion helps to address critical health needs in our country. 50% of the blood is collected and used for children in severe malaria, pregnant women, and the rest in fatal accidents that are high now in our country. Uganda has made some tremendous achievements. Its network has expansion and a national network with 8 regional well-equipped blood centers. Uganda, highly supported by the Uganda Red Cross and the World Bank, has moved a notch up in addressing the issues of blood transfusion in our country. Uganda achieved 100% from placement donation to voluntary non-remunerated blood donors. Uganda has advanced its services in regional blood banks, as I've said, well-equipped and well-transportation and transmitted to its end reach. However, there are some challenges as in supply versus demand. Limited national blood supply, especially in our rural areas, network is still an issue to be addressed. The national demand for blood consistency exceeds supply due to the blood budget constraint. Distribution and transportation and safety storing, especially in our rural remote area setup, is another challenge and a constraint to the country. Misinformation on myths about blood donation also hinders recruitment of those that would be the blood donors. Blood donors engagements, which mostly is our schools once they are closed in their holidays, is also another area that Uganda is trying to address. Generally, the position of blood transfusion in our country in Uganda has reached its excellence at performing level, as we have the Center of Excellence in the region for blood transfusion. We are happy that the blood transfusion in our country, the issues mostly that are challenges are being addressed, and we are moving on. I thank you.
Zimbabwe.
Thank you.
Gambia.
Thank you, Chairman. Zimbabwe welcomes the Secretariat's comprehensive report and the framework to advance universal access to safe, effective, and quality assured blood products in our region. We commend WHO for this timely guidance, which speaks directly to the realities of our health systems. Zimbabwe has made progress. Through the National Blood Service, we have achieved over 80% voluntary non-remunerated donations, and we ensure that every unit collected is screened for the 4 mandatory infections. These achievements reflect strong partnerships across government, civil society, and communities especially our youth. Yet the challenges remain stark. Demand continues to exceed supply, particularly during obstetric emergencies, malaria surges, and trauma cases. Most worrying, sickle cell anemia, which is highly prevalent in our region, faces a continuous and lifelong demand on our blood services. At the same time, our supply chain is fragile. Nearly all consumables, reagents, and equipment are imported, leaving us exposed to current shortages and global supply disruptions. Rural and remote communities remain the hardest to reach, while our hemovigilance and data systems require further strengthening. Chairperson, Zimbabwe believes that Africa must go beyond incremental progress. We must break the cycle of dependency and vulnerability. We call for regional collaboration to establish local and regional manufacturing of blood safety consumables, reagents, and test kits. We urge pooled procurement mechanisms that lower costs and ensure reliability. We further call for collective investment in plasma fractionation and advanced technologies so that Africa can meet more of its own needs. On sickle cell disease, we urge that the framework explicitly recognizes the unique burden it places on blood services in Africa, and that member states scale up integrated responses that link transfusion services to broader chronic disease care. Zimbabwe stands ready to champion these priorities and to work with WHO partners and fellow member states to translate this framework into bold action. Blood is not simply a product, it is life. By 2030, let us ensure that no African child, mother, or patient living with sickle cell anemia is denied that lifeline. I thank you.
Gambia, followed by Rwanda.
Thank you very much, Mr. Chair. The Gambia aligns with the framework on safe, affordable, and quality assured blood. Mr. Chair, it is no secret that the lack of safe, affordable blood in the sub-region and in the whole of Africa is responsible for the high mortality of mothers. Maternal mortality reduction is sincerely not possible without ensuring that there is safe, affordable blood in our hospitals. This framework is coming at the right time when the Gambia is developing and finalizing the national policy on blood transfusion and national strategic plan. In our collective efforts to expand our comprehensive maternal and child health services in the Gambia, the availability of blood in many of these major health facilities is critical. The blood transfusion services in the Gambia has procured a number of blood fridges for many of these major health facilities. Mr. Chair, we certainly also have to deal with the myth surrounding blood transfusion. In the Gambia, a popular myth is that blood transfusion or blood donation by men causes infertility. That is a big problem for our people. At this juncture, we certainly must thank our armed and security forces as they form the major group of voluntary donors in the country. Mr. Chair, to cap it up, the Gambia government and the World Bank is putting up a modern national blood transfusion center, the construction of which will be concluded by the end of this year. I thank the committee members that came up with this framework, which certainly will be incorporated in our blood transfusion policy and the strategic plan that we are finalizing very soon. Thank you very much.
Rwanda, and finally Burkina Faso.
Thank you, Mr. Chair. Rwanda welcomes the framework to advance universal access to safe, effective, and quality assured blood products, which offers robust guidance essential to achieving universal health coverage and closing life-threatening gaps across the continent. In line with this framework, particularly its focus on infrastructure, supply chain, innovation, and public awareness, Rwanda has made notable progress. Our National Center for Blood Transfusion, in partnership with Zipline Drone Delivery, has transformed access to blood products in remote areas. This innovation has cut delivery times from hours to minutes, reducing blood wastage by 67% and contributed to a 51% decline in maternal mortality linked to postpartum hemorrhage. We're also piloting drone delivery of routine vaccine to further advance equity and integrated service delivery. These are just a few examples of Rwanda's broader efforts to strengthen transfusion services, encompassing governance, financing, workforce development, hemovigilance, and community engagement. In this spirit, Rwanda strongly supports the swift adoption and implementation of this regional framework to advance safe, universal access to blood and blood products across Africa. Thank you.
Burkina Faso, the last.
Merci, Monsieur le Président. La délégation du
Burkina Faso. The delegation of Burkina Faso would like to congratulate the Secretary for the excellent quality of the report and commends their suggestion of coming forward with a framework to advance universal access to safe, effective and quality sure blood products to ensure that there is better access to medical products of human origin. The health sector in terms of blood and blood transfusion in Burkina Faso.
Grâce aux centres régionaux et aux banques de sang hospitalières. Le CNTS assure la collecte et la distribution du sang sur tout le territoire. Ces activités respectent les normes de bonnes pratiques transfusionnelles et s'appuient sur un cadre réglementaire solide, notamment la loi 038 votée en 2020. Au Burkina Faso, le don repose sur le bénévolat, le volontariat, l'anonymat et le non-profit. Mon pays et ses partenaires garantissent la gratuité des produits sanguins pour tous. Le CNTS, avec l'appui des associations, mobilise de plus en plus de donneurs volontaires. La qualité est assurée par des contrôles systématiques, un système d'hémovigilance, une formation spécialisée et la promotion d'un usage rationnel des produits sanguins. Malgré les efforts constants, le système transfusionnel du Burkina Faso connaît quelques défis majeurs. Ce sont les suivants: la mobilisation insuffisante en ressources financières, la disponibilité des produits sanguins spécifiques, notamment ceux de leucocytés ou phénotypés, les difficultés de rétention du personnel formé et enfin l'absence de valorisation du plasma frais produit faute d'une structure locale ou régionale de fractionnement du plasma. Face à ces défis, ma délégation souscrit à une approche holistique, intégrée dans le but de renforcer les partenariats entre les acteurs et d'assurer la résilience des systèmes de transfusion sanguine grâce à un soutien harmonisé et une collaboration durable. Nous voudrions terminer en invitant le comité régional à adopter les mesures proposées et dans ce document cadre qui est proposé par l'OMS. Je vous remercie.
Thank you, delegates. Distinguished delegates, when we close the list, you have to bear with us. We have to manage time. We haven't got the leisure of time. We've got only today, tomorrow to finish a lot of business. So when a chance comes, put up your cards. When we close, we close. It's not deliberate, but we have to manage time. Thank you. I now invite the representatives of the member states from other regions, UN agencies, and other IGOs to raise their nameplates I remind you that you have 2 minutes. Mr. Card. Thank you for your valuable comments. I understand that several non-state actors had actually requested legal statements on this agenda. I don't know what has happened, but we can proceed. Thank you. I see no more requests from the floor. Sorry? Oh, I'm sorry. I understand that several non-state actors have requested to deliver statements on the agenda item, and they are now invited to do so. 1 minute given. We have Federation of African Medical Students Association. We have World Federation of Societies and Anesthesiologists, International Federation of Medical Students Association. Those three, you have a minute each. Please have the floor in that order.
Distinguished delegates, we call for a renewed commitment to advancing
International Federation of
100% screening of all blood donations for relevant infections, 100% screening of all blood donations for relevant infections using WHO recommended testing protocols and establish robust quality assurance systems by 2027. Recognize and support youth-led blood donation drives through the provision of technical capacity and financial support by member states. Thank you.
World Federation of Societies, Anesthesiologists.
The World Federation of Societies of Anesthesiologists welcomes the adoption of the framework to advance universal access to safe, effective, and quality-assured blood products in the WHO African region. We commend the Regional Committee's commitment to strengthening blood systems as a pillar of universal health coverage and patient safety. We urge member states to recognize that ensuring access to safe blood is not solely about increasing blood donations or transfusion services, but requires an integrated, holistic approach centered on patient blood management systems. PBM optimizes the clinical use of blood by addressing anemia, reducing loss, and improving transfusion decision-making. And integrating PBM into national blood strategies will help countries reduce demand for avoidable and costly transfusions. We encourage member states to embed PBM within their national health plans and include PBM indicators in health information systems. Thank you.
On this list to the last, International Federation of Medical Students Association. You have the floor.
Monsieur le Président du jury.
Mr. Chair, distinguished delegates, every day lives are being lost in Africa because of women, we're losing women, children, and so on because of processes. The challenge for us in WHO Afro and as well as our member states to come up with national services that are of assured quality. We need to look at investments, make sure that we have good investment in this area. We need to also to have more campaigns with the community and also to invest in research and development and laboratory capacities. Finally, I think because of geographical regions, we need to be cognizant of this. We need to look at the young people and make sure that there is awareness raising for them, because this is life saving and this is not a right, a privilege, but a right. Thank you.
Thank you. I see no more requests from the floor. Are there any comments from the Secretariat? Secretariat of the floor.
Thank you, Chair. Good morning, distinguished delegates, honorable ministers. We acknowledge the interventions and comments made by the 27 member states who took the floor, in addition, and also the 3 non-state actors who we are seeing the acknowledgement that the advances that we have recognized, as well as the challenges that remain, are recognized also by the member state level. And therefore, we will be moving forward with the adoption, I hope, of this endorsement of the framework, and we stand ready to provide the technical support that is needed. There's a specific request by the Honorable Delegate from Zimbabwe, the Honorable Minister, about recognizing sickle cell as a special area of need. And I think we'll emphasize that in the revision of the report, so that, of the framework, so that that is taken on board as a recommendation that is coming from this assembly. And I think with that, we are ready to move forward. Thank you very much.
Thank you. Secretariat has taken note of the comments raised. Is the regional committee ready to adopt the priority interventions and the actions proposed in the document AFR/RC 75/7 titled Framework to Advance Universal Access to safe, effective, and quality assured blood products in WHO African Region 2026? An objection? I see no objection. It is decided. Delegates, let us now continue with an agenda item, Pillar 4. Agenda item 14, Program Budget, which is contained in document AFR/RC 75/11. I invite Dr. Francisco Katanyama, Coordinator for Planning, Budgeting, Monitoring and Evaluation, to present the document. Over to you, Dr. Katanyama. You have 5 minutes.
Chair, Excellencies, ladies and gentlemen. It is more than an honor and a privilege to address this in assembly. Okay, thanks. Can we have the slide also, please? Okay, good. Excellencies, distinguished delegates, ladies and gentlemen, all protocols observed. It is both an honor and a privilege to address this esteemed assembly. Allow me at the outset to recall that 3 months ago, during the World Health Assembly, member states endorsed the program budget for the next biennium. This budget is not merely a financial instrument, it is above all a policy document, capturing the collective priorities and aspirations of member states. Yesterday, the Director General provided an overview of the organization's efforts to advance shared goals, highlighting the dedication across the institution despite persistent resource constraints. Similarly, the regional director reported on the tangible achievements achieved thus far, underscoring both progress and the challenges that remain. Looking ahead with resolve, the critical question: how do we translate the program budget into effective action? More specifically, how do we ensure a seamless continuum from priority setting to planning, to funding, and ultimately to implementation? How do we guarantee that what is prioritized is what is planned, and what is planned receives the funding required, and what is prioritized, planned, and funded is indeed implemented with rigor and accountability? The purpose of this presentation is to seek your valued guidance on 4 proposed areas designed to strengthen collective ability to achieve results that will positively impact the health and well-being of our people and the resilience of our health systems. Next slide, please. Allow me to briefly highlight 3 key features of the program budget. First, the overall budget has been reduced. Globally, WHO faces ongoing fiscal constraints, a situation projected to continue for the next 2 years. The base budget is reduced by 21% from 5.3 billion to 4.2 billion. For the African region, our base budget envelope is decreased by 14% or 188 million from 1.33 billion to 1.14 billion. Second, despite these reductions, the flexible funding envelope for our region remains stable over the next biennium, thanks to the consistent advocacy of member states from the African region. Third, with an estimated 60% funding gap, the regional director has committed 70% of flexible funds directly to countries, ensuring that resources reach frontline programs. We will continue to use flexible funds strategically and smartly, moving beyond business as usual so that every dollar delivers maximum impact. To bridge the remaining gap, we are strengthening partnerships with both traditional and non-traditional allies and will continue to do so. Next slide, please. Distinguished delegates, to effectively deliver results, the Secretariat seeks your guidance in 4 key areas. Next, please. First, enhancing engagements such as in joint planning, monitoring, and reporting. Through this, your active engagement in prioritization, budgeting, and review ensures that we prioritize, plan, fund, and implement remains aligned, avoiding any disconnect and increasing our collective impact on people's health and health systems. Next, please. Second, advancing WHO's role in the national health architecture. By fully integrating technical support into national policies and strategies, we build resilience and national ownership. This allows the lessons we learn and the capacities we develop to serve as a foundation for scaling up and institutionalizing health gains. Next, please. Next slide, please. Third, sustaining political and financial advocacy is crucial. Our member states are pivotal in championing this regional strategy. And fourth, finally, we invite your continued support for WHO country offices, as exemplified by His Excellency President Hakainde Hichilema's provision of new funds for WHO country office. Such support is essential. Thank you so much.
Thank you very much. I now open the floor to member states' interventions. Make sure that you put up your tag because we have to manage time. Secretary, take the names so that we can close the list. As we are doing that, Togo, followed by Seychelles. Togo, you have the floor, please.
Merci, Monsieur le Président. Monsieur le Président du Comité régional, Monsieur le Directeur régional, le Togo remercie le Secrétariat pour le document sur le budget programme 2026-2027 avec l'établissement des priorités à l'exécution. Le Togo félicite le Secrétariat pour l'orientation stratégique et opérationnelle exprimée par ce budget programme au titre du 14e programme général de travail de l'OMS.
Le Togo salue la réalisation de cet exercice qui marque un tournant vers une prestation axée sur les résultats, car mettant l'accent sur des résultats mesurables au niveau des pays conformément à la vision audacieuse du nouveau directeur régional qui est de construire ensemble une Afrique en meilleure santé. Le Togo s'aligne sur ce budget programme qui promeut la couverture sanitaire universelle, l'équité et la préparation aux situations d'urgence grâce à une transformation centrée sur les soins de santé primaires. Le Togo se réjouit que malgré une réduction globale de 21% du budget de base de l'OMS, notre région conserve la part mondiale la plus importante, soit 24% de ses ressources, ce qui permet d'assurer la continuité des prestations de services de première ligne dans les 47 pays de la région. Le Togo adhère aux valeurs d'équité, de souveraineté, de résilience sur lesquelles se sont basés les budgets programmes et à l'appel à un pacte renouvelé entre le secrétariat et les États membres. Un pacte qui transforme l'engagement en capacité et la vision en résultat. Le Togo invite les États membres à repenser nos systèmes de santé, à renforcer l'appropriation africaine et à tracer ensemble des voies durables. Je vous remercie, Monsieur le Président.
Merci au Togo. La Tanzanie et le Sénégal se préparent.
Yeah, thank you very much, Chair. Since 1999, Tanzania has adopted a sector-wide approach, which means SWAP, whereby the developer partners together, the government, we do the planning together and mobilization of the resources together. But at the same time, we have pulled the resource through the Health Basket Fund, whereby 90% of those resources, they go to the primary health care to strengthen the provision of the service. Recent Tanzania has been affected by the USG funding cuts for HIV/AIDS, malaria, TB, and neglected tropical diseases. In response to this, the government conducted a rapid analysis and instituted a short-term, mid-term, and long-term measures. In the short-term measures, between February to June 2025, the government has disbursed over $56 million to procure essential commodities for HIV, TB, malaria, and other health products. But in the medium term, in this financial year 2025-2026, over $65 million has been allocated, but together integration of the vertical programs into routine services. And the long-term measures, we are revitalizing and establishing pharmaceutical industries, strengthening domestic manufacturing, enhancing the AIDS Trust Fund, whereby we are earmarked tasks, 70% goes to the AIDS funds. But at the same time, additionally, we are empowering the postal corporation of sample transportation, ensuring sufficient personnel for sustainable service delivery. Chairperson, Tanzania remains committed to mobilizing domestic resources, strengthening partnership, and safeguard the resilience of our health system to sustain progress in combating HIV, AIDS, malaria, tuberculosis, and other essential health services. Thank you.
Merci la Tanzanie, au Sénégal et la Namibie se préparent.
Je vous remercie, Madame la Présidente. Madame la Présidente, Monsieur le Directeur régional, Mesdames, Messieurs les ministres, distingués délégués, le Sénégal félicite l'ensemble des États membres et le secrétariat pour avoir mené à bien l'exercice de hiérarchisation des priorités, comme précédemment demandé par le Conseil exécutif. En outre, le Sénégal félicite le directeur régional pour la mise en œuvre des mesures de rationalisation organisationnelle pour une meilleure efficience. En effet, la réaffectation des ressources vise à protéger l'impact au niveau du pays et reflète le principe du pays d'abord, en plus d'assurer le maintien des fonctions essentielles de notre organisation. Il est maintenant crucial de faire un suivi rigoureux de la mise en œuvre et de veiller à une bonne gouvernance. Dans cette période difficile que traverse l'Organisation mondiale de la santé, le Sénégal encourage le secrétariat et le renouvelle sa ferme volonté de contribuer au financement durable de l'organisation. À ce titre, le Sénégal réaffirme son engagement à augmenter de 20% ses contributions obligatoires. De plus, le Sénégal va matérialiser sa promesse de contribuer au cycle de l'investissement de l'OMS sur la période du 14e programme général de travail. Aussi, le Sénégal exprime son souhait de voir chaque État membre de la région Afrique contribuer à ce cycle d'investissement dans un élan de solidarité. Par ailleurs, le Sénégal invite le bureau régional à renforcer son rôle de facilitateur à travers notamment ses fonctions relatives aux plateformes des données, la coordination des urgences, la supervision technique, la résilience des systèmes de santé face aux conséquences du changement climatique et le renforcement des soins de santé primaires, conformément à la vision du nouveau directeur régional qui est de construire ensemble une Afrique en meilleure santé. S'agissant du personnel, en raison de l'incertitude liée à leur redéploiement et au renouvellement de leur contrat, le Sénégal encourage le directeur régional à poursuivre sa démarche de communication transparente. Enfin, auprès de tous les États membres, le Sénégal réitère sa solidarité au secrétariat et lui renouvelle son engagement sans faille à l'accompagner pour une mise en œuvre optimale du budget programme 2026-2027. Je vous remercie de votre bien aimable attention.
Merci au Sénégal. Namibie prend la parole et après, ce sera la Gambie. Et avant ça, j'aimerais dire que tous ceux qui veulent parler peuvent soulever maintenant. On va arrêter la liste. Merci.
Thank you, Madam Chair. Thank you for the opportunity and good morning, everybody. Namibia would like also to echo our appreciation to the Regional Director, to the Secretariat for formulating and presenting the proposed budget for the biennial period of 2026 to 2027. We appreciate very much the fact that the proposed budget has been undertaken and has been formulated through an inclusive approach, through a participatory approach, and therefore that aligns very well with our aspirations as the region. So we welcome, Madam Chair, the fact that the proposed budget to a great extent is aligned to the core priorities that are central to the African Health Agenda. That is the alignment to the 13th General Program of Work of the African Regional Priorities, the strengthening of primary health care and the resources that are put at our disposal through this budget to support the member states to strengthen primary health care, advancing universal health coverage, and building resilient health systems. Namibia also notes, Madam Chair, that and appreciates the fact that this budget puts a strong focus on health emergency preparedness and response, and the growing burden of non-communicable diseases and the need to address climate-related health risks. These priorities, Madam Chair, resonates very well and deeply with our national context and our long-term health strategic objectives at the country level. However, we note very well that coming up with a budget of this magnitude and nature against the backdrop of declining financial resources and ability to fund globally, it is a tight balancing act, Madam Chair. We remain concerned that the limited fiscal space that continue to confront many member states, including Namibia, constitute a binding constraint that would weigh on our ability to fully implement the agreed health priorities at the scale and the scope that is necessary for us to achieve universal health coverage and to achieve the global agenda for development, the sustainable development goals. Therefore, Madam Chair, we continue to underscore the critical importance of adequate, predictable, and innovative financing for WHO programs. We continue to advocate for predictable financing for the African region programs in particular. This includes increased assessed contributions when it comes, if push comes to shove, and the strengthened partner support to ensure the successful implementation of the program at hand. So, Madam Chairperson, with this input, Namibia fully supports the budget at hand and it has our approval. Thank you, Madam Chair.
Merci à la Namibie. Donc, je vais lire la liste encore pour voir ceux qui ne sont pas enregistrés, qui veulent bien lever la plaque. C'est-à-dire, on va arrêter. Nous avons la Gambie, la République centrafricaine, l'Éthiopie, le Congo, Capo Verde, la Mauritanie, le Ghana, les Seychelles, Sao Tomé et Principe et les îles Maurice. Après ça, on va arrêter la liste. Donc, la Gambie a la parole et la République centrafricaine se prépare. Merci.
Thank you very much, Madam Chair. We thank the WHO team for putting forward this program budget for 2026-2027. We acknowledge the shift in the budgeting process, directing up to 70% to the countries as flexible funds. Madam Chair, this is very important. The WHO, we all recognize, is a technical wing for health support. However, the financial support to countries is equally important. Madam Chair, the availability of these funds should be made known to the countries. Too often than not, many of the countries do not actually know the total volume of these funds. Too often than not, our program areas are informed at certain points in time from the country offices to say, we have these funds, send applications. That is very difficult for programming, that is very difficult for planning. So we want the funds to be known to the countries and for predictability and also for alignment so that we reduce duplication. Too often than not, these funds are not disbursed in good time, and the countries would have gone ahead with alternative plans. And when these funds come, they become duplicated. And that is not sustainable, and that is not value for money at this time that funds are scarce. At country levels, the Gambia is mobilizing domestic resources. This is exemplified by the fact that as a country, we are doing health sector expansion, and a lot of those funds also come from government. Our government has recently constructed 6 brand new state-of-the-art health centers with the support of the National Assembly. Internal resource mobilization is key. However, this is not possible without carrying internal players along, including the Ministry of Finance. But with increased confidence in the Ministry of Health, the Gambia Ministry of Health is able to gather a lot of funds for implementation and complementing partner support. Very key in the advocacy is the National Assembly. We are happy to announce here that on our delegation here, we have the chairman of the National Assembly Select Committee for Health, and also our majority leader, deputy majority leader, is part of our delegation here. I think there cannot be any advocacy better than that, because they're hearing what we are saying, and I believe that when we go back, they will advocate for more resources for the Ministry of Health and more support. The community ambulances that we mentioned about yesterday, they were all procured from the GLF, that's the government local funds. So with local advocacy and bringing on board other partners, business partners, we believe this is achievable. Thank you very much.
Merci à la Gambie, la République centrafricaine et l'Éthiopie se préparent.
Merci, Madame la Présidente. La République centrafricaine félicite le secrétariat pour le travail abattu et remercie le directeur régional pour avoir autorisé la présentation du budget programme 2026-2027 qui s'inscrit dans le 14e programme général de travail de l'OMS. Ce budget programme traduit la vision collective, celle de construire ensemble une Afrique en meilleure santé. Nous prenons acte des contraintes financières majeures qui ont conduit à la réduction de 21% de budget de l'OMS et saluons les efforts entrepris pour préserver les fonctions essentielles de santé publique dans notre région, notamment la vaccination, la santé maternelle infantile ainsi que la préparation et la riposte aux urgences sanitaires. Pour notre pays, la République centrafricaine, où la fragilité du système de santé demeure un défi, l'approche proposée fondée sur les soins de santé primaire, l'équité et la résilience, la couverture sanitaire universelle correspond à nos priorités nationales contenues dans le plan national de développement sanitaire 3e génération. La préservation des financements flexibles qui permettent d'assurer la continuité des services de première ligne est très appréciée. Nous encourageons la poursuite de leur allocation stratégique. Nous souscrivons à l'appel à un pacte renouvelé entre l'OMS et les États membres et réaffirmons notre engagement à jouer un rôle à travers l'alignement de nos plans nationaux sur les priorités régionales, la participation active aux mécanismes de planification et de redevabilité et la mobilisation des soutiens politiques pour préserver la solidarité régionale. La République centrafricaine soutient l'approche axée sur les résultats pour la planification du personnel et insiste sur la nécessité d'affecter le personnel dans les bureaux pays en fonction des besoins des pays et de prêter plus d'attention aux conditions de travail de ces bureaux. La République centrafricaine exhorte à une mise en œuvre efficace et équitable de ce budget programme afin que chaque pays, y compris les plus vulnérables, bénéficie d'un accompagnement adapté pour réduire les inégalités et renforcer durablement la résilience du système de santé. Je vous remercie.
Merci à la République centrafricaine. L'Éthiopie a la parole et le Congo se prépare.
Thank you, Madam Chair. Ethiopia commends the Secretariat for presenting a focused and realistic program budget for the years from 2026 to 2027. We would note that it aligned with general program of work, building a healthier Africa together. We welcome the strong emphasis on equity, primary health care, and country-level results, as well as the transparent consultative processes which we engaged also. Chair, we recognize that these are challenging times and they require careful considerations and hard decisions. We would like to take this opportunity to sincerely thank the regional office and the staff for dedication and ongoing support to countries and focusing the country programs at large. We also acknowledge the African region's success in safeguarding flexible fundings and the commendable progress made in mobilizing additional resources to fill the urgent gaps. These steps demonstrate efforts to sustain the hard-won gains in the path towards institutional resilience. The political and financial solidarity are required more than ever. Ethiopia has long supported efforts for the sustainability, predictability, and flexibly financed WHO in all for us and contributed to the WHO current investment round. We have taken note of the call to action, including the efficiency and the cost containment measures, and we ask the Secretariat, especially on the decisions and the fund disbursement efficiency as well. We would like to emphasize the importance of continued resource mobilization and the joint review to ensure effective implementation of GPW14 and member states' priorities. We will continue to integrate WHO support into our national health strategies and align efforts with mutual accountability. Finally, Ethiopia reaffirms its strong commitment to regional solidarity and a stronger WHO that is able to support impact in countries. Together, let us ensure WHO at the resource and the flexibility it needs to protect lives, advance equity, and drive universal health coverage in Africa and beyond. Thank you.
Merci à l'Éthiopie. Le Congo a la parole et le Cap-Vert se prépare. Merci.
Merci beaucoup, Madame la Présidente. La République du Congo remercie le secrétariat pour la présentation du budget programme 2026-2027 et salue son orientation vers les soins de santé primaire, la couverture sanitaire universelle, l'équité et la préparation aux urgences. Nous notons avec préoccupation la réduction du budget de base, mais nous apprécions les efforts du bureau régional pour préserver les fonctions essentielles et maintenir la plus grande part du fonds flexible, ce qui garantit la continuité de l'appui au pays. Pour la République du Congo, ce budget est un appel à
is an appeal to strengthen our commitment through joint planning, accountability, and if possible, cost sharing. We note the continuation of efforts of mobilizing resources and emphasize on the importance of aligning the support of the WHO with our national priorities, especially primary health care, maternal and infant health, vaccination, and preparation for emergencies. To conclude, Madam Chair, the Congo would like to thank and is attached to regional solidarity, national ownership, and rigorous management to build a healthier Africa. Thank you very much. Thank you, Congo. Cabo Verde, you have the floor, followed by Mauritania.
Muito obrigado, Senhora Presidente, por nos conceder a palavra
Thank you very much for this opportunity for Cabo Verde to take part in this debate. This is agenda item number 14 on the program budget. We would like to thank the director who introduced this point, and we have taken good note of the documents that have been presented on this, particularly the progress report on the implementation of the regional strategy for the community development 2015 to 2030. Of course, we are concerned by the cut in the budget, and this means that we need to focus more on voluntary contributions from member states in a consistent manner and in a timiest manner. We are happy with the program, particularly the mapping of structures and community activities, which we are participating very actively. In terms of challenges, Cabo Verde agrees that we need to give greater priority to involving the community and in producing policies so that we can promote operationalizational measures and also mechanisms which will help us to monitor and evaluate the situation as we go along. With regard to the way forward, Cabo Verde agrees with the proposals and measures proposed for member states, particularly in terms of developing politics with a focus on primary health care, in taking care of the issue of climate change, and also to involve the community. Finally, Cabo Verde, as always, is ready and available to really commit financially to the organization and to make its contribution in terms of contributing to the achievement of our objectives in the interest of pushing forward with our agenda until 2030. Thank you very much.
Merci au Cap-Vert.
Thank you.
Merci, Madame la Présidente.
Thank you, Madam Chair. The Bureau has considered with a lot of it the multi-program document. I'd like to congratulate for the relevance and the quality of the program faced with the financial challenges marked by the review of the WHO budget by 14% of the budget 2026-2027. So this we have to change our paradigm, and Mauritania is a strategic partner to co-create solutions and share the responsibility and impact. This approach aligns with the vision of the regional director and with the orientation of the 14 WGP, which advocates for equity, resilience, and measurable results. We have to program target interventions with strong impact. That is why Mauritania, where every investment amplifies results of others. We have our priorities in the area of health, maternal health, adolescents, through the implementation of a roadmap for the acceleration of the reduction of maternal mortality, because the mortality rate justifies this emergency. We have to make target investment and digitalize efforts. The second priority concerns human resources, backbone of the health system, and the other is our national vaccination program, which is the linkage of our health system. If we have made progress, there are still many challenges to reach zero-dose children, cold chain in a difficult atmosphere. Not our fourth priority is nutrition. Malnutrition in all its forms costs about 30.5 GDP every year. We have doubled our budget for vaccination from 80 million to 87 million in 2027, with an increase of 15% per year. That's Mauritania plans to invest and to continue our partnership with active population to guarantee alignment and mutual accountability. We appeal the regional office to support us to design a strategy to mobilize innovative resources, targeting our 4 priorities to maximize the impact of our investment. Mauritania supports the adoption of the framework proposed. Thank you very much. Thank you, Mauritania. Ghana, you have the floor, followed by Seychelles.
Thank you, Mr. Chair. Ghana, thank you for the opportunity to take the floor to comment on Agenda 14, Program Budget 2026 to 2027, from prioritization to implementation. We appreciate the Secretariat's effort in preparing the program budget for 2026-2027. This budget is the first to be developed based on the 14th General Program of Work 2025 to 2028, emphasizing the advancement of health equity and the fortification of health systems resilience. Ghana commends the WHO Africa region for its bold and strategic program budget 2026 to 2027, which reflects a decisive shift towards outcome-driven delivery and country-level impact. Despite global fiscal constraints, the region's ability to safeguard core functions and preserve a flexible funding envelope of US $447 million is a testament to member states' solidarity and visionary leadership. We align fully with the regional director's call to build a healthier Africa together. Ghana remains committed to strengthening primary health care, advancing universal health coverage, and embedding WHO's technical support within our national health architecture. Ghana has noted that the region has adopted a result-based approach to workforce planning, where all country offices are required to align their staffing structures, and this may impact our future implementation. In the spirit of shared ownership, Ghana will continue to engage in joint planning, performance reviews, resource mobilization efforts, and championing regional solidarity within multilateral forums. We echo the call for political and financial solidarity and reaffirm our role as co-creators of resilient, equitable health systems. Let us seize this moment to transform challenges into opportunities and deliver lasting health outcomes for our people. We note the report and invite all member states to respond to the call for action. Thank you.
Merci, Ghana. Thank you, Ghana. Seychelles, you have the floor, followed by Sao Tome. Thank you, Madam Chair. Seychelles, we would like to express our general agreement with the program budget 2026-2027 proposed for the African region. We would like to hail the efforts to align regional priorities with measurable results and promote a bold vision based on the construction of an Africa in better health. Would like to firmly support the focus on universal health coverage, equity, and the preparation for health emergencies, areas that are essential in guaranteeing resilient health systems. Seychelles acknowledged the importance of primary health care as a bedrock to achieve these ambitious results, and underscores the importance of integrating and continuing to pay special attention to specific challenges faced by small island states. In this regard, we would like to call on the WHO to continue to focus on the following issues: capacity building of island health systems, management of non-communicable diseases, impact of climate change on health, equitable access to medications and health technologies, promotion of mental health. Moreover, we fully subscribe to the renewed pact proposed between the Secretariat and Member States, which focuses on the African ownership, resilience, and equity. This collaborative framework is necessary to transform commitments into concrete actions and build sustainable health and sovereign systems. Finally, we'd like to invite the WHO to maintain strategic focus on these priority challenges in order to help small island states to face up to their challenges and to build resilient health systems for the future. Seychelles is ready for active collaboration with the WHO in order to achieve its ambitious objectives. Thank you very much. Thank you, Seychelles. Sao Tome and Principe, you have the floor, followed by Mauritius.
Thank you very much. Although we are going through a budget, we really do appreciate the framework that was presented, where we are looking at prioritizing key operations. In Sao Tome and Principe, we know that it is important for us to look on more self-sufficient and also to promote the health of our population as a priority. It's the number of our contribution to the budget, to the health budget, shows how much we invest in health. And obviously it depends on the priorities at country level. And to this end, it is important to plan. We have managed to achieve several of our objectives. Recently, the United Nations reclassified Sao Tome and Principe as a middle-level country. We know that there isn't a direct link between socio-development and economic. We think it's very important to link health with other factors. Therefore, we do believe that we shouldn't be penalized in terms of funds that are being allocated to WHO, because otherwise we risk not consolidating and losing the gains that we have made. Therefore, we would also like to support the proposal of this document. Thank you very much, Sao Tome, and we give the floor to Mauritius, followed by Uganda.
Thank you so much, Madam Chairperson. And Uganda welcomes the 2026-27 budget report as presented, and we support it, especially its framework. And we take note of the areas that have been highlighted for our attention, mindful of the regional budget cuts and the call for action. In Uganda, in the financial 2025 and 26 budget allocation, it doubled up to 1.5 billion USD. And this was doubled because of the necessity that we needed to focus so much on our health sector, mindful that a sick nation is a country that is a failed country. We address the service, the delivery, and the works shortage and upgrade of medical infrastructure, which is our priority. This investment into the health sector underscores the government's commitment to improving access to health care and safeguarding public health through the human capital and the public health care, as have been enumerated by many speakers ahead of me. The budget allocation for this year increased budget support will support infrastructure development, especially the maternal health units at community levels, as we have a program of having health services down to the lower community from our structures, from the local people who are supposed to be the community, and we put services near to them. Strengthening emergency responsive services also, and surveillance is one of our most priority. Data surveillance, data monitoring, storage, and innovation. Laboratory development is one of the areas that Uganda is focusing on. This increase has come at a time when we are facing rising of non-communicable diseases in our country, recurring pandemics and infectious outbreaks, though they can be prevented. So our challenge is to ensure that we invest much in advocacy, awareness, and to ensure that every person is not left behind, inclusive of every stakeholder in the health care service. Transparency and accountability for value for money is another area that Uganda is looking at, and to ensure that the measurable achievements that Uganda has achieved, we continue with it. Assessment of health services by all and for all is an obligatory human right, not negotiable. Therefore, we are, as a country, focusing on more increase in the budget, and we pledge to work together with the region as far as resource mobilization is concerned. I thank you.
Merci.
Thank you, Mauritius.
The Republic of Mauritius fully endorses a transformative shift from outcome-driven delivery and country-level impact as articulated in GPW14 and the regional director's vision of building a healthier Africa together. For small island development states like Mauritius, it is comforting to witness the focus on primary healthcare, equity, and emergency preparedness. Indeed, priorities that are in alignment with our national health agenda. However, it will be a remiss to overlook the unique vulnerabilities of SIDS in terms of limited economies of scale and exacerbated climate-related health risks, which impact on the functioning of our health systems. These realities require tailored support and sustained attention. We have no doubt that WHO Afro will ensure that the specific needs of SIDS are considered in our collective progress towards achieving the GPW14. The operational workforce and realignment undertaken to safeguard essential health functions are timely whilst ensuring agility, flexibility, and responsiveness. At the same time, we are mindful that country officers must have adequate financial resources to implement catalytic actions. We also commend the region's unwavering commitment to transparency, efficiency, and institutional integrity. The $250 million in 250 days campaign is bold, timely, and imperative. The African region can count on the support of Mauritius in its endeavor. As a member state, we reaffirm our commitment to the call for action, notably cost-sharing support through in-kind contributions, evidence-based joint planning and performance dialogues to ensure alignment and accountability, financial solidarity to protect WHO's operational capacity, and strengthen delivery and impact in our joint work. As we approach the margin of the next program budget, we stand at a pivotal crossroad. We need to be bold in not only how we fund health, but in how we lead it. To conclude, we have no choice but to strive in transforming the constraints into opportunities and build resilient, inclusive health systems that will better serve the continent and its people. Together we can and we shall succeed. I thank you for your attention. Thank you.
Merci. Thank you, Mauritius. Thank you to all the distinguished delegates that took the floor. Now I'd like to invite the representatives in member states and other regions, United Nations systems and other IGOs that would like to take the floor to raise their name, please. And you're reminded that you have 2 minutes each.
Donc, je ne vois pas de plaque.
I do not see any nameplate raised.
Donc, là, on demande si le secrétariat a des observations.
If the secretariat has observations to make, they are welcome.
We would like to thank the interventions coming from the distinguished delegates and excellencies. Your guidance, we would move forward. We would like to reiterate our commitment to the principles of inclusivity, to make sure that we would consult everybody, and when during the planning process, but beyond planning, during monitoring and reporting, please continue to join us so that your priorities or changes in priorities could be reflected in the planning, funding, and at the same time the implementation. Secondly, we would like to continue working with everybody in the monitoring and of the program budget. You have defined your priorities. Now we will also be working with everybody so that we could monitor and report the progress in all these areas. Rest assured that we will all continue, the Secretariat will be better in ensuring that what you have prioritized is what is planned, is what is funded, and what is implemented. Thank you, Chair.
Merci pour votre attention.
Thank you for your attention. The Secretariat has taken due note of the suggestions put forward. We can take note of the program budget document. I do see no objections. It is so decided.
Donc, nous allons continuer directement avec le point 9 de l'ordre du jour.
We shall proceed with agenda item 9, regional strategy to strengthen rehabilitation in health systems 2025 to 2035. AFR /RC 75/6 and AFR RC 75 WP1.
Donc,
these documents will be presented by Dr. Benito Impuma, Director at Interim of the Health Promotion, Disease Prevention and Control Cluster. Over to you, Dr. Impuma. You have 5 minutes. Thank you, Madam Chair. I will be making the presentation in English, so please just allow me time to get technology together.
The document titled Regional Strategy to Strengthen Rehabilitation in Health Systems. So we'll cover just an overview of the rehabilitation paper, the rationale for this strategy, and then highlight some of the key priority interventions and actions that are required to achieve the set goals. Just a high-level overview of the rehabilitation, as you can see, it really cuts across the continuum of healthcare. It also addresses not only communicable, but also non-communicable diseases, as well as other conditions. It also happens across the life course. And in terms of intervention scope, they are very broad, going from occupational therapy, physiotherapy, as well as speech therapy. In terms of the rationale for strategy, for this strategy, there's a global initiative on rehabilitation, which was adopted. We would like to align with that global document. The second one, in this region, we did not have any regional strategy on rehabilitation. This is therefore the first regional strategy on rehabilitation, which will provide some guidance to countries on how to address this issue. In terms of burden, 3 numbers to remember. One is really, we have close to 200 million Africans, that is 1 in 5 who need rehabilitation due to various health conditions. We've seen an increase in the number of years lived with functions, limitations. It's over 100. And then we have less than 65 people in need of rehabilitation who have access to such services. There are a number of interventions that are suggested. I'll not go through all of them, but the first one is really the need for integrating rehabilitations into national health policy strategies and plans. That's one of the areas which we're suggesting countries to consider. The second one is really the financing of this area, although it's an important area, but in terms of funding, there is limited funding. The third one is really when countries are experiencing health emergencies, it may be extremely important when designing the response to health emergencies to at least include a rehabilitation dimension. So our suggestion will be in a region that experienced more than 100 acute public health events per year, when countries are designing their preparedness and response plan, you may consider including the rehabilitation dimension. The remaining are really the need for some research on rehabilitation, the need to generate some data so that our actions towards rehabilitation is informed by evidence. And then lastly, it's really the advocacy that may be required to really put this area high on the national political agenda. So with that, the regional committee is invited to review and endorse the proposed document. Thank you, Chair.
Merci, Dr. Impuma.
Thank you, Dr. Impuma. I now open the floor to member states' interventions.
Le Mali a la parole.
Mali, you have the floor.
Merci, Madame la Présidente.
Thank you, Madam Chair.
Le Mali, où ça? Le Mali est confronté à une demande.
Mali faces an increase of demand for rehabilitation services.
Non, s'il vous plaît, c'est pas le bon document.
Sorry, that's not the right. I'm just getting the right document.
Okay, donc,
we'll come back to you. We now give the floor to Togo. Comoros, sorry, and Togo will be next. Thank you, Madam Chair. I would also like to congratulate the Regional Director of WHO for Africa for his determined commitment to improving the health situation in our country. And we would like to express our commitment also and appreciation for by WHO, especially in regard of the SIDS countries. With regard to this agenda item, we are also facing challenges, and because of this, we have been refocusing our services in terms of more prevention and promotion and treatment. Palliative care has not yet been very well developed yet. And also we haven't looked at the issue of medical evacuations. We need to look at our epidemiological profile and to see how we can improve our university hospitals. We are requesting from WHO technical assistance to fill the gaps so that we can achieve UHA, so that we can cover the whole of the health pyramid, especially in terms of palliative care. With the financial constraints, we do support in terms of implementing our operations. With regard to the regional strategy, which we are now discussing, adjuncting item 9, we need to encourage our member states to come up with innovative financing systems and funding. And this will, therefore, on this basis, our country would like to support the adoption of the regional strategy and to step up our methods to come up with better solutions. Thank you for your attention. Thank you to Comoros. We have Togo next and then Kenya. Thank you, Madam Chair. Togo would like to thank the Secretariat for the document on the regional strategy to strengthen rehabilitation in health systems 2025 to 2035. Togo recognizes that rehabilitation is needed in terms of continuity of care and in terms of the SDGs. In particular, we need to focus on people who need these facilities and services and to have access to them. We are in agreement with the priorities that have been highlighted, especially in terms of leadership, governance, and also make sure that rehabilitation is a priority, and also to have a pluridisciplinary approach and to integrate rehabilitation data into our national health information systems. At the national level, Togo has registered progress in terms of improving skills in the area of rehabilitations. We have a national center and a regional center in terms of orthopedics, and this is in line with achieving a UHC by 2030, and we are focusing on including this kind of care in the general health package. We would like to call on WHO and partners to renew and streamline their cooperation so that we can make better progress together. Togo would like to approve the adoption of this document. Thank you, Togo. We now give the floor to Kenya, and then it will be Mali, if Mali is ready. Sorry, so Mali will go. Thank you, Madam Chair. Mali would like to congratulate the Secretariat for the quality of the document on this regional statute. Mali has an increasing demand for rehabilitation services. We have chronic diseases, we have road injuries. This complicates the situation, and therefore it's very important that this is reflected in the regional strategy 2025 to 2035. It affects 15% of our population, and this is also due to armed conflict. We are aiming to include these services so that we can achieve UHC. In 2024, Mali had 5 rehabilitation centers and 25 health specialists in rehabilitation, but 80% of the population is not covered. We do have a lack of infrastructures. We have a lack of specialist professionals and also lack of funds. However, we have set up a center of excellence for the production and the provision of orthopedics and prosthesis. The initiatives that we have underway includes partnerships so that we can train local technicians and also to rehabilitate at the community level, and also to come up with a plan of action and the deployment of outreach mobile teams so that we can reach hard to access areas. We are advocating for more budgets both at the public and private level. We are therefore calling on our partners to protect us, to support us better with a view to sustainability, to support our awareness, especially in terms of removing the stigma. Thank you very much, and therefore we would like to adopt this regional strategy. I will now read a list of those who will. We will have Kenya coming next. Then we will have Mozambique, Namibia, Central African Republic, Benin, Gambia, Sierra Leone, Angola, Ethiopia, Seychelles, Cabo Verde, Burundi, Niger, Nigeria, Madagascar, Burkina Faso, Zimbabwe, Tanzania, Guinea-Bissau, Benin, Mauritius, Algeria, and Angola. I hope I haven't left anyone else. Yes, Algeria, you are on the list. Sorry, you didn't raise your nameplate. we will take you off the list. We also have Gabon and Uganda, and we now close the list. Thank you, Kenya. You have the floor.
Thank you, Madam Chair. Kenya supports the regional strategy to strengthen rehabilitation in health system to 2025-2035 and affirms that rehabilitation must be prioritized as a core component of universal health coverage and resilient health systems. Rehabilitation is critical for improving functionality, independence, and quality of life, particularly for persons with disabilities, older adults, and individuals living with non-communicable diseases, injuries, or chronic conditions. It also contributes to productivity and reduced dependency. Aligned with WHO's Rehabilitation 2030 initiative and Global Disability Plan, Kenya has made commendable progress. The Ministry of Health has established a dedicated rehabilitation services unit under the Directorate of Creative and Nursing Services to lead national coordination, policy development, capacity building, and technical support for 47 counties. Rehabilitation is now embedded in Kenya National Health Frameworks, such as the Kenya Health Sector Strategic and Investment Plan, Kenya Essential Health Services Package, and the UHC program. Service delivery has expanded to hospitals, community-based programs, and outreach platforms. Kenya continues to prioritize workforce development through expanded training in visual therapy, occupational therapy, orthopedic technology, and speech-language therapy in collaboration with training institutions and regulatory councils. Assistive technology access has also improved through national standard and coordination. The ministry has implemented the rehabilitative services and assistive technology strategy and medical disability assessment guidelines based on ICT framework. Rehabilitation indicators have been integrated in the Kenya Health Information System for data-driven planning. Despite progress, the country still faces workforce shortages, infrastructure gaps, and limited community rehabilitation coverage. We urge the WHO and partners to support investment in human resources, infrastructure, digital innovation, and South-South collaboration. Kenya remains strongly committed to implementing the regional strategy and calls on all member states to prioritize rehabilitation as essential for inclusive, equitable, and resilient health systems. Asante sana. Thank you very much.
Merci. Thank you, Kenya. Mozambique, you have the floor, followed by Namibia. Mozambique, over to you. Thank you very much for giving me the floor. Firstly, we would like to commend this report, which is really indicative of leaving no one behind. In Mozambique, rehabilitation is particularly important because we have noticed a rise over the years of the need for rehabilitation services because of epidemiological, social, and demographic reasons. With the rise in infectious diseases and also NCDs and trauma and injuries, it's important for us to adopt this strategy. We should be ready at all levels of the healthcare pyramid to make sure that we have a continuity of health and care, including rehabilitation, and that this should be available also at community level. When we establish our services in our country, we always have the concern to include rehabilitation services. We do have rehabilitation, physiotherapy, occupational therapy services available in our country, even though we have progressed very slowly and we have limited more. It's concentrated in the main cities. We think that this is an inequality. This is a challenge for us, so we need to invest more and more in the community. It's important for us to view rehabilitation as an investment in human capital, and that will help us in terms of social development and sustainably so. Therefore, Mozambique welcomes this regional strategy to strengthen rehabilitation in health systems we will work together and make sure we leave nobody behind. We will come up with sustainable and innovative measures to strengthen our infrastructure and systems. Thank you very much, Mozambique. Namibia has the floor, followed by the Central African Republic.
Thank you, Madam Chair, and thank you so much. We welcome the coming online of this strategy. We believe that this strategy, which is a first for the region, would definitely serve as a necessary reference document for us to domesticate domestic policy and to be able to implement targeted measures to address this matter. Madam Chair, we find the initiatives that are engendered in this draft strategy appealing to our national context. The demand for rehabilitation in Namibia, like in a number of our countries, is quite high. We find increasingly more people requiring rehabilitation services. However, the coverage of these services is limited to a few health facilities. It's limited in our case to the National Referral Hospital, intermediate and district hospitals, leaving many people in need, especially at the lower level of the healthcare system. The number of rehabilitation professionals in the country is also low in per capita terms, with a general density of about 3.8 professionals per 10,000 inhabitants. Recognizing these challenges and Namibia's dedication to universal health coverage, the country, in collaboration with WHO and the partner countries and organizations, we have initiated actions to improve the rehabilitation services in country. This entail, one, the updating the policy framework for rehabilitation and assistive technology. Two, formulation of the National Strategic Plan on Rehabilitation, a 5-year national plan. And three, and last, updating the prosthetic and orthotics policy, the assistive technology priority list, the wheelchair and accessory provision guidelines, and the rehabilitation protocols for the visually impaired. Our ambition, Madam Chair, is to increasingly integrate rehabilitation services into essential healthcare services in the country and scale up the necessary investments in rehabilitation infrastructure and assistive technology going forward. We therefore welcome the coming online of this strategy, Madam Chair, and we lend our full support to this strategy as we deliberate on it. Thank you.
Merci à la Namibie.
Namibia, Central African Republic will be followed by Benin. Thank you, Madam Chair. Ladies and gentlemen, Central African Republic would like to commend this regional strategy to strengthen rehabilitation in health systems because this is important to achieve UHC. We congratulate the Secretariat for the quality of this document, which is aimed at the period 2025 to 2035. CAR has huge rehabilitation needs because of the injuries as well as increasing NCDs and also the sequelae of epidemics that we have suffered. However, rehabilitation service is limited and we don't have enough trained staff. Assistive technology is also lacking. Given the situation, the government has already undertaken several actions, such as the integration of rehabilitation into our National Health Development Plan, the third generation. We are prioritizing primary health care as well as the progressive development of rehabilitation in some of our hospitals, collaborating with certain partners by building capacity, especially of professionals working in orthopedics and in physiotherapy. However, we still have huge challenges. The implementation of the strategy will help us to resolve these gaps. We need financial and technical support so that we can implement our and also to set up specialist training and multidisciplinary training, given this in the context of a lack of human resources and finances. So technology is also very important in terms of humanitarian and emergency crisis. Our priority is to work towards universal health coverage in an equitable manner and to adapt to the situation to make sure that there is access to everyone who needs it. We will work at the national, regional, and international level. We are coming up with a strategy so that we work together with member states, and we would like to encourage everyone to adopt this strategy. Thank you very much, CAR. Benin has the floor and Gambia will go next. Thank you, Madam Chair. Benin would like to congratulate the Secretariat for the quality of this report and for coming up with a regional strategy 2025 to 2035 to strengthen rehabilitation in health systems. Benin takes note that indeed that rehabilitation represents an essential health strategy if we are to achieve universal health coverage. It is therefore necessary for the continuity of care at all levels and in terms of all diseases. This is why Benin is carrying out activities to promote rehabilitation in health systems. I am very pleased to note that Benin has a training school in physiotherapy for at least 20 years. They are training professionals for our country and also for other countries in the region. We have also set up within our hospitals a service which is coordinating rehabilitation services. Benin has therefore come up a 5-year plan from 2023 to 2027 with the support of Handicap International and CCR. Obviously, we have come up with some success stories. Because of that, we have physiotherapy, we have the training of 100 specialists, and also we have set up a pilot project in 3 of our 12 departments or provinces in the north, center, and south of the country to include rehabilitation within primary health care. The implementation of rehabilitation activities, particularly with the community, has really been helped by the Lilian Foundation. Benin would like to appeal to all stakeholders that we need to include rehabilitation into our national health development plans and also to focus on equity and accessibility of such services. This regional strategy can help us to strengthen rehabilitation in our health systems, and this will be in line with the global initiative in this area. Thank you. Thank you, Benin. We give the floor to Gambia, and next will be Sierra Leone.
Madam Chair, the Gambia warmly praises the development and presentation of the regional strategy to strengthen rehabilitation in health system 2025-2035 as outlined in the document. This forward-looking strategy offers vital guidance for integrating rehabilitation services across the entire care spectrum, making sure that no one is left out in our effort to achieve universal health coverage and better population health. We fully recognize the urgency emphasized by the strategy, and the gap highlighted. The Gambia is especially concerned given the increasing burden for non-communicable diseases, injuries, and infectious diseases that cause long-term functional limitations. Aligned with the global priorities, including the WHO Rehabilitation 2030 Initiative and World Health Assembly Resolution 76.6, this regional strategy sets clear aims and milestones to be achieved by 2025. We call on the WHO and partners to assist with strategies, guidance, technical support, and stakeholder coordination, especially for workforce development, data system strengthening, and financial model to sustain scale rehabilitation services. The Gambia affirms its unwavering commitment to this regional strategy and stand ready to collaborate in transforming health system. Together, we can ensure the rehabilitation becomes an integral, patient-centered, and equitable part of healthcare across Africa, ultimately advancing universal health coverage and better quality of life for all. Thank you.
Merci à la Gambie.
Thank you, Gambia. Sierra Leone has the floor, followed by Angola.
Thank you very much, Madam Chair. Sierra Leone recognizes the Secretariat for developing this regional strategy, which we definitely know will strengthen rehabilitation services in our countries. This strategy, from its outlook, clearly aligns with our national efforts as a country. Sierra Leone as a country has made tremendous progress in implementing rehabilitation programs within our health systems, in line with the WHO guidelines that exist and broader regional strategies that we have been adopting. We are dedicated to embedding rehabilitation as a core element in our healthcare delivery. Recognizing this, Sierra Leone has taken the following decisive steps to integrate rehabilitation services throughout our national healthcare framework. Key actions and interventions include key policy actions that we are taking is that the Ministry of Health has incorporated rehabilitation services as a core component of non-communicable disease plans and interventions in our country. One of our foremost achievements is the significant expansion of rehabilitation services across the nation. We have strategically invested in major hospitals and local community health centers, using resources from previous disasters. For example, the Wellington fire incident that occurred in 2022. Funds received to support that fire incident was also utilized to promote rehabilitation services. The expansion is crucial to ensuring all citizens, regardless of location, have access to necessary rehabilitation care. Additionally, in collaboration with Massachusetts Institute of Technology, we are working on creating the first ever center of to produce bionic prosthesis in the West African sub-region. The Ministry of Health has also prioritized human development as a key tool in terms of improving services in the field of rehabilitation. So we are embarking on training of all cadre of staff within this service. In conclusion, as a country, we give our full support to the adoption of this regional strategy. Thank you very much.
Merci.
Thank you, Sierra Leone. Angola, you have the floor, followed by Ethiopia.
Muito obrigada, Senhora Presidente.
Thank you, Madam Chair. Angola would like to congratulate the Secretariat for presenting the regional strategy to strengthen rehabilitation in health systems 2025 to 2035. In Angola, rehabilitation services were first established to respond to the demands that we had during the war, particularly due to victims of anti-personnel mines. And since then, we have also have a triple burden of trauma, injuries, and road traffic accidents. The health systems in our country are aimed at diagnosing and treating diseases which are life-threatening. We have to recognize that integrating rehabilitation, looking at motor skills and sensory skills, as well as palliative care, is very often neglected, because we are focusing on more urgent needs, and it helps us that we need to try and provide these rehabilitation services at a quality level so that we can have individuals functioning as best they can with the biggest amount of autonomy. We have a new reality because of road traffic and crashes. This leaves an impact on people with different levels of incapacities. Angola is strengthening the rehabilitation services at the municipal levels. We have several seats both at the municipal and central level. We have specialists who are in physiotherapy, occupational therapy, and prosthetics. We think that this approach has taken on a multi-sectoral impact because we have identified with the family ministry as well as the Ministry of the Interior. We think that a holistic approach is important. It needs to be people-centered. We have made an effort to try and have early detection of disabilities, and we have introduced this into the educational curricula in schools. Angola would like to support the regional strategy to strengthen rehabilitation in health systems in the WHO African region. Thank you very much.
Thank you very much, Angola.
Les Seychelles se préparent. Merci. L'Ethiopie.
Thank you, Honorable Chairperson. Ethiopia commends the Secretariat for preparing this timely strategy and welcome this alignment with the WHO Rehabilitation 2030 initiative and the Resolution WHO 76.6. The government of Ethiopia has established the Ethiopian Prosthetic and Orthotic Service as an independent institution under the Ministry of Health with mandate to provide comprehensive rehabilitation service including assistive technology, and it is producing it locally. This has been key strategic move demonstrating the attention given at the highest level of the leadership. Ethiopia has also integrated rehabilitation service into essential health service package, gradually expanding community-based rehabilitation and specialized rehabilitation and the prosthetic service across the health tier system. Rehabilitation is also increasingly part of mental and child health programs, trauma care, and emergency preparedness, demonstrating our commitment to universal health coverage. Nonetheless, access remains limited to the community and the primary health care levels. We also face shortage of trained and skilled rehabilitation professionals, import-dependent assistive technology, inadequate financing, weak infrastructure, as well as weak data system for tracking the progress. We believe the proposed regional strategy provides comprehensive set of actions to guide the process. We urge WHO to strengthen its regional support to develop rehabilitation workforce capacity and enhance collaboration for research, knowledge exchange, and sharing best practices. Ethiopia is interested and ready to build and strengthen partnership for innovation and the local production of assistive technology. We invite all partners and stakeholders to join the call in investing in the Ethiopian Center for Excellence that provides comprehensive rehabilitation services, assistive technology production, and the quality education and the research. Ethiopia supports the adoption of the proposed regional strategy to strengthen rehabilitation in health systems and looks forward to accelerating its implementation to ensure that no one is left behind. I thank you.
Merci à l'Éthiopie.
Thank you, Ethiopia. Seychelles, you have the floor, followed by Cabo Verde.
Thank you, Mrs. Chair. Madam Chair. Seychelles fully endorses the regional strategy to strengthen rehabilitation in health system 2025-2035. In Seychelles, rehabilitation is anchored in the Ministry of Health and recognized in our national health policies. Services are free for all Seychellois and delivered through physiotherapy, occupational therapy, speech pathology, audiology, prosthetics and orthotics, podiatry, and traditional medicine such as acupuncture. Care is provided at all levels of the system and even in communities. However, challenges persist. Our workforce is limited in size with increasing age profile, and there is a lack of rehabilitation physicians and specialized nurses. Access to assistive products is mostly limited to basic mobility aids, while advanced products often require costly overseas sourcing. In addition, there is limited national data on disability and rehabilitation needs, making evidence-based planning difficult. To address these gaps, Seychelles has recently developed its first national rehabilitation strategic plan, aligned with WHO's Rehabilitation 2030 initiative, aimed at ensuring that rehabilitation services are equitable, accessible, and of high quality for all. We remain fully committed to strengthening rehabilitation as a vital component of universal health coverage and to advancing health for all by 2030. Thank you, Madam Chair.
Thank you very much. Seychelles. Cabo Verde, you have the floor, followed by Burundi.
Thank you very much, Madam Chair. Distinguished delegates, we would like to thank you for this opportunity to take part in this, and we would like to support the regional strategy to strengthen rehabilitation in health systems. As a signatory of the United Nations Convention on the Right of People with Disabilities, and based on the strategic plan for sustainable development, Cabo Verde would like to reaffirm its commitment towards rehabilitation, looking at the social inclusion so that we can achieve the SDGs 3 and 10. In Cabo Verde, 10% of the population suffer from incapacities, particularly in terms of visual and sensory impairments. In Cabo Verde, we do not yet have a strategic plan for rehabilitation, apart from having a role within the Ministry of Health to provide rehabilitation services at all levels. Rehabilitation is within the essential health packages in areas such as physiotherapy and psychosocial counseling. It is included in terms of primary health care, particularly with visual impairments, hearing impairments, and this at the centralized level. In Cabo Verde, the Ministry of Family and in Social Inclusion has a key role to play in terms of rehabilitation. They have come up with a national strategy for inclusiveness to 2024 to 2030. This promotes functional rehabilitation with affordable and will provide employment. There are often private services, but they are limited. The contribution of Social Security for rehabilitation services and assistive technology is inadequate. Cabo Verde would like to support the adoption of a regional strategic plan for rehabilitation. We recognize the need for us to scale up rehabilitation services and to strengthen the amount of skilled staff. We need to look at evidence-based indicators, and this will help us to inform our decision-making. And finally, we do recognize that rehabilitation is a cost-effective measure to help individuals and communities and the health system. Therefore, we would like to support the adoption of the regional strategy. Thank you, Cabo Verde.
Thank you, Cabo Verde. Burundi has the floor. Thereafter, we'll have Congo, and we'll take a break after that. Burundi welcomes this to strengthen the rehabilitation in health systems 2025-2035. And it's a decisive instrument for health coverage and the sustainable development goals. My country aligns itself with this vision and has already laid foundation to build an inclusive and resilient health system that incorporates rehabilitation. After the 2011, 2016, and 2007 and 2022 strategic plan, Burundi developed another one, 2023-2027, supported by a technical service in the health sector. Since then, the recommendations of the WHO have been incorporated in this health system. As regards human resources, the establishment in 2099 of a national school that helped to train more than 80 graduates that are specialized, without forgetting the development of a research institute in public health. Access to infrastructure was also strengthened with more than 150 services of rehabilitation services in 2024 compared to less than normal in 2010. The funding is making progress thanks to the increasing involvement of the public and private insurance system. This progress is the fruit of political resolve and collaboration with our partners, especially the WHO. However, we still have challenges, especially in the area of technical assistance that is still little developed in developing. My country is looking for strengthened partnerships to bridge this gap in the context of regional and international solidarity. Our ambition is clear: make Burundi a regional hub for rehabilitation by sharing our experiences and achievements. Madam Chair, in conclusion, Burundi expressed its full support to implement the regional strategy of the WHO and a call for collective mobilization to ensure that nobody is left behind in regard to health and well-being. Thank you. Thanks, Burundi. Congo, you have the floor. We'll take a break after Congo's interventions. Madam Chair, the Republic of Congo is delighted of the adoption, the national strategy for rehabilitation in health systems from 2025-2035. We laud this initiative promoted by the WHO office that meets the profound challenges of resilience, equity, and quality in African health systems. Our country fully aligns itself with this integrated vision, which considers rehabilitation not as a peripheral service, but as a fundamental pillar of primary health care. It is indispensable for the autonomy, dignity, and the reintegration of people living with disabilities. We laud the resolve to institutionalize specialized training in rehabilitation in medical curricula. The call for continental mapping of needs in order to shed light our public policy with data and the commitment with sustainable funding through public budget. We'd also like to exhort the development of tele-rehabilitation, support to local research on innovations in rehabilitation, and the emergence of African Expertise Network. Madam Chair, our continent cannot content itself with surviving with the disease. It has to enable its citizens to rebuild, to take its autonomy, and to fully integrate social life. In this light, this strategy is a turning point. The Republic of Congo undertakes to integrate the principles of this strategy in its health policy and to take part in the pilot initiative from 2025. Finally, Madam Chair, we call and exhort all member states as well as our technical and financial partners to support this regional dynamic. Thank you very much. Thank you for all the distinguished delegates that made interventions. We would like them to stay on to wait for announcements from the Secretariat. Thank you.
Thank you very much, Chair. Dear ladies and gentlemen, you are kindly requested to remain seated for the upcoming high-level side event on the state of health financing in Africa, starting at 12 p.m., which will be honored by the presence of His Excellency, the President of Zambia. Please note that there will be no formal lunch break today. However, following the high-level side event, you may step out at your convenience to enjoy the food which is provided in the hall.
Closer to the mic, it's difficult hearing.
Okay, sorry. So probably I restart, recap that you are kindly requested to remain seated for the upcoming high-level side event on the state of health financing in Africa starting at 12 p.m., which will be honored by the presence of His Excellency, the President of the Republic of Zambia. Please note that there will be no formal lunch today. However, following the high-level side event, you may step out at your convenience to enjoy finger food, which is served in the hall in front of this conference room. Thank you for your attention. Ladies and gentlemen, I ask for your attention, please. I need to correct that the next high-level event is on partnership for strengthening an ecosystem approach to produce to production of medicine. Thank you.
Lors de notre approche.
On se voit. Oui, on peut marcher. Oui, bien sûr. Tout à l'heure, moi, peut-être de discuter, c'est un peu compliqué.
Alors, professeur, oui, très bien. Je suis content de vous voir. Donc, Jessie m'avait dit que c'est lui qui allait vous dire. Moi, je n'allais pas venir. Surtout que je suis trop pris par les activités de moi-même, du ministère, mais aussi de l'enseignement supérieur. Donc, les thèses de doctorat, les consorts, les mémoires de TIA, c'est vraiment ennuyant. Vraiment ennuyant pour moi. Donc, j'étais trop coincé. Alors, démocratique Congo. Give me tout. Bonjour, donne-moi encore un. The sac. Oui, mais give me one. Give minister. Give me one. Give me one. No, you can't. Give me one. Yes, give me one. Give me one. No, he's minister. Hein? Lui ne comprend pas. Ça, c'est pour le ministre. Maintenant, pour moi. Hein? Comme le ministre n'est pas venu, c'est le secrétaire général qui le représente. Normalement, je dois amener ça chez le secrétaire général. Ah. Le président va entrer ici.
Voilà. C'est ça que j'ai fait. Et puis, depuis hier, je me suis un rapport.
C'est bon, nous allons c'est ça.
Il y a des voilà. On n'avait pas bien maîtrisé en fait la procédure. Parce que quand on a fini, on a envoyé en fait une correspondance pour l'étape présidence. Et puis bon, après moi, j'ai dit que notre but, c'est on devait envoyer la après, quand on a fait un rapport en conseil de ministre, donc c'est bien sur le rapport de la vraiment, ça ne suit pas du tout le format classique en fait d'un rapport. Non, c'était juste. Ah oui? Du tout, vous perdez moi rester en fait c'est pas simple. Hein? C'est pas simple. Tu peux perdre moi rester en fait dans pas. Oui, avec le dîner là. Voilà. Si, moi je suis parce que les dîners là, je ne pas tant que je peux. C'est fatigué. Mais ici, moi, je suis resté. Mais c'est le dîner l'Occident. Je n'aime pas. Tu donnes des petits. On parle anglais, tu comprends la sécurité. Donc, ça veut
Colleagues, let's take seats. The president is just about to arrive. Let's take seats. Come. Huh? Kalangwa, with your big voice, come.
The president is gone. Oh yeah, he said we should sit. Why are they giving instructions like that? Because we know the president can't expect that. But instead of telling us to stay, you can sit.
Ladies and gentlemen, the guest of honor, the President of the Republic of Zambia, Mr. Hakainde Hichilema, is here. Please, let's settle down. Let's settle down as we sing the national anthem. Stand and sing of Zambia, proud and free, land of bread and joy, unity, victors in the struggle for the land. We won freedom's fight. One strong and free. Africa is our own motherland, fashioned with and blessed by God's good hand. Let us serve our people, join as one, brothers under the sun. Oh, one, strong and free. One land and one nation is our cry. Dignity and peace needs Zambia's sky. Like a noble eagle in its pride. Zambia, praise to thee, oh one, strong and free. Praise be to God. Bless our great nation. We stand under the flag of our land, Zambia. Praise to thee, oh one, strong and free. Shall we remain standing for the word of prayer? Shall we pray? Our Father who art in heaven, and our Lord Jesus Christ, in whom all knowledge and wisdom are hid, we salute you this afternoon. We call upon you, your presence, as we commence this important side event as leaders, experts, and partners unite for the noble cause of healthy and healing across Africa. We thank you for the gift of knowledge and innovation, for the minds that research and the hands that heal. We are grateful for the collaborative spirit that brings us together, reflecting your divine nature of community and love. Father, as we deliberate on the partnerships for the strengthening an ecosystem approach to end-to-end local production of medicine, vaccines, and other health technologies, we ask for your guidance. Grant us clarity of thought, generosity of spirit, and a shared vision. Bless our guest of honor, Mr. Hakainde Hichilema, the President of the Republic of Zambia, all dignitaries, and every participant with wisdom beyond their own, that our discussions may be fruitful and commitment steadfast. We pray for a successful and impactful meeting, that from our partnership, hope and healthy may flourish for all your children. We ask all this in Jesus' mighty name we pray. Amen. Your Excellency, a request may be seated. Let's see.
Good
morning, everybody. Now that we are duly blessed and we're feeling patriotic, then we can begin. The President of the Republic of Zambia, Mr. Hakainde Hichilema, the Director General, World Health Organization, Dr. Tedros Adhanom Ghebreyesus, the Regional Director for Africa, World Health Organization, Professor Mohamed Yakub Janabi, the Director General, Africa Centers for Disease Control and Prevention, His Excellency Dr. John Teseya, the first Vice Chairperson of the 7th session of the World Health Organization, the Honorable Dr. Louise Makle Kupoto, the Minister of Health, Republic of Zambia, the Honorable Dr. Elijah Mchima MP, Honorable Cabinet Ministers, Honorable Ministers of Health from Africa, the Provincial Minister, Lusaka Province, Honorable Shiel S. Muliata MP, representative of the Secretary to the Cabinet, Mr. Patrick K. Kwanga, the Chief Executive Officer of the Gavi Leap Initiative and Alliance, Dr. Sanya Nishta, the Director General, African Medicines Agency, Dr. Deles Mimi Bako, the Director General of the International Vaccines Institute, Dr. Jerome K. Kim, the Deputy Executive Director, UNITAID, Dr. Tenu Afabia, the Mayor of the City of Lusaka, Ms. Chilando Chitangala, the Permanent Secretary, Ministry of Health, Dr. Thiangwe, invited permanent secretaries, senior government officials, invited delegates, distinguished invited guests, members of the press, ladies and gentlemen. I don't think I've left anybody out. You're all welcome. Thank you very much indeed. Good afternoon and welcome to this side event on partnerships for strengthening an ecosystem approach to end-to-end local production of medicines, vaccines, and other health technologies in Africa. I'm your moderator, Henry Bonsu, a broadcaster from the UK and Ghana. And I'm privileged. It's when I said Ghana. Your Excellency, my apologies. I'm privileged to guide you through this high-level gathering led by His Excellency, Mr. Hakainde Hichilema, President of the Republic of Zambia. Mr. President, your presence here demonstrates the importance that you attach to this subject. We are thankful and we look forward to hearing what you have to say in your keynote. Now, this gathering is about partnerships between organizations aiming to turn pledges to produce medicines, vaccines, and other health technology into a reality across Africa. So we'll hear from the WHO Regional Director for Africa. We will hear from the Director General of the Africa Center for Disease Control and Prevention, and we'll hear from the Director General of the World Health Organization himself. And once they've set the scene, I will invite the Honorable Minister of Health, Republic of Zambia, to introduce Mr. President. Then our side event will be divided into two sessions. The first will be on the Gavi Leap, an exciting initiative from the Vaccine Alliance, led by Dr. Sanya Nishta, and her two ministerial board members from Ethiopia and Burkina Faso. Our second session will be a panel discussion on generating sustainable health, environmental, and economic benefits of a biotech sector in Africa. And all this through a life cycle ecosystem approach. But what does that mean and how do we do it? Well, our honorable health ministers from South Africa and Senegal will be joined by the Director General of the African Medicines Agency, the Deputy Executive Director of UNITAID, and the Director General of the International Vaccine Institute. Now, I've spoken a lot. And because we've got so much to get through in the next 90 minutes, our speakers will be extremely brief. I say that again, they'll be extremely brief and to the point. When necessary, I will encourage them to land, but they will leave you in no doubt of the scale of the ambition and the roadmap to get there. Let us hear first from Professor Mohamed Yakub Janabi, World Health Organization Regional Director for Africa. Professor. You can stay from there. Okay, here, yes.
Your Excellency, President Hakainde Hichilema of the Republic of Zambia, Honorable Dr. Elijah Muchima, Minister of Health of the Republic of Zambia, Honorable Ministers of Health and distinguished delegates, Honorable Dr. Jane Kaseya, CDC Africa, Dr. Sonia Nishta, Gavi, esteemed representative of the Africa Continental Free Trade Area Secretariat, the African Medicines Agency, valid partners from the International Vaccine Institute, UNITAID, the Gates Foundation, the European Union, the World Bank, regional and continental institutions, including Africa Exim Bank, the African Development Bank, the African Pharmaceutical Technology Fund, and the Islamic Development Bank, industrial leaders from the African Vaccine Manufacturers Association and the Federation of African Pharmaceutical Manufacturers Association, distinguished guests, colleagues, ladies and gentlemen, good afternoon and welcome. Let me begin by extending my heartfelt welcome to Dr. Sonia Nishta, CEO of Gavi, whose unwavering commitment has propelled the immunization agenda across our continent. I also salute the leadership of International Vaccine Institute and UNITAID, whose contributions have been nothing short of transformative. Mr. President Hichilema, your presence here today is not just symbolic. It's a powerful statement of intent. Your remarks at yesterday's opening of the 75th Regional Committee were a masterclass in vision and cohesion. You spoke of health as a cornerstone of economic development, of the urgency of harmonizing public health regulations, and of imperative to build a resilient institutions. You reminded all of us yesterday that health is not a sector, it is a sovereign priority. Your leadership in championing local vaccine manufacturing, especially Zambia's bold move on cholera vaccines, is a beacon for the continent. The inequalities laid bare during COVID-19 were not just statistics. They were stories of lives delayed, denied, and lost. Your call for change is a call we must answer. Allow me to share a personal story. During the height of the pandemic, I read a story of one doctor who visited a small clinic in a remote village in west of Tanzania. The nurse there, her name was Amina, had been working tirelessly, often without electricity, refrigerator, or even gloves. She told about a young boy, Samuel, who had walked for 2 hours with his mother to receive a vaccine that never arrived. The heartbreak in her voice was palpable. She said, "We are ready. We just need the world to believe." That moment stayed with me. It reminded me that behind every policy, every supply chain, every regulation, there is a human life waiting for dignity, for protection, and for hope. At WHO Regional Office for Africa, we have long recognized this need. Through African Vaccine Regulatory Forum, we have worked hand in hand with the national authorities to build the regulatory scaffolding for local production. Today, 8 countries, Ghana, Nigeria, South Africa, Tanzania, Zimbabwe, Senegal, and Rwanda, have reached maturity level 3, a milestone that brings us closer to self-reliance. You spoke of the link between health and education, a connection we deeply value. Our revitalized HPV vaccine programs in schools are a testament to that belief. As we look ahead, I offer 3 commitments. WHO stands firmly behind the immunization agenda and the shift to local manufacturing. We will continue to build the regulatory and clinical trials capacity side by side with our partners. We will drive the implementation of Gavi across all 47 member states, engaging closely with the ministers and the national authorities. Our country representatives are already briefed and mobilized. And finally, Mr. President, I count on you. I count on your continued leadership to keep health at the forefront of the continental agenda. Your voice among fellow heads of state is very, very vital. Your advocacy is our momentum. Let me close with your own words yesterday, you said, Mr. President, which echoed in this room and across the continent. Health is not just a service, it's a sovereign investment. We must harmonize our public health regulation, build resilient institutions, and ensure that no African child is left behind in the race of equitable healthcare. Let us move forward with urgency, unity, and unwavering resolve. The future of Africa's health sovereignty depends on what we do together today. Thank you, Mr. President.
Professor, thank you very much indeed. It's good to hear about those commitments and the sustainable dedication of the WHO Africa region to this cause. One of the initiatives we're championing today is the Gavi Leap, the Global Alliance for Vaccines and Immunization Leap. So some of you will be thinking, what is the Gavi Leap and where are we leaping? Where are we going from and to? Well, let's hear from the Chief Executive Officer of Gavi, Dr. Sanya Nishta. Dr. Nishta.
Your Excellency, Honorable President of the Republic of Zambia, Honorable Minister of Health, members of the Zambian Cabinet, WHO DG, WHO Regional Director, Director General of the Africa CDC, Excellencies, partners, friends, ladies and gentlemen. Gavi is extremely honored to have this space to talk about its new transformation program. I want to reiterate, we come to your continent, we come to your country with a lot of humility, with a lot of respect. And we're very grateful for the space that has been created for us to talk about our new transformation program called the Gavi Leap. Gavi Leap is all about putting countries at the center of development, at the center of health, and not Geneva and New York at the center of development and health. It's about transformative change, and this is not rhetoric. This is not a story. As we speak, concrete changes have actually cascaded into implementation. Let me tell you a little bit about Gavi before I talk about the transformation plan. Gavi is an international, multilateral, public-private partnership, which is a non-UN partnership. We work as an alliance very closely with WHO and UNICEF. There are 2 things that Gavi does. The first is to provide access to vaccination for routine vaccines. And within that space, we work with the private sector, we work with governments, we pool demand, we give the manufacturers long-term visibility. We drastically bring down the cost of vaccines and we make them available to 100 countries. With 54, of which Zambia is one, we work very closely. And with another 46, we have a slightly lighter touch engagement. And over the last 25 years since Gavi has been in existence, we have vaccinated over 1.1 billion children, saving over 19 million lives and accruing more than $250 billion worth of economic benefits to the society. And this is all thanks to your leadership that has happened. The other thing that Gavi does is that it plays a very important role in global health security. Your countries have vested Gavi with a very important and unique mandate. We are the custodians of the vaccine stockpiles for the world. And we currently maintain the vaccine stockpiles for 4 diseases: the Ebola vaccine, the yellow fever vaccine, the meningitis vaccine. And going forward, we are also going to be maintaining the stockpile of the Mpox vaccine from January 2026 onwards. We have also been vested by your governments who sit on our boards to have special funding arrangements that come into play when there's a public health emergency, including the First Response Fund. And to give you an example, during COVID-19, it took months for money to be mobilized to get vaccines, which is why Africa was at the back of the line. Learning from that, we have put in place the First Response Fund. So when Mpox struck, we were able to secure vaccines and place orders for your countries within 3 days of the public health emergency being declared. So there are in summary, to bring to bear, 2 kinds of roles we play, in routine vaccination and in global health security. Now, Gavi works in 5-year cycles. Our current 5-year cycle is coming to an end of the year, and our next 5-year cycle will start from January 2026. In preparation for that, there is a new strategy in place. All your countries have inputted into the establishment of that strategy. That strategy was costed, and we went on the replenishment drive, which was costed at $11.9 billion. And I'm extremely grateful to His Excellency President Hichilema, who was one of our champions and wrote to many donor countries to secure support for Gavi. I must reiterate, Gavi is almost like a pass-through. We do not have high administrative costs, and 80% of the money that we secure comes to countries directly. Now, of course, is the time to operationalize the strategy now that we have secured $9 billion. Of course, the journey continues to secure the next $3 billion, and we seek your support in that journey. But now it's time to operationalize the strategy. We have made profound changes internally within the Secretariat to work far more simpler, to be more transparent, to exploit synergy with the partners. And there is an important element related to operationalization, which relates to our country operating model. That is where the first principle of the Gavi Leap is extremely important. And the first principle is focused on country centricity. I cannot emphasize this more. The first principle is country centricity. We have made a number of changes already to our ways of working, which you will start seeing playing out from the 1st of January 2026. The first of those changes are to put more resources at the decision-making discretion of countries, because we respect your decision-making ability. We know that you have your own vision, you know your own problems, and we want to be able to put more money at your discretion to use as you deem fit. The second thing that we have done is to make it easy for countries to work with Gavi. Previously, countries had to make 8 applications, and even this morning, as I was speaking to the Minister of Health of Liberia, she talked about how onerous it was to fill in applications all the time. And I'm pleased to let you know that from 2026 onwards, with a period of transition, countries will be able to put in 1 application. Thirdly, we're improving the speed of response. Currently, it takes 16 months for us to turn around your applications. So we've made significant internal changes to espouse end-to-end automation, to change our decision-making structures, to make decision-making more streamlined without compromising controls, so that the time that it takes for us to get to you with decisions is reduced. We are also, as an alliance, and the DGWHO is here, we work very closely. As an alliance, we're working on a new accountability framework because we believe we are in your service. The international agencies are meant to serve you. You are meant to be in the lead, and we have to be accountable to you. And so there is a new accountability framework, and we're quite further along in our efforts to prepare that. We are also changing our modalities of support to strengthen systems, despite the decline in resources. And here, while in Zambia, I was very pleased to see that we were able to support the president's vision. We were able to support the ministers of health's efforts to solarize health facilities, to provide motorbikes, to provide bicycles. This is your vision that we are supporting. Our role is just to be catalytic and to support you from behind. We are also, Your Excellencies, calling for a merger at the last mile. A merger at the last mile. A poor woman who goes with 4 children and a sick husband and paralyzed in-laws back at home does not have any interest in knowing how many agencies operate out of the primary healthcare facility. She wants vaccination for herself, for her children, contraceptives for herself, medicines for sick parents at home. And we are calling for a merger at the last mile of all agencies, and we are doing our own analysis on how to drive this further. Another change we are bringing is to support you with your health financing plans. We know that Africa CDC has convened several important meetings to promote domestic resource mobilization, and health financing is on top of their agendas. This May, when the African Ministers of Health convened in Geneva, the first meeting that they attended was a meeting on health finances. So to unlock that potential for you, we have launched a new initiative called the Multilateral Development Multiplier, through which we will work with you and the bank and other multilateral development initiatives to unlock financing for you. And finally, we have taken concrete steps to respond to your earnest desire to be sovereign in terms of vaccine manufacturing. Africa was at the back of the line during COVID-19. That must not happen again. Learning from that, we put in place what is called the African Vaccine Manufacturing Accelerator. It's a $1.2 billion subsidy mechanism which exists today. The money is in our bank. And it's meant to give milestone payments to African commercial vaccine manufacturers who qualify. The first milestone payment is when they get WHO pre-qualification. The second milestone payment is when they compete in our tenders. I'm not saying that the African Vaccine Manufacturing Accelerator, or AVMA as we call it, is a silver bullet, but it is a very important tool at your disposal in your toolkit, which you own, to catalyze commercial vaccine manufacturing on the continent. And if it is combined with the right government policy, with the right government incentives, with the right offtake agreements, it will really help to unlock the African potential to be vaccine sovereign within the next 5 years, and we stand ready to support you. So, Your Excellencies, I want to reiterate to you once again that we have made concrete changes within the organization to facilitate this transformation. And I want to reiterate once again that Gavi is highly respectful, and we come to your table with great humility and with great respect, and that our aspiration is for you to lead, and our aspiration is for us to continue to support you with global public goods from the back. Thank you very much for this honor of having us speak.
Thank you very much, Dr. Nishtar, for that address on behalf of Gavi. As you can see, we have lots of partners. We're barreling towards a destination, and we're going together. You did mention, Dr. Nishtar, the Africa CDC and how domestic resource mobilization is at the top of their agenda, as it was in May at the World Health Assembly. So what is the capacity of African member states and their public health institutions to rise to this challenge, to be able to use these new initiatives? Well, let me invite Dr. John Kaseya, Director General of the African CDC, to make some brief remarks about exactly that. Dr. Kaseya, please come to the stage.
Your Excellency, President Hakainde Hichilema, President of Zambia, Global and African Union Champion for Cholera. My dear brother, Dr. Tedros, Director General, WHO, Professor Janabi, RD, WHO Afro, Minister Elijah Muchima, and my dear sister Sanya. Let me also recognize all of our ministers and all colleagues who are here for this event. Excellency, I cannot start this speech without thanking you officially for giving me opportunity to become commander of the Order of the Eagle of Zambia. This great honor is not for my humble person, but it is for AU. It's for Africa CDC and all of our ministers and partners working on daily basis to support health in Africa. Thank you so much, Excellency. Please, Excellency, allow me to share with our colleagues your remarkable leadership as a global and AU champion for cholera. You are transforming the role of political leadership in public health, setting an example for the current and future generations, and showing what the Africa we want must be. Today, I had a nice meeting with a wonderful person called Joy Pumapi, who's leading the African Leadership Alliance. Excellency, she was informing me that under your leadership, there is what we call the End Cancer Malaria in Zambia. And she was telling me that Zambia is one of the success stories, the way this End Cancer Malaria is working. Then we decided to give Joy opportunity to transform this End Malaria Council to the Health Council, and to implement your vision to end cholera and other outbreaks. This is why, Excellency, I have the honor to inform all of our colleagues here that Zambia will be the first country where we will implement, under your leadership, the Health Council in Africa. Excellency, you have been at the forefront of championing not only cholera, but so many agendas, including local manufacturing of health products in Zambia and in Africa. You are investing in the development of the health workforce, and you are doing all of that to show our national leadership, grounded in accountability and innovation. As you have to repeat to me, leading a country as a company, being the CEO, is bringing transformation in Africa. Excellency, this session is also about the Gavi Leap. Let me share with you, the very first day my sister Sanya took office in Geneva, the first partner she met was me. Because Africa is representing 80% of the Gavi envelope. But also because I wanted to make sure that as the CEO of Gavi, she's listening, she's implementing what we want, and she's respecting us. My meeting with my sister was so fruitful. I moved by saying today she's not only my sister, she's my best friend. Because Gavilip is the transformation that we need in Africa. She already described this, Gavilip. We need alignment, we need respect, and we need this Lusaka agenda to be a reality. This Lusaka agenda, grounded on the Rethinking Africa and financing in a new era that our head of state they developed and they are championing. Your Excellency, you tasked with your colleagues, Africa CDC, to lead the local manufacturing agenda and working together with African Medicine Agency for the regulatory aspect and the FCFTA for the third aspect. Yesterday, I was trying to engage ministers and member states here to contribute to make AMA working. Even if the DG AMA is here, she's still waiting for a contract because African countries must contribute. And this is also another reminder for us to make it happening. For the demand side, Excellency, we created under your leadership the African Pool Procurement Mechanism. This is a game changer. A game changer because, Excellency, since yesterday, I'm facing some headaches. We have countries in Africa facing stock out of medicines, total stock out of medicines. I'm talking with your colleagues, head of state from this country, with ministers. We are supporting them to get these medicines very soon, but we need to put in place strong systems that can avoid this kind of issues again in the future. This is why we are engaging our member states to consider the African Pool Procurement Mechanism as the game changer for us not to face again this issue. We need also to invest in our R&D. I was talking with Jerome Kim, he must be somewhere. How Africa must provide funding for the research and development. We don't have to wait for Western countries to give us their own priority in terms of research and development. Excellency, without that, will not move on with our local manufacturing agenda. It's an opportunity for me to say clearly and loudly, we are supporting as Africa Union, as Africa CDC, the replenishment not only of Gavi, still a success, but also Global Fund, Green Climate Fund, and Pandemic Fund. But Excellency, today is your day, because after organizing a meeting with 20 member states a couple months ago, after giving a clear guidance, you decided to launch today the Continental Cholera Outbreak Response Plan. This one is a major milestone and is signing a turning point in how political leaders can be engaged with technical colleagues like us to make Africa's public health challenges out of this continent. Excellency, I will disclose what you shared with me with your permission to show that your leadership is in action. You even decided not only to launch today, but to visit countries affected by cholera very soon. We'll be supporting you. My brother, Rosa Janabi, and myself will be accompanying you in these countries. I want our member states, mostly those who are affected by cholera, to know that you are not alone. We have a champion, and this champion not only supporting us, but reporting to other heads of state on the way we need to make Africa safe. Thank you so much.
Dr. Kaseya, thank you very much for that raft of very positive announcements, and congratulations again on your award, Dr. John Kaseya. Thank you very much indeed. Now, how do Dr. Kaseya's remarks fit into the broader WHO strategy for Africa and globally? Well, I'm delighted to welcome the Director General of the World Health Organization, who, despite all the global pressures of his role, and I see him on my television station regularly, constantly punching for Africa as well as global health, he remains a proud African despite the challenges. He's Dr. Tedros Adhanom Ghebreyesus. Please welcome. And you continue the claps. Don't leave him in silence, please.
Your Excellency, President Hakainde Hichilema, Honorable Minister Elijah Uchima, Honorable Ministers of Angola and Burkina Faso, Honorable Ministers or Heads of Delegation, our Regional Director, Professor Janabi, Director General, Dr. John Kasea, Director General Delice Darko, and Gavi CEO, Sina Nishtar, dear colleagues and friends. First of all, I would like to join my brother John Kasea in thanking His Excellency the President and his government for the recognition yesterday, the Order of the Eagle of Zambia, Third Division. Thank you so much, and I accept it full-heartedly on behalf of my colleagues at WHO who are working hard day and night, and you have seen it during COVID, and the hard work continues. So I accept it based on my colleagues, and thank you so much for that recognition. And Your Excellency, I would like to use also this opportunity to thank you for joining us again today. This shows the great commitment you have to health, which doesn't actually happen very often. And we really cherish that. Health is central, and that's what you're showing. So thank you for that, Your Excellency. And please accept my deep respect and appreciation. In my opening remarks yesterday, I spoke about the opportunity for Africa to chart a new path for sustainable self-reliance. A key part of that journey is self-reliance in production of medical products. One of the most important lessons of the COVID-19 pandemic was that the concentration of manufacturing in just a handful of countries led to deep inequities in access to vaccines and other health products. This has been underscored by outbreaks of Mpox, Ebola, and Marburg virus disease, as well as the continuing prevalence of ancient diseases like malaria and tuberculosis. The situation has been further compounded by the drastic disruptions and cuts in the global health landscape. In the face of these challenges, it's clear that expanding national and regional production is essential for strengthening epidemic and pandemic preparedness and response. Recognizing these challenges, the new pandemic agreement drafted and adopted by WHO member states includes an entire article on sustainable and geographically diversified local production, and another article on transfer of technology and know-how for the production of pandemic-related health products. The pandemic agreement is just the latest step. In fact, WHO has been working for many years on strengthening local production using an ecosystem-wide approach. In 2021, we launched the mRNA Technology Transfer Program, which is now sharing technology from its base in Cape Town, South Africa, with a network of 15 partner countries globally. And in 2023, we established the WHO Biomanufacturing Workforce Training Initiative, including a global training hub in the Republic of Korea, which has helped to train over 7,000 participants globally so far. Another key element of WHO's work is assessing and strengthening national regulatory authorities using the WHO Global Benchmarking Tool, which addresses 9 key regulatory functions. So far, 8 national regulators on the continent have reached maturity level 3. Egypt, Ghana, Nigeria, Rwanda, Senegal, South Africa, Tanzania, and Zimbabwe. Several other countries continue to build their regulatory and ethics capacities. WHO has also supported the operationalization of the African Medicines Agency, which is a game changer for our continent. And continental capacity is very important and will continue to support. Together with our partners, WHO is committed to supporting the region to develop its regulatory and manufacturing capacities, providing technical expertise and effective coordination. Of course, WHO cannot do it alone. It takes strong partnership, including with Gavi. Since Gavi was founded in 2000, under 5 mortality globally has dropped by more than half, and Africa has been the biggest beneficiary. So I was very encouraged that at Gavi's replenishment in July, donors pledged more than $9 billion to support its work over the next 5 years. In addition, Gavi implementing countries are investing a record $4 billion in their national immunization programs over the next 5 years. We also welcome the launch last year of Gavi's African Vaccine Manufacturing Accelerator and the African Export-Import Bank's pledge of $2 billion to support African health product manufacturing. All of these efforts are aimed at supporting national initiatives to strengthen local production. It's especially important that in Africa we produce medicines and vaccines for diseases that afflict our populations, but we should not always attract investment from companies outside Africa. So I am very pleased to welcome His Excellency the President's initiative to establish a cholera vaccine production facility here in Zambia, in line with his leadership as a global cholera champion. As you all know, global production of cholera vaccines is insufficient, and it's here in Africa that the need for those vaccines is greatest. WHO looks forward to supporting Zambia to make this project a success. Your Excellency, thank you. I think you I have to wait until you maybe recognize, but this is truly an inspirational leadership, and I would like to recognize His Excellency's commitment to this. Your Excellency and colleagues, ministers, the right to health means the right to equitable access to essential medicines, vaccines, and other life-saving products. Local production is about realizing that right. Thank you all for your dedication and commitment to equitable access and a healthier, safer, fairer Africa and fairer world for all people. I thank you.
Tedros, thank you very much indeed for that stirring and visionary speech, and let local production indeed be the watchword. Now, if you've been reading the WHO cooperation strategy for the Republic of Zambia, you will see that Zambia has done a lot to address both communicable and non-communicable diseases, from maternal mortality to HIV/AIDS, and from TB to basic immunization. But there remain challenges, do there not, as President Hichilema observed in his remarks yesterday. Before we hear from His Excellency, the President of the Republic of Zambia, please welcome the Honorable Minister of Health, Dr. Elijah Michima, MP.
Excellency, the President of the Republic of Zambia, Mr. Hakainde Hichilema, Cabinet Ministers, Your Excellencies, heads of mission agencies, senior members of African Union, let me climb on the protocols already established. Distinguished delegates, invited guests, ladies and gentlemen, Your Excellency, Mr. President, it's not my intention to be long. My colleagues from the 47 member countries here want to hear from you after you gave them Bekajonku yesterday. Bekajonku means a peace, respect. They loved it and they cherished it. And Zambia yesterday was elected here as chairperson for the 75th committee here. So we are now in the chair to lead this champion with the rest of our colleagues. Congratulate you, Mr. President, for that. Mr. President, it's a great honor that you found the opportunity to grace today's side event being held on the margins of the 75th session of the World Health Organization Regional Committee for Africa. This side event focuses on advancing the agenda and securing investments and partnerships towards local production of medicine, vaccine, and other health technologies in Africa. This is an agenda that is very important for regional health, security, and economic development. It is a subject that you value highly, demonstrated by your continued leadership and advocacy at various continental national fora on the need for commitment towards local manufacturing. You made a call in this very room in 2023 during the 3rd International Conference on Public Health in Africa for enhanced bilateral partnerships and regional commitment to establish a cholera vaccine manufacturing hub in Africa. And you work as a continent's champion on cholera control has continued to highlight this resolve. Today is another demonstration on your continued dedication to securing partnering and strategizing on investments for this initiative through your gracious acceptance of this invitation to attend this side event. It is now my singular honor and privilege to invite you, Mr. President, to deliver your keynote address and officially open this side event. Mr. President, sir.
Please do take your seats. Thank you very much. Take your seats, please. Let me acknowledge Dr. Tedros, WHO, and all your colleagues in the leadership and specialists that work with yourself, Minister of Health and your colleagues that are present from other countries, and also other ministers from here and other countries. I want to acknowledge my colleagues on the table, other colleagues, Africa CDC, and indeed, obviously, Prof here, Prof Janabi, and my other colleagues. If I may say, just ladies and gentlemen, in the interest of time, I want to start by acknowledging and expressing my on behalf of the people of Zambia, our gratitude once more for deciding to host this conference here. I said it yesterday. I am repeating to deliver emphasis how appreciative we are for a decision such as this one. But I'm equally delighted to address this subject of equitable access to medicines, to vaccines, and new medical technologies, advanced medical technologies, obviously, as has already been touched on, arising from R&D, the importance of research and development, and consequentially, the need for us to continue allocating sufficient resource envelopes around research and development cannot be questioned. That aspect cannot be questioned. And we know the benefits, the value of research and development. If it weren't for that, many more of our people would have been killed by COVID, taken by COVID, just as an example, and others. So I'm very delighted to be part of this group today. I know you are all saying, speakers are saying, no, we're happy the president is here. I must tell you, I'm more delighted that I'm amidst yourselves today. And I want, thank you. I want to sit a little bit after the speeches to listen to your deliberations. So I can benefit. These policies that we implement, they are shaped by yourselves, by discussions such as what went on yesterday and today. So if that's okay for my protocol bosses, so I want to stay a little bit and listen to the conversations because we derive benefits from those. This agenda of equitable access to medicines, to vaccines, is important to all our citizens, not in one jurisdiction, not in one region, but the continent and the world. No one should truly be left behind. I think it's important to emphasize that point. Let me say one or two words. A lot has been said on vaccines. Vaccines, no doubt, have saved millions of lives. Don't we all know that? We do, isn't it? Superstitions around vaccines, narratives that were basically driven to scaremonger families, health systems away from vaccines, only lead to more deaths unnecessarily. And I think acceptability of vaccines that they have saved lives must be universal where we are today. I remember even the COVID vaccine, there were a lot of stories around it. Too many stories. Too many stories. But we know what the COVID vaccine did to reduce mortality. So, in particular, childhood mortality. Just imagine a kid who can't say exactly what they want. They're not yet able to communicate. For them to survive, they depend on us adults to make the right decisions. And so families are important, communities are important. Yes, health ministries are important, nations are important, but the fundamental and primary line of defense, first line of defense, is the family. To make sure that they can take this child to a health facility to receive the necessary vaccinations and to take out away the mystery. I must say, I'm a liberated soul. I'm an African who does not believe in witchcraft. And I want to urge Africans to move away from these beliefs of witchcraft and therefore reduce the utilization of vaccines. I can tell you from the politics, even within our political party, we won elections against those who received a lot of medical support in witchcraft. Even the national elections. Those things take a lot of our brains, time, intellectual gray matter. And we walk away from solutions to save lives, such as vaccines. And indeed, medicines. I know as we sit in this hall, someone is reflecting back in their homes, in their countries, around this subject. So I'm here on behalf of my other leaders to confront this emotional issue. Families, get your children to be vaccinated. Why develop the vaccines? And they're not utilized, yet we know they save lives. So, Zambia has managed to reduce childhood mortality over years up to 70%. 70% as we stand today. I think this is a tremendous achievement. We can do more. We can do more. Now, even when we acknowledge that vaccines save lives, but the COVID-19 pandemic revealed our supply chain weaknesses, serious weaknesses. We touched on that yesterday. No need to repeat that. So we need to also understand that dependence on others, this continent has a habit, very nauseating habit, of always looking to someone to solve our problems. We as leaders, your elected leaders, are saying this must come to an end. We cooperate, but we do not continue to be dependent on other people to solve our problems. There's no way we can operate as an island, as a continent. I'm not saying that, far from it. Cooperation, joint efforts in all areas, essential. But we must take the responsibility to solve our problems. That's a duty that we cannot pass on to somebody. Somebody can only help us, support us, but we must be clear of what we ought to do going forward in this area. Now, if we all agree vaccines are important, numbers don't lie. Colleagues in this room, numbers do not lie. Zambians know this story and numbers and with me. These fellows speaking here, numbers are the best of friends. Numbers don't lie. You can give a good story eloquently, but numbers will expose you, isn't it? Numbers will expose you. Numbers will call the bluff, which you are not able to express in a meeting like this. What am I saying? Africa produces less than 1% of its vaccine needs. How about that? Less than 1% of our vaccine needs are produced here. We're exposed. Seriously exposed, colleagues. We're targeting to reach 60% by 2040. It won't come by us twisting our tongues and saying we want 60% by 2040. We have to work diligently, collaboratively, intelligently in order to reach this 60% target by 2040. I was talking to yesterday, side meeting with some Korean colleagues. Prof. Chilengi organized a meeting for me, a side meeting yesterday. I think they're here in the room who are involved in the vaccines. They're there. And 15 years ago, they were producing very little Korea of their vaccines. They took a decision, set a target. Now you're about number 4. In the world, vaccine production. Where are you? Yes. But they are on 50% now. Tell me, remind me the number you were 15 years ago, low number? 20%. But they took a decision as a country, invested money in research and development, of course, networked with others who have done it, no need to reinvent the wheel. I say this to you people in this hall. There's no need to reinvent the wheel. Let's benchmark, let's learn from others. There they are now, 50%. Impressive, isn't it? I think we should clap for Korea. And I'm glad there are ministers today. WHO, Gavi, Africa CDC. It is this benchmarking I'm talking about. We don't have to take as long as they took. We can actually leapfrog by working with them. And others. And others. So, let's work in a targeted way. Dr. Tedros in this country, when we took public office 4 years ago, I was laughed at by my opponents here, my political opponents, because we started setting targets which the country had never done before. Food production, so much by this year. Copper, 3 million tons by 2031. Everywhere, we're setting targets. And my opponents were saying, this chap thinks that this is the business he used to run. Country doesn't run like that. But today we're moving very quickly to set targets. I'll give you one target we set immediately, we set it up. We inherited the government at the height of COVID. Minister of Health colleagues are here. That's when I appointed Professor Chilangi to be my COVID advisor. And we set targets. We found the COVID vaccination at 5% or less. And we go to 70% within what period? 3 months, 4 months. And it made a huge difference. But my colleagues were saying, Mr. Target man. Away from health, this year, in the history of mining in this country, we will hit 1 million tons of copper. Now you are wondering, why is this fellow saying that? Yesterday I said, healthy is the economy. And if the economy is deliric, you cannot support domestic resource mobilization. Not possible. No matter how much you like to do it, it won't happen. So the economies must function, African economies. They will bring stability in the economy. They will generate treasury income to support domestic resource mobilization, to support our vaccines manufacturing. Anyway, at this point, partners such as Gavi, Vaccine Alliance, WHO, and others should be greatly appreciated for supporting these efforts, including the US $1.2 billion of African Vaccine Manufacturing Accelerator Fund. It is these initiatives that will move us towards that 60%. It is not just meeting like this, chatting, coffee, networking with friends from our school days, university days. It is these specifics that will lead us there. And we, as your elected officials, are aligned to this kind of working. And we will do our part. We cannot do it in isolation. We have to work as one team. Absolutely work as one team. We all do not need to be doing the same thing, but different bits of the jigsaw puzzle. And we'll get there. Let me touch a little bit on medicines and new technologies. I believe the same principles must apply to medicines and new technologies as we've talked around vaccines. Africa has unique advantages. Again, Dr. Tedros, when I came in, everybody was mourning about Zambia being a landlocked country. And I drove a message that I don't want to hear anyone mourning and groaning about Zambia's location. It's an excellent location. It's a land-linked country. It's flip the coin, going to Dar, flying to Dar, just a few hours. To Kinshasa, to Cape Town, to Johannesburg, to any other place around this region. 1 hour, Harare, 40 minutes. This is an excellent location. Zambia is a land-linked country. So we should not mourn that Africa has these negatives. Africa has a lot of pluses, a lot of special advantages. Warm people. Africans are warm. As long as you don't walk straight in their faces and start bullying them. I heard the word respect, Gabi. Thank you very much for those reforms. I listen attentively when people speak. Gabi's reforms under her leadership, our sister's leadership, on how to deal with countries, member countries, towards one agenda. Africans are warm people, and there are many. 1.3 billion people. Certainly, this is an asset. It's a big market. What else? Raw materials. Moving closer to common markets, Africa Free Trade Area. We need to take advantage of economies of scale. We produce vaccines, medicines, connect these two. And I must say, affordable labor, which is youthful, affordable labor. Some countries are old not by development, but age profile. Now they need younger workers. Africa has the energy in our young people, youthful population. Let's take advantage of that. I will not repeat what has already been said about Zambia's initiatives. I'm very grateful that partners have acknowledged our little efforts, but I'm the first one to tell you that we can do better as Zambia. We can do more, but we will do more together with yourselves, with your leadership, with your skills, experiences. As I said, benchmarking. But it's not an issue about Zambia. It's an issue about us all. Health for all. We have a few expectations from this meeting. We want to see concrete commitments and strategies tailored to Africa's needs. Standards, yes. We talked about that. Harmonization, yes. But also recognizing us, Africa's circumstances, situation, conditions. From the business side, I used to tell colleagues, and I'm still doing it now, as one of the 3 African presidents who are tasked by the AU to drive the reform of the global financial architecture. Why am I using this example? It's because Africa is defined as one entity. Yes, it's one entity, but it has components in it. If there is conflict in one part of Africa, we are all rubbished as though we cannot do business in some corners. Even in developed countries, Europe has a war now that has been going on for more than 2 years. But if you look at the risk profiling of Europe, the cost of capital is still low, despite the war going on in Europe. But on our continent, we are given a huge, high risk profiling, increasing the cost of capital. That is discriminatory. Absolutely discriminatory. So we want Africa to be looked at properly. And actually yesterday I talked about conflict and its relationship to health challenges. Effects are similar. So let's look at Africa in the correct context. It has a lot to offer. It's a frontier we can do things. I think yesterday in our side meetings with Korean colleagues again, we said we want research and samples to be taken and processed on the continent as well, so that they're relevant to the conditions and to the slight variations in the genetic stuff. I'm not going the science way, but you have heard my message. So we expect concrete commitments and strategies to address the reasons that we're here. And these should be implemented expeditiously. We don't have time. Every time we're not there on certain things, we lose lives. I want to remind all of us in this room that the health security of the 1.3 billion Africans depends on our actions, individually and collectively. Just remember that. It's not just a conference here. We're not just coming to Zambia for a conference. What we are doing here, you as a participant, we as a group, 1.3 billion people are looking up to us to find solutions to their challenges. As I conclude, we want to thank WHO again. We want to thank Gabi, my dear sister there. Thank you for the tremendous work that you're doing, especially the reforms. We heard the reforms of WHO yesterday from Dr. Tedros. Thank you for that. Reforms are essential. I must say to non-Zambians, this president and government was elected on the backdrop of reforms. And we're injecting reforms. We're not concerned about popularity. No. I know what many politicians worry about. Popularity, popularity. If you don't deliver, there's no question of popularity. You have to deliver. To give you an example, we inherited an economy that was declining at minus 2.8% GDP growth. This year, we are targeting 6% plus growth through reforms. Reforms are essential. So we encourage the reforms going on in WHO, in Gavi, Africa CDC. Reforms, positive ones, meant to address the challenges that we face. There are other partners, lots of them. We appreciate your support as well. Let us turn today's deliberations into action that builds resiliency, equitable health systems for Africa. When we talk about Africa here, we know others are talking about their continents. Remember, many of these communicable diseases do not recognize boundaries and borders. Just remember that. Just remember that. Wasn't there a big argument where COVID-19 started from? Were we spared as Africa? We were not. We talk Africa, but it must be in context. I believe, Dr. Tedros, I said what I wanted to say. Thank you very much for your attention. Most appreciated. Dr. Kaseya asked me to do something else. Many times you think presidents are the bosses. No, they are the servants. We're the chief servants. It is a profound honor for me to launch our Africa Continental Cholera Outbreak Response Plan in my capacity as Global African Union, by the way, SADC Cholera Control Champion. We're launching the Continental Cholera Outbreak Response Plan. Very important, because with so many outbreaks here and there, and sometimes we don't respond correctly, many times late. So there's a plan now. This moment marks a turning point in Africa's fight against a disease that has robbed communities of health, and not just health, dignity, and opportunity. I want to call for leadership and accountability around this issue. I urge my fellow heads of state across the continent to establish presidential task forces on cholera to ensure high-level accountability and coordination. We know it works when we do it properly. So that's a call I make to my colleagues. We emphasize the need for domestic resource allocation. We dealt with that yesterday, and this morning people have talked about it, to show national commitment at a country level. Each country on the continent must show national commitment. You cannot be asking for help when you've done nothing yourselves. We must do things first, then seek help. That is extremely important. And we must recognize that cholera is primarily a water and sanitation challenge. So we call for the Ministries of Water and Sanitation to lead jointly with Ministries of Health. But I'm quick to say that in our country, we know that, yes, the Ministries of Water, Ministries of Health are important, but we also know that the communities where our people live are under a ministry called local government, in our case. Those two must be part of the agenda. Ministries of Finance, because sometimes from my sins of the past, we focus on people similar to us, economic skills, finance skills, but it's important that, as I said yesterday, health is an economic issue. It's a fundamental economic issue. That, Dr. Kaseya, that the Ministries of Health are brought on the table. Sorry, Ministries of Finance, so that the right resource envelopes at the local level can be made available. I do believe that once we do that at national level, led by presidents and ministers, specialists, we will be responding properly to the cholera outbreaks. And a country like us with 8+1 neighbor knows how important to take interest in what's happening on the cholera issues in the next door country, in the border areas. Thank you very much for your attention. Thank you.
Thank you very much indeed, Mr. President. That was a wonderful address.
packed full of vision and inspiration. And you did talk, of course, about this continental cholera emergency preparedness and response plan for Africa 1.0, September 2025 to February 2026. Mr. President. Yeah.
Thank you very much indeed, Mr. President, Honorable Ministers, DG, RD, Chief Executive of Gavi. Thank you very much indeed. We can consider now that the Continental Cholera Emergency Preparedness and Response Plan for Africa 1.0 has been duly launched. Thank you very much indeed. So we're now going to play a game of musical chairs, as it were, because our initial speakers will be leaving the stage, and we're now going to change panels because we're going to talk about the Global Alliance for Vaccines and Immunization, LEAP. I want to thank Professor Jabani, Dr. Nishta, Dr. Saya, Dr. Tedros, Dr. Michima. Thank you very much indeed. And we're going to now change panelists. I want to invite up on stage from Gavi, the Chief Country Delivery Officer, Tabani Maposa. Please come up on stage. And alongside Dr. Maposa, please let us welcome Dr. Sylvia Lutukuta, Minister of Health from Angola, and Dr. Robert Lucien Jean-Claude Kagugu, Minister of Health and Public Hygiene, Burkina Faso. We're going to discuss the Gavi LEAP in a bit more detail. Thank you very much. Yes,
Mr. President, of course, you being the head of state, you are free to leave whenever you want. Of course you are. But you did suggest earlier you wanted to stay a bit longer and listen to some deliberations. Thank you very much. We are delighted that you are remaining with us. And do we have Dr. Sylvia Lutukuta, Minister of Health from Angola? I believe she is here. If not, we will. She's here. Okay. Ah, hello. Thank you, Dr. Lutukuta. Really good to see you again. Thank you very much indeed. Thank you very much indeed. Now we heard Dr. Nishtar talk about the Gavi Leap and why it was so exciting. And Mr. Maposa, Chief Country Delivery Officer of Gavi, we'd like you to take us a little bit deeper, just briefly, into the vision for the Gavi Leap and why it is so relevant to not just the people here on this table, but also the people in the room and across Africa. Please explain why it is such a game changer. You can come here.
Your Excellency, the President has given me the permission to sit down, so I'll go back to my seat. Your Excellency, President of Zambia, President Hichilema, Your Excellencies, Honorable Ministers of Health from the African region, Your Excellency, Dr. John Kaseya, Your Excellency, Professor Janabi, Dr. Tedros, DG WHO, distinguished guests, ladies and gentlemen, all protocols are observed. My role is to go a little bit deeper on the Gavi Leap. I will go deeper, but I will also speak as an African child. One of the beautiful things that we have seen here as the president is coming in is the drums. The drums have a special and important meaning in our traditions and our culture. In the past, they were always used to signal a message to another community in another part of the world. And I use this analogy because for us, in this particular point, a message has come from the countries, a message that has been very clear, that was saying your processes are complicated. They need to be simplified. And so one of the first and most important pieces which Dr. Nishtar spoke to was very much about countries, when they were applying to Gavi, they needed to put 8 or more applications to get money. And I remembered as a child growing up in Zimbabwe, that when my mother would run out of salt, she would go to a neighbor. A generous neighbor, when they give you salt, they give you sufficient until you get to buy your own. When we actually ask people to keep coming with so many applications, it is being like an ungenerous neighbor who wants to hold control of their salt case. And it is very important that Gavi does not act as an ungenerous neighbor, but it actually allows people to come and to get the funds that they need to get and get on with the work that needs to be done. You can imagine that every day when you are cooking your pot, you have to say, oh, I need salt, and then you send a child next door to get salt. That is not good neighborliness. That is not good partnership. And so in the spirit of respect, in the spirit of Ubuntu, in the spirit of being responsive, Gavi says, you will come once and we'll give you the time to spend in your kitchen cooking your meal. And the meal that has to be cooked is, of course, the priorities of the government. You don't get to somebody's house and say, today you are doing vegetables or you are doing meat. You actually give them the salt and they cook what they have got to cook in their house. And so the GovLib, in terms of principle, is about supporting what the countries are prioritizing. We were in Chongwe district and under MP Masebo district, the health facility that we went to, the maternity ward was built by the CDF that came from the government of Zambia. The other wings were built by World Vision. The water was drilled by others. And what we were putting was a solar system. And this is what development looks like. When you buy into the plans of the government and you actually build on top of that. And so the GovLib, in terms of what it brings, is really a commitment to make sure that our interventions are responding to countries. The second piece that is important here is addressing persistent challenges. Dr. Nishta, when she came in, she said, there are challenges that have been happening for the longest of time. Why don't we lean in to some of these challenges? And some of these challenges are around reaching zero-dose children, about data systems, and sustainable financing. And one of the things that we have just instituted is actually deep dives. These deep dives, we look at a country, we reflect on the program, and then we engage with our partners, WHO and UNICEF and the country to say, how can we break and deal with this difficult challenge? The next one is about the use of AI as well. We have been thinking about the role of AI in microplanning and how that can be brought to land into the space of delivering our programs. The Gavi board, for the first time, had a special meeting with the GPEI, which was really focused on saying we cannot finish the agenda of polio without actually working together. It was also the same with the Global Fund, where the boards have met and discussed and said, how do we advance? So one of the things that is important about the GovLib is partnerships. What the president just did in launching the continental cholera response, it calls for a multi-sectoral response. It calls for a multi-sector engagement. And you cannot do that without partnerships. But these partnerships actually begin at a country level. They begin with ministries coordinating, but they also are about us and how we coordinate. 2 days ago, we had a dinner and Dr. Nishta gave an example. The Minister of Health has to deal with 20 partners, sometimes 25 or more, who all come with their little piece. If we are better coordinated, we make it easier for the ministers of health to actually focus on the priorities that need to be done. I am glad that we are talking about the GovLib when we are actually sitting in Lusaka. In the global capitals and everywhere else, the Lusaka agenda is an agenda that is important because it is about really putting countries at the center of what we do through partnerships and bringing others on board. Thank you.
Thank you very much indeed, Chief Country Delivery Officer of Gavi. And as you suggested, countries should note that they are being respected. It's about country ownership. I'm delighted to say we have 2 health ministers who are on the board of Gavi, and one of them is to my immediate right, Sylvia Lutukuta from the Republic of Angola. She is a health minister. Minister, please, can you explain how this change is going to impact you? What do you make of it?
Thank you very much. Mr. President of Republic of Zambia, Excellency DG of WHO, Excellency Regional Director of the WHO, Excellency Director of CDC, Excellency Executive Director of Gavi, Excellency Ministers of Health, and ladies and gentlemen, allow me to express my deep gratitude to WHO Regional Office for Africa and to the Gavi Alliance for organizing this important debate on Gavi Leap and the future of Gavi 6.0 strategy at such a decisive moment when the future of immunization and strengthening of health systems in our countries are being refined. Angola is not alone, as more African countries reach middle income status. They will face the same reality, reduced donor support, while resources remain insufficient. This is why Gavi decision in 6.0 to maintain the eligibility threshold at 2,300 US dollars GNI per capita and sustain engagement with middle income countries is so important. Dear colleagues, we must also recognize that the global health financing landscape is changing and resources are scarce. In this context, strengthening national ownership is not just a principle, but a necessity for sustainability. The Gavi Leap represents a historic opportunity to make countries both on the drivers and the implementers of Gavi investment. It means simpler, more agile grant management that is better aligned with national financial system. It is also means a broader transformation, more efficient secretariat, less bureaucracy, stronger accountability, and smart use of innovation and digital tools. And above all, it means partnership, better alignment with the Global Fund, humanitarian actors, and African institutions. As we prepare for Gavi 6.0, in a resource-constrained world, sustainability must remain at the center of our choices. The new strategy gives us hope by slowing the pace of co-financing increase, providing flexibility for fragile and humanitarian settings, and introducing catalytic support to sustain programs. Thank you very much.
Thank you very much indeed, Dr. Lutukuta. And now we will hear from West Africa, from Burkina Faso, the Minister of Health and Public Hygiene, Dr. Robert Lucien Jean-Claude Kagougou. Et, Monsieur le Ministre, vous allez parler en français ou en anglais? OK, mais assis, s'il vous plaît. Voilà. So he will speak in French. So those of you who are not comfortable in French, then obviously you put your headphones on. Et ceux qui parlent français, bon, il ne faut pas mettre vos casquettes.
Excellence Dr. Hakainde Hichilema, président de la République de Zambie, Dr. Tedros Ghebreyesus, directeur général de l'OMS, professeur Yacoub Janabi, directeur régional de l'OMS pour l'Afrique, chers homologues ministres de la Santé, distingués délégués, mesdames et messieurs. C'est un réel honneur pour moi de prendre la parole aujourd'hui devant ce parterre que vous constituez au nom de ma collègue Dr Sylvia Lutukuta, nous qui représentons la circonscription Afrique francophone et lusophone au Conseil d'administration de Gavi, pour faire part de quelques remarques. Pour nous, ministre de la Santé, le principe de Gavi-Lip vient à point nommé. Il met les pays au cœur de la décision, des actions. Pour nous, Gavi-Lip est tout simplement indispensable. Et nous demandons à Gavi et à nos partenaires d'aller dans ce sens depuis plusieurs années. D'aller vers un financement qui soit véritablement aligné sur nos priorités nationales. D'aller vers des procédures plus simplifiées et qui s'alignent sur les procédures des pays. D'être beaucoup plus flexible dans l'utilisation des ressources lorsqu'il arrive des chocs. Et enfin, d'aller vers une véritable redevabilité des partenaires envers nos pays. Gavi-Lip est une réponse à cet appel. Et comme l'agenda de Lusaka, Gavi-Lip veut donner aux pays davantage de pouvoir de décision, simplifier les processus encore une fois, s'assurer que les partenaires s'alignent véritablement sur nos priorités. C'est la voie vers la souveraineté réelle. Son Excellence, Monsieur le Président de la République, en parlait tout à l'heure. Vers une souveraineté réelle où les gouvernements fixent le cap, où les partenaires accompagnent et où les citoyens en tirent tous les bénéfices. En tant que vos représentants, Dr Sylvia et moi-même, soutenons pleinement cette transformation. Mais nous allons plus loin. Nous utilisons ce tournant pour plaider en faveur d'une représentation plus forte de l'Afrique dans la gouvernance de Gavi. Excellence, l'Afrique concentre près de 75% des investissements de Gavi. Pourtant, sur 27 sièges au conseil d'administration, nous n'en occupons que 2. Vous voyez donc comment notre voix peut être diluée. C'est pourquoi, avec les autres représentants pays, nous demandons un renforcement de la présence africaine au conseil d'administration de Gavi. Un siège supplémentaire pour chacune des 2 circonscriptions africaines, mais aussi un siège officiel pour Africa CDC. Excellence, le LIP est une occasion.
Your Excellencies, the Gavi Lip is an opportunity to place countries at the center of things, but that also requires a form of responsibility from us. This year, if this year has taught us anything, is that sovereignty should not remain a slogan. We should move our countries out of help, out of aid, as the President mentioned. We can do it by mobilizing greater domestic resources. And I'd like to take this opportunity to recognize the leadership of His Excellency, the President of the Republic of Zambia, for the 12% of the national budget allocated to health in Zambia. Mr. President, I must say I'm very happy to say that your brother, Captain Ibrahim Traore, head of state of my country, has also allocated 12% of the national budget to health in spite of the difficult financial situation we are facing. We all signed the Addis Declaration on Vaccination or Immunization, and we need to do our bit. We need to trust our own technical capacities and to call on international experts only when it is necessary to do so. Because over 40 years after Alma Ata, we cannot continue to be dependent. To conclude, I would say that the Gavi Leap affords us the opportunity,
mais aussi d'incarner nous-mêmes la souveraineté.
but also to show
cette opportunité, l'Afrique non seulement préservera ses acquis en matière de vaccination, mais elle démontrera aussi qu'elle est prête à jouer un rôle moteur dans l'avenir de la santé mondiale. Je vous remercie.
Monsieur le ministre, merci beaucoup pour votre allocation. Thank you very much, Minister Jean-Claude Kagougou, Minister of Health and Public Hygiene, Burkina Faso. And with that, we are going to change panelists. Thank you very much to Honourable Minister Lutukuta as well. Thank you very much to Gavi also, to Tabani Maposa. Thank you very much indeed. We're going to move this on now as we change our panelists. Thank you very much. I think Mr. President is also going to be on the move. Thank you very much for giving us so much of your time. It underlines your commitment. Thank you very much indeed. Mr. President, one more time, thank you very much. It's great that you came here and spent some more time with us. Delighted. We know that the shoulder is to the wheel. Lots of heft coming from Zambia here. You champion on cholera. Thank you very much. The presidential party is leaving, and I invite you now to resume your seats for our final session. And this is on generating sustainable health, environmental, and economic benefits of a biotechnology sector in Africa through a life cycle ecosystem approach. We have the Minister of Health from South Africa, Dr. Pakishe Moseledi. We have the Minister of Health and Social Action from Senegal, Dr. Ibrahim Assi. We have the Director General of the African Medicines Agency, Dr. Delesi Bibi Dapo. We have the Deputy Executive Director of UNITAID, Dr. Tenu Pavia, and the Director General of the IVI, Dr. Jerome H. Kim. So we're just reassembling the table, and we will invite our panelists to come up on stage. Thank you very much. And we're just going to put you and assign you a seating plan. Unitate is here. IVI. No, sir. Please resume your seats. Thank you very much indeed. It's going to be a very interesting session. We've talked a lot about biotech, about producing here in Africa at scale and sustainably. The question is, how do we do this? Thank you very much. You can have your attention. If you could close those doors, that'd be really helpful. Thank you very much. I'm glad to see many of you have stayed. It's a really, really important session. I'm delighted that our partners are here in full effect. Thank you very much. A bit of a gap in between you, but we can handle that. Thank you. Right. We're going to start off with Dr. Moseledi, because South Africa has made really remarkable progress in the end-to-end manufacturing of vaccines, medicines, diagnostics, and other health products. And we know about your thriving ecosystem. It's been going for some years, and we want others to do the same. The question, Dr. Moseledi, is how do partnerships across different sectors influence your progress in end-to-end manufacturing of vaccines, medicines, and diagnostics in South Africa? What are the lessons? Shh. Thank you. From the seated position, yes. I see. Yes.
So Dr. Musa, yeah, please speak from your seat. And we want to know how these partnerships, because as we were talking about, across different sectors, have influenced your progress in the end-to-end manufacturing of vaccines, medicines, and diagnostics in South Africa, because there may be lessons for others to learn.
Well, Excellencies, delegates, and guests, thank you very much. I think biotechnology is more than a health solution to Africa. It's a foundation for building a modern bioeconomy. Across the world, biotech is shaping new societies to health challenges, produce food, manage water, and create new industries. Biotechnology should be developed not in fragments, but as part of a life cycle ecosystem. That means thinking about entire journey, discovery science, translational research, clinical trials, manufacturing, regulation, market access, and even how we manage waste and recycle resources. Now, coming to South Africa, South Africa can confidently say that biotechnology has the potential to revolutionize our healthcare system and contribute significantly to the country's economic growth. By leveraging advanced biological tools and techniques, such as genomics, proteomics, and bioinformatics, we can develop innovative solutions to address pressing health challenges in Africa. We are making significant strides in biotechnology with notable advancement in the following areas, and I'll mention only 4 of them: genomics and proteomics. We are utilizing cutting-edge technologies like next-generation sequencing and proteomics to better understand diseases and develop targeted treatments. Number 2, vaccine development. Our partnership with Afrigen BioVac, which is co-owned by the state and private sector, and the Bill and Melinda Gates Foundation, has enabled the development of messenger RNA vaccines for infectious diseases like tuberculosis, malaria, and vaccines for pandemic preparedness, such as Rift Valley fever, one of the global priority pathogens, as well as vaccines to address global antimicrobial burden of diseases such as gonorrhea, which is disappointingly resurfacing. Number 3, indigenous knowledge systems. We are harnessing traditional wisdom to innovate production in health, beauty, and nutrition, promoting cultural heritage and economic growth. But we do have our challenges, I must say. So while we celebrate the progress, the following challenges must be watched for. That include regulatory frameworks, funding, and infrastructure. But we believe by addressing these challenges and fostering collaboration, investment, and innovation, we can unlock the full potential of biotechnology in Africa and create a brighter future for our people. Lastly, South Africa also supports Gavi, Africa Vaccine Manufacturing Accelerator, or AVMA, objectives to strengthen localizing of vaccine manufacturing. Thank you very much.
Thank you very much. Thank you. What about the position in Senegal? This is an interesting one because the Institut Pasteur de Dakar is the only Africa-based pre-qualified manufacturer of the yellow fever vaccine supplying the UN. So my question to Dr. C is, what strategic approach is needed to make vaccines, medicine, and diagnostics more easily available and indeed accessible to those who need them in other parts of the continent? Dr. C.
Merci beaucoup de m'avoir donné la
Thank you very much for giving me the floor. It's a very interesting panel discussion, I think. But before I start, this is the English channel.
That takes this. Okay.
Apologies for that, says the speaker. But before I respond to your question in full, I would like to make a few remarks. As for Senegal, we have a long history of vaccine production. It goes back to 1930. That is the Institut Pasteur in Senegal. And to date, the Institute has produced over 100 million vaccines against yellow fever, which has been distributed not only in Senegal, but across the world. And Senegal also has a specific regulatory framework which enables us to produce vaccines and manufacture them according to specific country norms. We also have what we call AFCFTA, which is the free trade zone across our continent, which ensures that member states and signatories can benefit from it. This means that we have the largest free trade area in Africa. And we also need to remember the demographics. We have 5 billion people, and we have a very large market. And that is an important fact to keep in mind. So that's just for context. I think you need to hear this data to help you understand where Senegal stands in terms of its public policies. Well, we have a goal of developing our country in various ways with the date of 2050 being particularly important. In line with our president's vision, pharmaceutical sovereignty has been an absolute priority, and it emphasizes local manufacturing of vaccines and of medicines. It is in this context that we have the Madiba project. It is manufacturing in Africa for disease and immunity, and we are very much involved in this project because it is focused on increasing pharmaceutical sovereignty. The goal is to produce around 3 million doses, if not more, per year, targeting yellow fever and malaria. Now, when it comes to a very important issue in my mind, it's this. If Africa really wants to take advantage of the economic benefits of local manufacturing of vaccines, what we have to do is develop a joint vision regarding vaccine sovereignty. So we need to have a mutual approach. It will ensure that African partners can create localized hubs. In this way, we won't be duplicating initiatives. In this way, the benefits will be numerous, and those that will benefit, that which will benefit will be public health. And I'm thinking about transnational epidemiological surveillance, joint responses to pandemics, research regarding diagnostics and treatment of certain pathogens, pathogens that is. But we need health diplomacy, cooperation, and appropriate policies. And these are the points that I wanted to share with you regarding Senegal's experience when it comes to vaccine sovereignty. Thank you.
To the Minister of Senegal, thank you very much indeed. We've heard a lot of talk of the African Medicines Agency. This promise of a common market for the continent requires a competent regulatory environment agency that is science-based, pragmatic, focused on results for Africa. So let me ask Dr. Darwin, which partnerships do you see as essential for supporting end-to-end production of safe, effective, affordable, and high-quality vaccines, medicines, and other
health products? Because this is crucial, isn't it?
Yes, it is. Thank you very much for the opportunity. We've talked a lot about vaccine manufacture. We've talked about having domestic manufacturing in Africa. But what I'd like to say is that you need, first of all, a strong regulator, and not just a strong regulator, you need an enabling regulator. Regulators are sometimes thought of as being barriers to access, but an enabling regulator is what makes sure that an investment into vaccine manufacture thrives and happens. Now, regulators cannot do it alone, and local manufacture of products is not sustainable unless manufacturing, before manufacturing, we have research and development, we have R&D, we have evaluation and availability of the product on the market, we have market access. The manufactured products have to be accepted. And then we need financial and political will. The African Medicines Agency is the continental regulator that has the role of knitting all this together. Now, the AMA cannot work by itself, and we need strong regulatory partnerships. And His Excellency, the President, actually said that there's no point reinventing the wheel. And so we have partnerships like the WHO, which is the agency that we would all look forward to benchmarking us to ensure that the African Medicines Agency is working along the strict, stringent regulatory standards that it should. We also have the European Medicines Agency, and those are partnerships that the African Medicines Agency will have to look to partnering with. We have AWUDA NEPAD that would support us with the infrastructure and the regulatory support resources that we need. They have, in Africa, we have what we call regulatory centers that are of excellence. And a lot of countries have these regional centers of regulatory excellence in place. And we would also need advocacy. Today, I met a group of students from the International Federation of Pharmacists, young students and young pharmacists who are looking to work strongly, and they are considered also as partners. I remember during COVID, some vaccines were manufactured in South Africa that ended up not being used. That was whether it was a question of acceptability of the products, whether more advocacy should have been done. But if you ensure that if Africa manufactures or Africa produces medicines that are not going to be acceptable, then there's no point producing these medicines at all. And therefore, we will ensure that whatever Africa produces is done in partnership with these agencies that I've mentioned, and that we will use harmonized, standardized processes to do these, such that we can build trust. At the end of the day, the reason why we like certain medications or vaccines or medical products is because of the trust that we have in it. And if we don't have partnerships, and if we don't build strong partnerships, there will not be trust. Over the years, we will, African Medicines Agency will ensure that it will use the well-trusted, it will have a well-trusted system. It will use the laboratory networks that we are building up in Africa. And we will ensure that we can even eventually pre-qualify our own products and make them available to the continent and even for export, rather than always relying on external systems. We can't always do that. And the third partnership that I think that we would be looking at is to partner with trade. If you manufacture a vaccine and it never gets to the market or never gets to the people that need it, then there's no point. So we have the Africa Continental Free Trade Area and all the regional communities that will ensure that once a vaccine or a medical product is manufactured, it can move quickly across the border to meet the needs of the 1.4 billion people that we have on the continent. And therefore, I would say that the African Medicines Agency will be the backbone, the regulatory backbone and pathway towards access and also towards sovereignty that we need for Africa tomorrow. Thank you very much.
Thank you very much indeed, Dr. Darko. Really important to hear that. Okay, let's move to the Deputy Executive Director of UNITAID, Dr. Abafia. Well, access to innovative and affordable health products, as we've heard today, is central to health security, sovereignty, and economic prosperity. So let's look at your experience. Given UNITAID's significant investment in building end-to-end market-driven, very important there, manufacturing of priority medicines, therapeutics, and diagnostics across Africa. Here's the question. What should governments, regional bodies, and private sector organizations do? What role should they have to ensure these efforts not only strengthen local production, but also deliver long-term resilience. This has to last for decades.
Thank you very much, Mr. Moderator, for that question, and good afternoon, Excellencies, colleagues and friends. So we at UNITAID are driven, our North Star is the goal of equitable access and universal health coverage. And to that end, we believe that domestic and regional manufacturing is an important pathway, one of the key pathways to realizing that goal. We also know that if done correctly, domestic and regional manufacturing have additional benefits in terms of economic growth, prosperity, and also strengthening one's industrial base. There are also very well documented examples of how governments have used manufacturing to strengthen economic cooperation and development. But what we really believe is that it requires collective and coordinated work together for us to be successful. So on the topic of working together, I want to leave you with 3 points. The first one is that for us at UNITAID, a key element of being able to manufacture sustainably is the creation and the maintenance of the market. And that's why we actually put more emphasis on regional manufacturing than local or domestic. Let's take COVID as an example. Rightly so, a lot of attention was paid to vaccine inequity, but actually there was a lack of access to many other important health tools. For example, rapid diagnostic tests in many parts of the world were not available. So we partnered with a South Korean rapid diagnostic test firm and supported a technology transfer agreement between BioNote in South Korea and the Institut Pasteur in Dakar, which then allowed them to domestically produce and also to supply neighboring countries. And more importantly, after COVID ended, Institut Pasteur was able to pivot and to start producing rapid diagnostic tests for HIV and for measles. And that's important because this is where the market is, this is where the needs are, these are the diseases that are prevalent. And in doing so, there's a sustainability element there. Now, of course, the price and the quality are extremely important to be maintained, but so too is the principle, and that word was used earlier this afternoon, of Ubuntu. I succeed because we succeed. Oh, we succeed. I am because we are. And it's about getting that commitment from governments, from regional bodies, and the private sector that we're also going to support regional manufacturers. My next point is also about sustainability. And the point has been made by a number of speakers that we should avoid the temptation to have a very big ambition, and sometimes we should start from where we are with what we have and build from there. There's some important examples of that being successful in the East Africa region, where UNITAID is supporting manufacturing of medical oxygen, which is an important therapeutic used to treat about 20 or so health conditions, but also antimalarials, because by supporting these manufacturers, we're then again able to create a sustainable economy of scale that we can build on. My third point is that sometimes what is seen to be a disadvantage can actually be an opportunity. And we've heard the word leapfrog used a couple of times today. A unique feature of our work at UNITAID in regional manufacturing is that we're placing an emphasis on climate smart manufacturing. And this includes greener approaches to API production. The Council of Scientific and Industrial Research in South Africa recently launched Future Pharma Facility. This is designed to manufacture small molecules as well as biologic APIs. And these are not just cost effective, but they're also climate smart. And we think that there's an opportunity there for African manufacturers to adopt green technology and actually position themselves, and for this to be seen as a comparative advantage. But it requires us to put environmental standards in our procurement rules and also to provide incentives to manufacturers to do this. So we think that this actually could position Africa's regional manufacturing ecosystem as a leader in sustainable production.
So we've heard a lot today about this being a turning point, and we at UNITAID very much agree, and we stand ready to contribute to strengthen African-led ecosystems that deliver not just health, but also economic and environmental objectives. Thank you.
Thank you very much indeed, Dr. Fabia. Really exciting. And this is a kind of partnership and long-term thinking that is required. You already flashed in the pan. Thank you very much indeed. Let's move to the Director General of the International Vaccines Institute, Dr. Kim. A bit of context. We keep hearing about this ambition, this goal of producing 60% of vaccines in Africa, so by Africa, by 2040. And the IVI is going to contribute to this quota, to strengthening vaccine capacity building on this African continent. So the question then, what concrete steps are needed to ensure that investments in manufacturing are matched by African-led R&D? We heard about R&D earlier, regulatory strengthening, and also sustainable partnerships, because we want vaccine self-sufficiency to deliver long-term health sovereignty and pandemic preparedness. So how?
Right. Thank you very much for that very interesting question. It is a complicated one, but one that IVI, which many people don't know about us, we're a small international organization, 56 member countries and the World Health Organization. Zambia is actually the most recent member, approved yesterday by the board. But we discover, develop, and deliver safe, effective, and affordable vaccines and empower global health equity and vaccine security. So when we hear about the need for simplified oral cholera vaccine, that is an IVI vaccine, developed in our laboratories, technology transferred to companies around the world, no licensing fee, no IP. Why? Because this is our commitment to technology and technology transfer and the work that we all do in global health. So IVI has done 14 technology transfers of 6 different vaccines. And I think one of the most interesting ones is a technology transfer to BioVac in South Africa. The final funding for phase 3 has been received. And if the BioVac manufactured oral cholera vaccine is equivalent or not inferior to the U Biologics, the Korean version, then it will be the first new introduction of an African manufactured vaccine since the yellow fever vaccine at IPD, which would be an important first step. But again, just an example of a commitment to an end-to-end process that doesn't just manufacture a vaccine, but builds the capabilities across the value chain to enable manufacturing. So I was going to talk about that, but in the beginning of this year, there were big changes in global health, and what would just be another story of failure? Yeah, just another story of something that we all thought was going to happen that isn't going to happen. We had put together with about 30 other African collaborators a proposal for African-led vaccine research and development. It was $100 million, and it disappeared when USAID disappeared. But that wasn't the end of the story, because our collaborators and the companies that we worked with on African-led vaccine manufacturing said, we need to find $100 million. And that was the question. And I think this will get to the rest of your question. How do we approach this? And we heard a lot of stories today about how countries and organizations like Africa CDC and the World Health Organization are grappling with this and are beginning to, the leadership there is beginning to turn crisis into opportunity. And that really is the key here. So Achieve starts with an announcement, and Professor Drew Weissman from the University of Pennsylvania will be on in the next session to actually make the formal announcement. It starts with a pledge of $25 million and the intellectual property that is developed by African scientists, with the ability to train them to develop vaccines and drugs. So it starts with that, but it doesn't end with that. Why? Because one of the lessons that we learned during the crisis earlier in the year was that there should be leadership and ownership of this effort. And how do we get that? So we've been working with different partners, different African countries, to secure commitments for African contribution to this, to create a matching fund to what was originally contributed by Dr. Weissman. And at this point, 3 African countries, you heard President Hichilema's commitment, Nigeria, Rwanda. There's another country that we were in late stage discussions with. We are almost at 25 million. And with that, African leaders will go to other partners and say, we have our commitment. We want you to match it. And it's that way that we build the pieces that will fund research and development for vaccines and drugs funded in part by African countries in collaboration with others. And now we'll have African political leadership, African scientific leadership, because this is an effort that it will be run by African scientists. We will have African ownership from the initial stake, but also the commitment from Penn for intellectual property. So owning the IP, owning the data, owning the samples, all of these pieces become a part of ownership of research and development. So the entire end-to-end chain, as products are coming out, will go to regulatory approval, will be manufactured in Africa because that is a part of the commitment to the African companies. Afrigen was one of the companies really pushing us very hard to try and come up with a way to find the funding for this. And really the development of this end-to-end effort is really a commitment by African countries to leadership in this effort to create not a factory, because the factories themselves don't manufacture vaccines. It's having the people, the human resource skills that really start in the laboratory and go all the way to approval and implementation. And ownership of that entire effort is what Achieve 2.0 is about.
Speak about end-to-end.
End-to-end.
Fantastic. So, well, you mentioned Dr. Drew Weissman's name a couple of times. I believe he's on the line and standing by to make an announcement. So this is very exciting. Can we have Dr. Drew? There we are, Dr. Drew Weissman. Hello to you, sir. Please, we are waiting with bated breath to hear what you have to announce.
Thank you very much. So I'm highly honored to be here. I apologize I'm not in person. Thank you for all of the excellencies, health ministers, etc. My commitment to the development of end-to-end RNA vaccine and therapeutic development throughout Africa, we will give $50 million to support the program. We will also help train, help develop, help set up the entire ecosystem for mRNA vaccines and therapeutics for anybody, any country, any region, any academic institution that wants this technology. We will also give all of the IP that we have developed throughout Africa. I've talked with a bunch of friends and collaborators throughout the world. They will also work to commit their IP for similar no-cost licensing. This, I believe, will help build the entire infrastructure needed to develop RNA vaccines and therapeutics that are needed by populations throughout Africa and throughout the world. Thank you.
That's wonderful, Dr. Weissman. Thank you very much. 50 million and plenty of collaboration, end to end. That is wonderful. Thank you very much indeed for joining us for that. We also have an announcement on behalf of Unitaid. Do we have Robert Matiru, Director of Programs? Because we want to hear about, support for capacity building for local manufacturing of medical diagnostics and therapeutics, Unitaid. Dr. Matiru, thank you very much indeed. Okay, I'll see you. Go for it.
Great, thank you. As they up the slide, Honorable Ministers, Excellencies, ladies and gentlemen, distinguished guests. As you heard from His Excellency the President, numbers don't lie. So Unitaid is also pleased to announce today a $50 million grant. This is not a pledge. Our executive board has approved this financing, and we signed grant agreements last month with the grant implementers who will work with Unitaid to deploy this investment. The program is called Regional Manufacturing for Equitable Access. It's a flagship program that will focus on Africa. And I want to emphasize that it's a foundational investment. Unitaid is a catalytic investor, meaning we invest our grant funds and then use them to leverage and crowd in additional financing
several factors this amount. So it is our aspiration that with these investments, we can work with national governments in Africa, with continental development banks, such as Afrexim Bank and the African Development Bank, global financing institutions, such as the IFC and others, to bring in critical financial instruments alongside our grant funding for manufacturers in Africa, in all regions, but also critical aspects of manufacturing that go beyond the capital investment and infrastructure and human capital that are needed. And I've just listed a few of those here that are included in this flagship program. We will focus on medicines, starting with oral solids and injectables. We will focus on diagnostics, starting with RDTs, but also molecular tests as well. We won't only look at finished product, we'll also aim to support active pharmaceutical ingredient development in Africa, which is quite in its infancy today, and also raw materials and other critical starting materials for products, because much of the cost and the quality elements are built in and baked in from there as you move on to the finished products. And that's the most resilient and sustainable way to do it. Importantly, though, I want to highlight to the ministers and their delegations in this room that UNITAID will also work to build clinical research and clinical trial capabilities. And you heard just how important those are from the earlier panelists and speakers, but also IVI just most recently. The ecosystem is key. And I'm very glad that the newly appointed Director General of the African Medicines Agency made this point. And UNITAID will do our part to support further regulatory harmonization and support AMA to do that, including through our partners, the WHO, and working with donors such as the Gates Foundation, but also procurement. You heard from the Africa CDC DG, the criticality of the APPM continentally, but we're also working with the regional economic communities to support their procurement efforts in regional blocks. I talked about blended financing. This will be a crucial component of this program, as well as market shaping, as you heard from our Deputy Executive Director. But also, as you also heard, the opportunity to put African manufacturers as market leaders in green production, and with that, a comparative advantage that will even help them to compete with peers in the global north and in high-income countries. I'm going to conclude this announcement by acknowledging the donor support that has enabled this. This investment now brings close to 100 million UNITAID's investments in regional production over the last 3 to 4 years, starting with our investments with IPD during COVID and others. So we thank our core donors, in particular France, the United Kingdom, the Gates Foundation, and several others. We thank the European Commission. We thank also the Republic of Korea, as well as Japan and Canada, and also our collaborating partners, Africa CDC, ARDENAPAD, WHO, PATH and USB, which will lead the implementation of this flagship investment with other partners, but also national governments. And several governments helped us develop the strategy that led to this investment, but we've cited here PVAC in Nigeria and the government of South Africa, but also others who helped stress test the approach we were taking to make sure it's responsive to African needs. Thank you so much.
Thank you very much indeed, Robert, Material Director of Programs at UNITAID. Right, we've been through quite a lot, haven't we? We've heard some very, very interesting approaches to the challenges that confront us as a continent and as a group of people who are interested in health for the 1.3 billion Africans. I'm delighted to say we've been joined on the stage by Dr. Benito Impuma, who I invite to make some closing remarks. Dr. Benito.
For those of you who don't know him, I think everybody knows who you are. You are the director of the Non-Communicable Diseases Cluster at the WHO. You can do it from your sedentary position.
So thank you very much. I would like on behalf of Dr. Tedros and our regional director, Dr. Janabi, to once again express our sincere thanks for all the panelists. We very much appreciate the presence of Dr. Sanya. I guess this is your first regional committee, and we are very honored for your participation in this committee, despite of your busy schedule. I would like also to really acknowledge the presence of AMA, IVI, UNITAID, and all our ministers of health for accepting to attend this special side event. I think in terms of concrete results, so one of the things which was highlighted here was numbers do not lie. we all acknowledge the support provided by Gavi in this region. I was looking at some of the numbers. If you just look at WHO, Gavi has been supporting more than 150 staff, WHO staff, who are, of course, closely working with our member states to advance the immunization agenda. Now, the two announcements which were just made are really concrete outcome of this special event. And we strongly believe that working closely with our member states, we'll be able to address some of the challenges that we are facing in this continent. So with that, thank you again for taking part in this special event. We will make sure that the report is made available as soon as possible, and some of the key recommendations which will emerge from this, side event will be implemented by member state, WHO, and all partners who attended this event. Once again, many thanks for your participation. Thank you.
Thank you very much, Dr. Benito Impuma. Thank you very much indeed. That concludes this particular session. Been very dynamic, very energetic. And I think it remains for me to say, we want a group photo of all our principals here. Who is going to arrange that group photo? Do we have sir, are you going to? Yeah, no, well, let's do a group photo of you first, and then we'll have a wider group, first of all. You can get in front or behind the table. Whichever looks better. In front of the table. Okay, in front of the table. Let's have our group photo. All our participants, let's get this group photo done. Hello. Is that tailoring? Thank you very much. Just to remind you, the next phase of this RC, the next session will commence immediately we have left the stage. Thank you very much indeed. Very good to see you again. How are you? How are you? Fantastic. I see some of our other colleagues from Gavi and our other participants are coming up on stage to take their pictures. Why? One. Thank you, everybody. Thank you. That concludes our wonderful session. I hope we now understand how to strengthen an ecosystem approach to end-to-end local productions
of Medicines, Vaccines, and Other Health Technologies. Benito, always here. Yeah, thank you. Please bear with us. We're just making preparations for the next session of this RC, which will take place as soon as we manage to arrange the table and get our principal speakers back up on stage. Thank you very much indeed for your indulgence. As we wind down this session, this has been a long but very exciting and energetic session, one full of game changers. We had some tremendous speakers from our principal partners, including Unitaid, Gavi, IVI, AMA, Africa CDC, and our member states, of course, as well. So things really are happening, and I'm delighted you stayed the course. Please stay where you are. The next session in this RC will commence in a few minutes' time. Thank you very much.
Hello.
Sure. The ushers.
Just one. Please. Ah, là, c'est bon.
Devemos aproveitar esta oportunidade para demonstrar a parceria de projeto. Pronto, isto concluiu a ministra. Vamos lá.
Essa capacidade.
Faz aí. No início. Espera aí. Vai saber como é que temos que aprender a fazer. Essa é a mesma coisa. Não, mas elas também fazem assim. Não, elas também fazem assim. Foi comunicar a empresa, mas tens que pôr sempre. Não é importante.
Ela já fez sua política, tem pressão para fazer de
não faz fazer. Isto é o quê? Isto é um comunicado de imprensa. Então.
Allô? Est-ce que la traduction est en place?
Interpreters, are you ready? Can you kindly confirm?
Yes, we are. Interpreters are ready.
Bonjour, mesdames et messieurs, honorables ministres.
Ladies and gentlemen, honorable ministers, dear colleagues, we're going to agenda item 9, and the last country that spoke was Congo. We have a time constraint. We would like you to be very fast. We would like to request you to speak less than 2 minutes. We'll give the floor to Niger, and after that, we'll invite Nigeria.
Merci, Monsieur le Président.
Thank you, Chairperson.
Monsieur le Président, Mesdames et Messieurs les ministres, chers délégués.
Chairperson, honorable ministers, distinguished delegates, we'd like to thank the Secretariat for including the point on the regional strategy to strengthen rehabilitation in health systems 2025 to 2035. Their needs for rehabilitation has become an issue of great concern. Niger has undertaken to including rehabilitation in its social and development plan, and some regulatory and legal texts have included rehabilitation. There's an existence of rehabilitation department in the Ministry of Health. And then we've also included this in maternity care and free care for children aged below 5 and for disabled persons. The support from TFPs and personnel in hospitals as well as therapy are challenges that we need to look at. There's a lack of a strategy for rehabilitation. There's a lack of infrastructure, lack of human resources, and the procurement of technical aids. In conclusion, Niger supports the regional strategy to strengthen rehabilitation in health systems for 2025 to 2035 and encourages other member states to adopt it. We encourage the WHO to conduct strong advocacy among partners in support of finances to implement this strategy. Thank you. I'll now hand over to Nigeria and then Madagascar.
Thank you very much, Chair. Nigeria commends the Secretariat for developing the regional strategy to strengthen rehabilitation in health systems 2025 to 2035. Rehabilitation is an essential component of universal health coverage, yet it has long remained under-prioritized in many health systems. The proposed strategy provides a timely framework for action, ensuring that rehabilitation services are integrated across all levels of care, from community to tertiary facilities. In Nigeria, we recognize the increasing demand for rehabilitation services driven by non-communicable diseases, injuries, congenital conditions, aging population, and the long-term effects of infectious diseases. We are strengthening capacity by expanding training for rehabilitation professionals, scaling up physiotherapy and occupational therapy services within primary health care, and improving access to assistive technologies. Worthy of mention is the rollout of comprehensive support and rehabilitation services for women with obstetric fistula in Nigeria. Nevertheless, and despite all of this, significant challenges remain. Nigeria therefore welcomes this strategy as a guiding framework to expand equitable access to rehabilitation services, particularly in underserved communities, strengthen human resources through education, training, and retention of rehabilitation professionals, mobilize sustainable financing to ensure affordability of services and assistive products, foster innovation, digital solutions, and regional collaboration to close service gaps. Nigeria reaffirms its commitment to implementing this strategy in alignment with our national health priority and the pursuit of universal health coverage. We fully support the adoption of this strategy and lend our voice to call upon all partners and member states to work together to accelerate investments, build capacity, and ensure that rehabilitation is no longer a neglected aspect of our health system. Thank you very much, Chair.
Madagascar.
Madagascar, thereafter Burkina Faso. Thank you, Mr. Chair, for the opportunity to take the floor. Mr. Chair, once again, Madagascar would like to congratulate the Secretariat on the efforts made regarding rehabilitation in health systems. Madagascar shares this vision. It is true that rehabilitation should be an important part of our health systems. And we shouldn't limit ourselves to cure only. So we need to focus on prevention as well. Now, we need to look after persons with disabilities. We need to ensure that they have access to care and that they can take part fully in everyday life. And this is the spirit in which this recommendation has been made. And we included this idea in our own roadmap. Madagascar has made several efforts in this line when it comes to rehabilitation. We have integrated decentralization into rehabilitation services in our existing healthcare structures. We have done this from clinics to major hospitals. Our goal is to bring the services closer to everyone, especially in rural areas. Training healthcare workers in physiotherapy and OT is very important, and we focused on this as well. We've also raised awareness amongst community leaders so that they can take note of what the needs of their community are. And we have had to face many challenges here as well. And multi-sectoral collaboration is moving forward. Here, we've collaborated with the Ministry of Education. And the goal has been to ensure that the continuity of care continues, especially for the benefit of persons with disabilities. Looking at the next 10 years, we have very ambitious goals here, such as strengthening infrastructure and ensuring that each healthcare unit is able to provide rehabilitation services, and in reference hospitals too. We also want to involve more technology in rehabilitation. This can be done via video link as well for rural areas. And when it comes to financing, we have many partners, especially CSOs. And we are grateful for these investments. And Madagascar recommits to improving the availability of rehabilitation to people. Thank you very much. Now Burkina Faso, thereafter Zimbabwe. Thank you very much, Chair. Burkina Faso congratulates the Secretariat for the quality of its report, and we welcome this initiative 2025-2035. The goal is to ensure that we integrate rehabilitation in all healthcare services, and we are very satisfied with the quality of this report. And looking at Burkina Faso's situation, we have a national health development plan which integrates the aspect of rehabilitation. We have done various different activities to improve rehabilitation and its access. For example, we have benefited from WHO support. And thanks to this support, Burkina Faso has included rehabilitation services in all hospitals in the country, and we are now moving forward in this area. And when it comes to integration, national data is used for indicators, and we're also looking at building capacity for various actors in rehabilitation and therapists. And we have also done this in various areas such as funding. And we have also focused on human resources and health insurance. This feeds into universal health coverage. When it comes to human resources, unfortunately, there is a lack of resources, and this remains a persistent challenge, especially in the light of terrorist attacks. Please conclude, says the speaker. My delegation would like to exhort the WHO to increase collaboration with global, national, and regional partners. Thank you. Now the floor is to Zimbabwe, thereafter Tanzania.
Thank you so much, Chairperson. Zimbabwe welcomes and strongly supports the proposed regional strategy to strengthen rehabilitation services in our health systems, recognizing its it as a critical framework to advance inclusive, equitable, and integrated rehabilitation services across the African region. Zimbabwe is fully aligned with the WHO Rehabilitation 2030 initiative and remains committed to embedding rehabilitation as an essential component of universal health coverage. In line with this commitment, Zimbabwe has undertaken several strategic actions to strengthen rehabilitation within its health system. This includes the country continues to invest in the training and deployment of rehabilitation professionals, including physiotherapists, occupational therapists, speech therapists, audiologists, orthopedic technicians, and among others. Efforts are underway to expand training programs and improve retention, especially in underserved rural areas. Integration into health information system, rehabilitation data is being incorporated into the National Health Information System, and rehabilitation module has been developed and is awaiting incorporation into our electronic health records so that it is digitalized. In terms of assistive technology, the strategy, Zimbabwe is a national assistive technology strategy, and a priority list that guides procurement and distribution has been developed. To that extent, Zimbabwe has plans also to develop the national rehabilitation strategy, a document to guide coordination, implementation, and resource mobilization and monitoring of rehabilitation services over the next decade. To that extent, Zimbabwe affirms its support to the Africa region strategy and calls for continued collaboration, technical assistance, and investment in this neglected area. Thank you.
Merci. Thank you. Now Tanzania. Thereafter Guinea-Bissau.
Thank you, Chair. The United Republic of Tanzania acknowledges rehabilitation as a core component of universal health coverage, vital for improving function, outcome, and quality of life. Our strategy for 2025-2035 seeks to integrate and scale up rehabilitation services across all levels. Our goal is to make rehabilitation services available in all council hospitals by 2030, supported by increasing training in our universities and mid-level cadre institutions. We are also establishing a specialized rehabilitation hospital to serve as a national resource center. Chair, Tanzania is now finalizing priority list of assistive technologies, securing procurement and supply of essential rehabilitation commodities throughout the country. Also, effort to integrate rehabilitation service into our essential health package is ongoing. With the WHO Afro support, we have established the Rehabilitation Health Management Information System to guide safety and infrastructure planning. With the strong political will under the leadership of Her Excellency Dr. Samia Suluhu Hassan, the President of the United Republic of Tanzania, we invite global stakeholders to partner with us in this commitment, and we take note of the report. Thank you very much.
Now Guinea-Bissau, and thereafter Benin. Good afternoon, everyone. As for Guinea-Bissau, we would like to thank the WHO for their commitment to this topic in recent times. Our country has undertaken various activities within its National Health Development Plan. We intend to guarantee access to rehabilitation for everyone in our country. We have done this via various healthcare programs, such as the Community Health Development Plan, as well as sexual, reproductive, and health rights. And when it comes to reducing MMR, Guinea-Bissau has undertaken various activities too, especially when it comes to rehabilitation for mothers, as well as blood banks in the different health structures in the country. In addition to this, we have mobilized resources to ensure that care is available in the furthest flung regions. This can be done via mobile clinics, which provide services to pregnant women. Thank you very much.
Maurice.
Now Mauritius, thereafter Angola.
Thank you, Chair. In Mauritius, the need for enhanced rehabilitative services as an integral part of the continuum of care has been growing steadily. The trend reflects the increasing prevalence of non-communicable diseases, the rapid aging of our population, the rising number of road accidents, and the health impacts of extreme weather events. To illustrate the magnitude of this challenge, in 2021 alone, among our population of 1.3 million, 658 amputations were performed in 507 patients, that is 89% of whom were diabetic. Cerebrovascular diseases and stroke are also on the rise, now ranking as the third leading cause of death after vascular diseases and cancer. While rehabilitative services are currently available in some public hospitals, primary health care facilities, and through community or home-based care, they remain limited in scope. Too often, they are not fully integrated into the continuum of care and are delivered by professionals with insufficient training or resources. As a result, many individuals in need of rehabilitation remain confined to long-term hospital beds or isolated homes, unable to integrate into society, resume productive activities, and contribute to the economic and social development of the country. This not only diminishes quality of life, but also increases a significant social economic burden. Therefore, it is imperative to develop and implement a comprehensive rehabilitation policy, such as a policy should clearly delineate the provisions of quality rehabilitation services at all levels of the health system delivered by well-trained health professionals. So we look forward to the addition of international partners. Thank you.
Now Angola, thereafter Gabon. Angola is not present. Now Gabon, thereafter Uganda. Thank you, Mr. Chair. Please allow me to make the declaration of Gabon on behalf of the relevant authority. Now, distinguished delegates, Gabon believes that this regional strategy is a milestone in the journey. And this regional strategy is ambitious, it is pragmatic, and it is focusing on something which has been neglected for far too long, that is access to essential rehabilitation services. We welcome actions undertaken, such as including rehabilitation across the continuum of care, as well as palliative care, treatment too. Persons who need rehabilitation often don't have access to it. This is why it is important to prioritize rehabilitation in health policies in the member states. All of this shows that our region is moving in the right direction. We think that it is a specific opportunity to improve the state of affairs on the ground and at all levels. We need to work with strategic partners, such as donors and communal actors. Innovation and digitalization are important. We must use technology to assist us. We need to leverage technology in public health. Please conclude, says the chair. We welcome the strategy. Thank you. Uganda, thereafter Sao Tome and Principe. Uganda is not present. Sao Tome and Principe. Thank you very much for giving me the floor. I would like to welcome the inclusion of this item on the agenda. It is a clear sign that excellent work has been done by the Secretariat. Approving this initiative will provide more attention to this important topic. It will also lead to more investment. This will be very important and be welcomed by healthcare workers in this area. We mustn't leave anyone behind. Now, this has everything to do with rehabilitation services too. It just shows how important universal health coverage is. It must be of high quality. Rehabilitation can help serve persons who already face many challenges in their lives. In Sao Tome and Principe, we have been making progress. For example, recently we approved investment in health infrastructure and procurement of equipment for rehabilitation. In this way, the provision of services will fulfill our requirements. We are looking forward to making our contribution. Thank you. Thank you. Distinguished delegates, I see no more requests to take the floor from our delegations, and I would now like to turn to extra UN organizations, NSAs, who would like to take the opportunity to take the floor. You have 2 minutes to take the floor.
There's no one.
I see no requests for the floor. I would like to thank everyone for their useful contributions. I understand that several NSAs have decided to make requests to make statements, and on this point, I now invite them to take the floor. Firstly, International Handicap Federation.
Some estimated delegates. Handicap International Federation welcomes the regional strategy to strengthen rehabilitation in health systems. With 200 million people in Africa needing rehabilitation due to aging, NCDs, and injury, the need is urgent. The 2023 World Health Assembly resolution was a key milestone, but real change requires regional and national leadership. Strengthening health system must go beyond reducing mortality. It must also improve functioning, autonomy, and quality of life, core outcomes of rehabilitation. We urge Afro member states to adopt and implement the strategy swiftly and to expand rehabilitation in essential care package to reduce out-of-pocket costs, especially for a person with disability and other group.
Please conclude.
Rehabilitation workforce who remain short in number, inadequately trained and not sufficiently.
Please conclude.
And engage civil society and users to scale up services, training and innovation. Thank you.
La parole est.
I now give the floor to Uniting to Combat NTDs. You have 1 minute.
Thank you, Chair. Uniting welcomes the first regional strategy to strengthen rehabilitation in health system. Its aims, objectives, targets, milestones, guiding principles, and priority interventions. This strategy presents a very vital opportunity to strengthen and elevate the response to neglected tropical diseases within the broader agenda of health system strengthening. Recognizing that rehabilitation can help people affected by NTDs, giving rehabilitation focus on minimizing the impact of these impairments, maximizing functionality, and improving the overall quality of life for individuals affected by these conditions. Yet, functioning limitations and disabilities resulting from NTDs are not prioritized, underfunded, and poorly integrated into national health plans. As member states develop national rehabilitation strategic plans, we urge member states to prioritize NTDs within adequate plans to provide the tailored rehabilitation interventions needed for improved quality of the life of the people affected. This will not only reduce disability.
Please conclude.
Thank you very much.
Merci.
Thank you. International Society for Physical and Rehabilitation Medicine.
Thank you, Chairperson. Distinguished delegate, the International Society of Physical and Rehabilitation Medicine, member of the World Rehabilitation Alliance, a WHO state network, welcomes the proposed regional strategy to strengthen rehabilitation in health system in African region by 2035.
This strategy is a critical milestone in embedding rehabilitation within UHC, aligned with the World Health Assembly landmark resolution on strengthening rehabilitation in health systems. We call on member states to adopt and resource it fully, prioritizing workforce development, evidence-based interventions, integrating into primary care, emergency preparedness and response, sustainable financing, so that all people can achieve the highest possible level of functioning and quality of life in African region. Thank you. Merci.
Thank you. Public Services International.
The situation analysis reveals poor integration of rehabilitation in health systems across Africa. This is of grave concern to PSI. In carrying out the strategy, we call on member states to prioritize integration of rehabilitation into planning and funding with investment in social care, recent work for community health workers, and increasing the numbers and mix of rehabilitative health professionals. We also urge member states to note the intertwined connections between rehabilitation and reintegration, without which rehabilitation would be futile. This includes socioeconomic determinants of health, such as safe housing and secure employment, including reasonable accommodation, as well as the social connectedness necessary for psychosocial well-being and mental health in the rehabilitation and reintegration process. Thank you, Chair.
Merci.
Thank you. International Association of Communication and Sciences and Disorders. Thank you.
International Association of Communication Sciences and Disorders, as a member of the World Rehabilitation Alliance, commends WHO and its partners for their commitment to strengthening rehabilitation globally. Speech therapists and audiologists remain amongst the smallest professional groups in health systems, with acute shortages in many African countries. In some contexts, there is insufficient in-country expertise to deliver comprehensive training. We request updates on progress by WHO and partners in supporting speech therapy, audiology, and rehabilitation training in low-capacity contexts. Communication, safe eating, and drinking are fundamental human rights underpinning education, identity, participation, and development. Yet in many African health systems, these needs are undervalued. We urge WHO to promote recognition of communication and swallowing as integral to human dignity, embedding these needs in
Please conclude.
Culturally adaptive speech therapy and audiology training. Thank you.
Now, International Federation of Students, Africa.
Honorable Chair, distinguished delegates, every day thousands of Africans survive injuries only to face preventable disabilities. Currently, fewer than 25 countries have more than 5 rehabilitation professionals per million people. Therefore, FAMSA commends WHO Afro's leadership in advancing regional strategy to strengthen rehabilitation. We recommend integration of rehabilitation into primary health care by training community health workers in basic rehabilitation, screening, and interventions. Harness youth innovation and leadership by establishing national platforms for youth engagement, digital health skills, and community mobilization. To secure dedicated and sustainable financing by allocating national health budgets to rehabilitation infrastructure, workforce, and technology by youth innovators. Rehabilitation is not a luxury. It is a catalyst for economic productivity and human dignity. Let us build resilient health systems where no African is left behind. Thank you.
Merci. Thank you. International Union of Cancer. Thank you.
Thank you, Chair. We welcome the proposed regional strategy to strengthen rehabilitation, recognizing its importance for people living with cancer and survivors across Africa. Cancer patients face unique and complex rehabilitation needs, yet access to services and skilled professionals remain highly unequal, leaving many without essential support. We strongly support the development of clear targets for primary health care, integration, and use that this be aligned with National Cancer Control Plan, ensuring rehabilitation is not seen in isolation, but part as the continuum of cancer care. For patients with advanced cancer, we often face comorbidities with other NCDs and communicable disease. Rehabilitation and palliative care are critical to improve quality of life and reducing suffering. Together, we can make rehabilitation a cornerstone of comprehensive cancer care in Africa. Thank you.
Merci. Thank you. West African Alcohol Policy Alliance.
Chairperson and distinguished delegates, the West African Alcohol Policy Alliance welcomes and supports the adoption of this agenda item. Chairperson, across the region, rehabilitation is being integrated into health systems. However, alcohol-related rehabilitation services remain widely neglected, despite alcohol being a major contributing factor behind road crashes, gender-based violence, mental health conditions, and other non-communicable diseases. Distinguished delegates, rehabilitation services for those affected by alcohol are either inaccessible or unavailable, particularly at the community level, leaving many without a pathway to recovery. We call on the WHO Regional Office to support member states to effectively implement the framework for implementing the Global Alcohol Action Plan 2022 to 2030 in the WHO African region, with a focus on ensuring alcohol-related rehabilitation is not left behind in health systems reforms. Thank you.
Merci. Thank you. Now, the International Federation of Medicine Students.
Chair, esteemed delegates, rehabilitation is too often overlooked, yet it is vital for dignity, independence, and full participation in society. From children with disabilities to patients recovering from illness or injury, it is not optional but a cornerstone of universal health coverage. We commend the WHO AFRO for advancing a regional strategy, but implementation must be bold. We call on member states to invest in training and retaining rehabilitation professionals, integrate rehabilitation into primary health care, leverage digital health tools and assistive technologies, and combat stigma and discrimination, ensuring that rehabilitation is understood as empowerment, not limitation. As IFMSA, we are committed to raising awareness, advocating for equity, and working alongside communities to ensure rehabilitation is accessible for all across the life course, because health systems are not complete until they include the parts to recover, adapt, and thrive. Thank you.
Thank you very much. I don't see any more requests for the floor. The Secretariat, would they like to make observations, remarks? Thank you, Mr. Chair. Firstly, the Secretary would like to start by expressing his apologies. Sorry that you had to have, dear ministers, such a short time to make your presentations. What we did here is that what is being dealt with here is a clear problem when it comes to public health. And there are a couple of issues which have cropped up. Firstly, the need to prioritize this topic. We need to make sure that rehabilitation is a part of the continuum of care. Secondly, the need for some countries to have budget plans which will help mobilize further financial resources in order to deal with the rehabilitation issues. And the issue of technology being used to promote rehabilitation has also been raised by several speakers. There's also the need for there to be more data available to help decision making. This was also raised. And then finally, the question of human resources came up, the amount of resources needed at a national level and also at a sub-regional level. And finally, when it comes to partnerships, we heard that there is a need for the World Health Organization to support countries in the different areas related to rehabilitation. We have taken note of all the comments and remarks made, and we will make sure that in the days to come, a report on this topic will be made available, and that the WHO will continue to work with countries, making sure that the strategy can be implemented with funding. And it would be on that point that I hand back the floor to Mr. Chair.
Thank you for your attention. The Secretariat has taken note of the comments and the regional committee is ready to adopt the regional strategy in the document AFR RC 75/6 and as well as the document AFR RC 75/6. The document is so adopted. I'd like to thank everyone for your important contributions. We've come to the end of our deliberations on agenda item 9. Ladies and gentlemen, we will move on to agenda item 8, which is entitled Accelerating Progress in Health and Well-Being of Women, Children and Adolescents by Transforming Health Systems in the African Region. The document we'll be referring to is document AFR RC 75/5. I'd like to invite Dr. Adelaide Onyango, who is the acting director, to present this document. You have 5 minutes to present the document.
On behalf of the Secretariat, I am pleased to introduce the technical paper AFR/RC 75/5 on accelerating progress in the health and well-being of women, children, adolescents by transforming health systems in the African region. Okay. It's not changing. Okay, good. This paper highlights that the African region has made modest progress in improving the health and well-being of its populations, especially in reducing maternal and child mortality. Between 2000 and 2023, the region's maternal mortality ratio dropped 40% from 727 to 442 per 100,000 live births. Likewise, under 5 mortality rates decreased from 149 to 64 per 1,000 live births. However, this progress is uneven across the region and remains insufficient to achieve the Sustainable Development Goal targets. This paper, where am I supposed to be pointing? This paper outlines the critical issues and challenges that underpin these trends, notably limited access and utilization of quality health services. We know that most deaths are preventable and are primarily driven by complications during pregnancy and childbirth and poor quality of care. Health systems are underfunded, understaffed, under-equipped, and unable to meet population health needs. There are also broader social, economic, and environmental factors such as climate change, water, sanitation and hygiene, food insecurity, and extreme weather events that undermine health systems' resilience. We continue to face contextual challenges that militate against sustained political will, good governance, and effective leadership. And finally, we still have a lot of disease outbreaks, fragile and conflict-affected situations that as well as other health emergencies. Okay. As implied in the paper, this is about, in the title of the paper, this is about transforming health systems as crucial to providing essential health services. It therefore presents details on 3 strategic flagships, which with actions that can address the identified challenges. The first flagship on stimulating investments in health as a socioeconomic development priority. This means strengthening governance, increasing domestic funding, tracking resources, fostering multi-sectoral coordination, and promoting a health in all policies approach. The second flagship, capacitating health systems, means increasing the health workforce and reinforcing their competence, strengthening regulation and production of health products, strengthening evidence and data systems, financial protection, and infrastructure. The third flagship, delivering quality essential health services for everyone along the life course and across the continuum of care. We do that by implementing comprehensive packages for all, differentiated for the development and fragile settings, and implementing service delivery models with strong referral mechanisms and focus on quality and equity. Okay. WHO is committed and calls on partners to support member states by providing technical support to implement results-driven service models, supporting advocacy and innovation for increased domestic financing, and improving South-to-South learning with mutual accountability. I thank you.
Merci beaucoup, Docteur. Thank you very much, Dr. Onyango. I now open the floor to member states' interventions.
Alors, tout à l'heure, personne ne nous a permis d'économiser un peu le temps.
I hope that you will speak in a short time so that we make up for time. We'll start off with Tanzania and thereafter invite Togo.
Chairperson, Africa has made commendable progress in reducing maternal and child mortality. Between the year 2000 and 2003, maternal mortality in the region dropped by 40%, and under 5 mortality declined by over 50%. Yet, this progress is uneven and too slow to meet the 2030 SDG targets. Only 10 member states have a maternal mortality ratio less than or equal to 140 deaths per 100,000 live births, and just a handful have reached the target for neonatal and under 5 mortality. Therefore, accelerated coordinated action is needed across all member states. We commend the adoption of the resolution of WHA 77.5, which emphasizes a multi-sectoral approach and the reorientation of the health systems towards primary health care. To achieve the SDG target 3.1 and 3.2, countries must rethink and scale up innovative, high impact strategies. Chairperson, Tanzania has seen significant gains by investing in primary healthcare infrastructure. The establishment of CMOC centers across the country helped reduce maternal mortality by nearly 80% between 2015 and 2022. We urge other countries to adopt similar investment in RMCH. However, the progress will only be sustainable if we address the critical shortage and maldistribution of the healthcare workforce, strengthening capacity and increase domestic financing. Honorable Chairperson, we call upon WHO AFRO to support member states through learning exchange and continued advocacy for increased health.
Continuez, s'il vous plaît. Le Togo a la parole.
Togo, followed by South Sudan. Thank you, Chairperson. Togo would like to congratulate the Secretariat on their analysis of the progress made by Africa region countries in improving the being of their population, and particularly with regard to reducing maternal and children mortality rates. In Togo, efforts have been made to improve the well-being of women, children, and adolescents. And among the efforts made, I'd like to cite the strengthening of emergency obstetric care, and then a free care, including cesarean sections, a program to accompany pregnant women who are entitled to a package of services, malaria services for children aged under 5, and then services adopted to adolescents. This has contributed to reducing to the reduction in the MMR ratio based on the latest UN estimates. Regarding infant and juvenile mortality rates, some progress has been made. However, there are challenges, including availability of human resources, particularly in rural areas, and then the lack of domestic resources. We need to accelerate actions to reduce the high mortality rates. And in this regard, we have developed a plan covering 2024 to 2027. And we subscribe to the measures that have been proposed, and we want to strengthen the health systems to provide services throughout the life cycle. Thank you, Chairperson. Thank you, Madam. I now move on to South Sudan, followed by Seychelles.
South Sudan focus on advancing universal children's and adolescents by strengthening integrated service delivery through primary healthcare system. South Sudan has made some progress over the years. Despite the several years of multiple humanitarian crises, South Sudan has made some good progress in improving the health of women and children. The recent UN interagency report shows a 59% reduction of maternal mortality ratio between 2000 and 2023 to now 692 deaths per 100,000 live births. With the same period, the neonatal mortality rate dropped from the 56 to 40 per 1,000 live births. The stillbirth rate dropped from 39 to 28 per 1,000 total births, while the under 5 mortality rate decreased from 183 to 99. Mortality rate among adolescents aged 10 to 14 years also decreased from 19 to 8, while among 15 to 19 years also dropped from 29 to 15 per 1,000 live births. There is still room to improve on this progress, as South Sudan is far from achieving the 2030 targets of the Sustainable Development Goals. The government of South Sudan approach is aware of worst indicators of this, and working with the partners, we committed to continue improving those trends. We focus on the integrated services and multi-sectorial approach as one of the key. Please, s'il vous plaît.
Conclude.
On that. For this, South Sudan is also wanted to work in the providing services in the humanitarian crisis and to ensure that it delivers services in that.
Please conclude.
La parole est
I now hand over to Seychelles, followed by Senegal.
Thank you, Mr. Chair. Seychelles commend WHO for this timely and insightful report, and because it aligns with, this report aligns with emphasis on transforming health systems through primary health care, multi-sectoral collaboration, and strong governance. We particularly support the call for investment in health as a driver of socio-economic development and the prioritization of quality people-centered care across the life course. Seychelles has made notable progress in reducing maternal, neonatal, and under 5 mortality. However, there are sustainable achievements that needs to be prioritized. To build on these gains, our comprehensive family health program has long been established, encompassing sexual and reproductive health, maternal and child health, EPI, school health, and even adolescent health. Recently, we also have a Youth Education for Success campaign, which equips adolescents with knowledge, skills, and values to make informed and responsible health choices. Services are also provided through the Youth Health Center.
As our commitment to adolescent and women's health, Seychelles introduced HPV vaccines for young girls in 2014 and extended to boys last year. And we also have upgraded the cervical cancer prevention through new methods and also national guidelines. We also echo reports for strengthened health workforce capacity and reliable essential medicines and robust data systems to guide evidence-based decision-making. But we also want to stress the importance of embedding quality of care and equity at every level of health system through the integration and also comprehensive national quality policy strategies. We also urge greater focus on community engagement, adolescent health, and also addressing social determinants of health. We remain steadfast to collaborate with the member states and other partners to share our experiences and collectively work towards inclusivity and equitability. Thank you.
Merci. La parole est au Sénégal.
I now hand over to Senegal, followed by Angola. Thank you, Chairperson, distinguished delegation. We congratulate the WHO Regional Director on the situational report and pledges to continue making progress in the health and well-being of women, children, and adolescents. The government of Senegal has always prioritized the health of mothers, newborns, children, and adolescents. This is reaffirmed in the new 2025 to 2029 sectoral policy letter for the health and social action, which is operationalized by the new integrated 5-year strategic plan for reproductive, maternal, neonatal, child, and adolescent health and nutrition, complete with resource mapping. Like other countries, Senegal has made strides in improving access to quality, affordable care, particularly for the most vulnerable groups, namely women, newborns, children, and adolescents. This has resulted in improved maternal and child health. In fact, between 2005 and 2023, maternal mortality ratio decreased by 60%, dropping from 401 to 153 deaths per 100,000 live births. During the same period, infant and child mortality dropped from 121 to 40 per 1,000 live births. Neonatal mortality also decreased from 35 to 23 per 1,000 live births. Senegal is committed to achieving the SDGs relating to maternal, child, and adolescent health. It would be necessary to ensure that we consider the reduction in ODA and try to increase health coverage. We are going to try and have high impact interventions and reduce inequalities. Thank you. Angola, followed by Ghana.
Chair, Your Excellencies, Ministers, Director General of the WHO, Angola would like to congratulate the Secretariat on the relevance of this report on women, children, and adolescents, aiming at transforming healthcare systems in Africa. Angola is completely committed to improving the well-being and health of women, children, and adolescents, particularly when it comes to human resources, infrastructure, the availability of services for RMNCAH throughout the life cycle and the continuum of care, also using technology when it comes to primary health care and involving a multi-sectoral approach. Our Ministry of Health has implemented an ambitious program to help train and build capacity of healthcare workers on the 3 different levels. We are also looking to build the capacity of train 38,000 healthcare workers by 2028. We're looking at supporting pediatricians and other specialists in line with this approach. Our National Health Network has seen a 28% increase over the last 8 years. That end date is 2025. And we have also implemented healthcare centers, which are friendly for adolescents and welcoming of adolescents. We have
conclude.
Angola is working on a report, welcomes this report, and will continue to support this topic when it comes to investments in the health of women, children, and adolescents. Thank you.
I now hand over to Ghana, followed by Congo.
Thank you, Mr. Chair. Ghana wishes to thank the Regional Office for Africa for preparing the technical paper on Agenda Item 8. We welcome the emphasis on transforming health systems to address the agenda of reproductive, maternal, newborn, child, and adolescent health across our African region. Over the past 2 decades, Ghana has made steady progress in expanding coverage for essential maternal, child, and adolescent health services. Although maternal death has declined steadily over the period, the average annual rate of reduction is still far too below the 15% required to reach the 2030 target. The paradox of persistently high maternal mortality despite high antenatal care attendance and institutional deliveries points to critical challenges within the healthcare system. In addition, the agenda for reducing the unmet needs of modern contraceptives among women in union and among sexually active adolescents remain a priority. Ghana notes with appreciation the flagship areas proposed in the technical paper. On stimulating investment in health, Ghana is planning to roll out the quality-focused free primary health care program, which from September 2025 will eliminate user fees for essential primary healthcare services for all residents. On capitating health systems, Ghana recognizes that a resilient health workforce is the backbone of RMNCAH services. We are scaling up training and recruitment for health workers, strengthening community-led service delivery and primary healthcare networks, and ensuring full implementation of free maternal health services in all health facilities. On delivery quality essential health services across the life course, maternal and prenatal health services conclude is being institutionalized nationwide with plans for a centralized electronic audit system and strengthening accountability to national and district level. Chairperson, Ghana reaffirms its commitment to the proposed action in the technical paper. We note the progress report and recommendations therein. Thank you.
La parole est au Congo, la République centrafricaine se prépare.
The floor goes to the Republic of Congo, followed by the Central African Republic. Chairperson, the Republic of Congo lauds the document prepared by it and reaffirms its commitment to the well-being of women, children, and adolescents. Our country has initiated a strategic plan of 2022 to 2026 for reproductive, maternal, neonatal, child, and adolescent health and nutrition, which is has integrated free cesarean sections and major obstetric interventions, care for malaria in pregnant women and children aged under 5, and care for people living with HIV/AIDS. We are trying to strengthen the EPI program and look at the needs of our national laboratories. We have support from the WHO, UNICEF, and the results are encouraging. Neonatal mortality has decreased to 18.2 per 1,000 live deaths. And for children aged below 9 months, as well as those aged under 5, has also reduced. We need to strengthen our interventions, particularly emergency obstetric care, through qualified human resources and access to these services. We want to attain the SDGs with the support of our partners. Thank you. Thank you, Congo, for helping us gain on time. I'll hand over to the Central African Republic, followed by Malawi. Chairperson, the Central African Republic congratulates the African Region Secretariat for preparing this paper on accelerating progress in health and well-being of women, children, and adolescents by transforming health systems. We would like to say that the mortality rates are below the threshold. However, we note that there is a reduction in fertility rates of adolescents and a reduction of support for reproductive health. And these are part of the presidential priorities. They're reforms, and we are trying to give care to mothers and targeting children aged below 5. We're implementing the plan to give access to contraceptive products and the obligation of declaring perinatal deaths. Maternal health is a health emergency for us, and we are trying to accelerate the reduction of the maternal mortality ratio so that we have 0 deaths. We have trained thousands of community health workers using paramedical schools. We are improving the collection and the use of DHIS2 data. However, we have a lack of qualified human resources as well as complete neonatal and obstetric care. We need strengthening through South-South partnership to train specialized staff. Thank you. Thank you. I would now like to request African regional member countries who wish to take the floor to raise their flags because we're about to close the list.
Chairperson, Malawi has noted the progress highlighted in the document and its technical options of improving the health in maternal and child health. Chairperson and delegates, it is worth noting that close to 95% of our women do deliver in our health facilities. And what we've noted as a country from 2000 up to now is a significant reduction in maternal mortality ratio of about 40%. But despite this, the MMR is still above the SDG target of 140 per 100,000 live births. And paradoxically, most of these maternal deaths are happening in our health facilities. And as a country, we're still experiencing a high rate of teenage pregnancies. Now, the government of Malawi, through the presidential initiative on maternal and child health, through multi-sectoral collaboration, and also using the WHO flagship, we try to highlight several interventions, and these interventions include improving pre-service training to build capacity, and as well as in-service training, and also improve availability of life-saving commodities, and also improve in the procurement of equipment and remodeling our infrastructure, addressing the health assisting social and political determinants, at the same time improving the referral system. What we've noted as a country is to adopt what has worked already in the Republic of Tanzania, the M-Mama referral system. And at the same time, we also...
Merci de conclure. Thank you. Kindly conclude.
Thank you.
Le Cap Vert à la parole. Cabo Verde, thereafter Madagascar.
Boa tarde.
Good afternoon, everyone. As for Cabo Verde, we would like to thank the opportunity. Thank you for the opportunity to take part in this session. We reaffirm our commitment to this topic. And when it comes to progress in Cabo Verde, what I can say is as follows. Cabo Verde has reduced MMR by 20 per 1,000 deaths in 2014 to 13 in recent years. So we're getting closer to achieving our goal. And as for neonatal mortality rate, this has gone down to 6.3%, and further progress has been measured in 2021. And Cabo Verde has neonatal services in its hospitals. We have the capacity necessary to look after 12 early births, and the rate of the first consult is higher than 90%. When it comes to adolescent health, we have adolescent health centers on every island in our archipelago. We provide them with information on reproductive health. When it comes to recommendations, Cabo Verde is improving access to universal care, and Cabo Verde is also focusing on research into the use of digital technologies. We're also promoting equity of access to healthcare services. In addition, Cabo Verde would like to thank you once again the opportunity to take part in this forum. Thank you. I give the floor now to Madagascar, thereafter Chad. Thank you, Mr. Chair. We'd like to congratulate the Secretariat for the work that they've done, and we're very grateful. As for Madagascar, in the last 20 years, we've made significant progress when it comes to RMCNH. This includes increased vaccine coverage, increased access to obstetric services, electronic, or rather mobile healthcare services, also including the use of drones. Now, besides this progress, serious challenges persist. However, Madagascar remains firmly committed to transforming its healthcare system by learning lessons from the past and looking ahead to the future. We are looking at the transformation using technology and improved resilience. How we are going to invest more effectively, and a special area of focus has been prioritizing mapping of our services across our country. We've also looked at health care workers and human resources so that they can better use digital technology. To conclude, Madagascar would like to reaffirm its commitment to fully contribute alongside other countries to improving our performance in line with the indicators. Thank you very much. Thank you, Chad. Thereafter, Kenya. Mr. Chair, Chad would like to congratulate the Secretariat for its report on this topic, which is very important for public health on the African continent in general, but also in Chad. When it comes to sexual and reproductive health rights, this is an important part of our NCAH. We have always, however, achieved rates lower than the African average. Let me just remind you that the highest level of the state is aware of how important interventions in this area are. This is why we have a national healthcare policy which has taken into account these issues. One of the goals is to reduce MMR. In 2019, Chad joined an initiative that is the Funding GFF initiative. It also includes investment on a scale going up until 2027. And we also are part of the Family Planning 2030 Global Initiative. We've taken part in national high-level dialogue on the issue of maternal mortality rate, as well as that of children. We have involved actors in the healthcare sector on a national and international basis in this dialogue. And we have made commitments. We now have a roadmap, which is which has resulted from this dialogue. And Dr. Tedros has given us the honor of providing us with a specific provision of funds for this roadmap, and specific actions have been taken, especially when it comes to the development of our national network. We now provide training for healthcare workers. Please conclude. However, challenges are still what we face, and I'd like to take this opportunity to remind all international actors that we need support in Chad in order to make progress. And we would like to call for the acceleration of progress when it comes to the well-being of women, children, and adolescents. Thank you. Kenya now has the floor. Thereafter, the DRC.
Thank you, Chairman. Kenya appreciates the opportunity to make our statement. Kenya remains committed to achieving SDG targets 3.1 and 3.2. Despite notable gains, maternal mortality rates remain high at 355 per 10,000 live births, and national mortality at 21 per 1,000. To address this, Kenya is scaling emergency obstetric and newborn care, implementing M&H quality and care standards, strengthening MPDSR, and expanding postpartum and community-based family planning. EMONC guidelines have been updated to reflect emerging evidence for prevention and management of postpartum hemorrhage. The finalization of the RMNCAH investment plan and efforts to integrate MNCH into social health insurance fund demonstrate sustained political commitment. Newborn health is a priority. With CPAP machines distributed to all high-volume facilities, expansion of comprehensive newborn units, there is a focus on both essential and comprehensive newborn care to enable health providers give quality care to sick and to small newborns. National standards for newborn infrastructure and HRH in development is an investment case to support scaling up of comprehensive newborn care units. Health worker training and IMCH ETAT guideline revisions are being implemented to reduce under 5 mortality. For adolescents, Kenya is finalizing its adolescence health policy strategy and M&E framework, establishing centers of excellence and rolling out adolescent modules for community health promoters. The AYPs for Change initiative and the first National Adolescent Forum underscore youth engagement. Key challenges include inadequate funding,
S'il vous plaît, please conclude.
Commodity gaps, and skilled workforce attrition. Kenya calls for increased domestic investment, cross-country learning forums, and stronger regional mechanisms for accountability and data use. Kenya reaffirms its commitment to ensuring
Thank you.
child and adolescents not only survives but thrives. Thank you.
La parole est now DRC, Nigeria afterwards. Thank you, Mr. Chair. As for DRC, we'd like to thank the Secretariat for the quality of the report. Regarding this topic, the DRC, since 2023, has been implementing the presidential initiative ensuring free maternal health care. This is in line with the UHC. In addition, we have made commitments to building capacity and training of midwives. Following on from recommendations, we have implemented initiatives to facilitate the achievement of UHC, such as we have focused on equity measures when it comes to implementing UHC. Our regulation authority, our pharmaceutical regulation authority, has focused on safety and security across the country. We have also been focusing on scientific knowledge and making it available to our healthcare sector. We've also worked with epidemiological centers and public health. Fourth point would be the quality of healthcare, ensuring that it supports the most vulnerable. Fifth, promoting good health, ensuring that there is equal access to good healthcare. Sixth, the National Clinic Network. We have been modernizing health services to ensure there's a high level of quality. 7, essential medicines and healthcare products. Here we've been ensuring that they are available. Synergies and complementarities of these structures is important because it will help us transform our healthcare system throughout our country, especially for the benefit of women, children, and adolescents. We support the report. Thank you to the DRC, now Nigeria. Gabon afterwards.
Thank you very much. Nigeria joined other African countries to welcome the technical paper on accelerating progress in the health and well-being of women, children, and adolescents by transforming health systems in the African region. In Nigeria, women, children, and adolescents remain central to our development agenda. We have made progress towards the revitalization of primary health care, expanded immunization, and implementation of the Basic Healthcare Provision Fund. We have also scaled up HIV prevention and reproductive health and adolescents age group. To address these challenges, we're investing in our health workforce, leveraging digital innovations, and promoting multi-sectoral actions on nutrition, education, and gender equality. Furthermore, Nigeria launched the Maternal and Neonatal Mortality Reduction Innovation Initiative, known as MAMI, that co-creates context-specific strategies with states to crash maternal and neonatal mortality by deploying a client-centered service delivery approach and optimizing demands, access, and supply to address delays across seeking care, reaching care, receiving care, and coordination. We note the recommended strategic flagships to stimulate investment to capitate health system that deliver services to everyone across the life course, but also recognize that national efforts need to be supported by regional and global solidarity through sustained investment, through stronger partnership and knowledge sharing across member states to accelerate progress in the health and well-being of women, children, and adolescents. By working together to transform our health system, we can secure a healthy, a more prosperous future for the continent. Thank you very much.
Merci. Thank you. Now, Gabon, thereafter Gambia. Thank you, Mr. Chair. Gabon would like to welcome this initiative, which promotes an ambitious goal focusing on the needs of women, children, and adolescents in our region. We have made commitments in line with this objective, including in reducing mortality rates. We've been improving neonatal care. We've also been increasing the numbers of midwives and obstetric services. This has been supported by state funding and transforming and strengthening healthcare systems in communities. This has been done through improving healthcare services, especially for adolescents. We have targeted young mothers as well as teenagers. We've been working with NGOs. We have national vaccination campaigns. We've also been able to target preventable disease amongst children. And this is going to achieve several different SDGs. We intend to accelerate our progress. Healthcare registries for the health of women and children will help us improve monitoring. we have diagnostic services which will now use data to create innovative responses. We intend to include the health of women, children, and adolescents in state health policy. Gabon fully supports the adoption of this regional strategy, and we call for increased political commitment to women, children, and adolescents. We also need accountability mechanisms and periodic review mechanisms. Increased collaboration amongst member states when it comes to RMNCH is vital. Thank you. Now Gambia, thereafter Namibia.
Thank you very much. Mr. Chair, the delegation of the Gambia extends its appreciation to the WHO Regional Office for Africa for the progress report on accelerating progress in the health and well-being of women, children, and adolescents by transforming health system in Africa region. We recognize and appreciate the progress and the challenges. The Republic of the Gambia reiterates its unwavering commitment in advancing the health and well-being of women, children, and adolescents across the Africa region. We recognize the transformative health systems. We recognize that transformative health systems are essential to achieving universal health coverage and the Sustainable Development Goals. Our national health strategies aligned with the WHO Country Cooperation Strategy 2024 to 2028 prioritize equity, resilience, and people-centered care. We have made commendable progress in reducing maternal and child mortality, expanding immunization coverage, and improving access to essential services. However, the challenges remain, particularly in the health workforce capacity, financing, and service integration. To address these gaps, the Gambia is investing in strengthening primary health care and the community-based services, introduction and rolling out of the National Health Insurance Scheme, enhancing health worker training and retention. In this, we are training more obstetricians, gynecologists, nurse anesthetists, midwives, and others. All this is done locally. Scaling of digital health innovations, promoting multi-sectoral collaboration and youth engagement, integrating sexual and reproductive health and rights into national policies. We call upon WHO and development partners to continue supporting member states through technical assistance, capacity building, and resource mobilization. Together, we can build resilient health systems that deliver quality, accessible, inclusive care to every woman and child and adolescent. Thank you very much for your attention. Thank you.
Merci. Thank you. Now, Namibia, thereafter Liberia.
Thank you very much, Chair, and thank you, the Regional Office and the Secretariat for this technical paper. Namibia remains deeply committed to improving the health and nutrition of women, children, and adolescents in line with our national priorities and international commitments that we have signed up to. This vision, Chairperson, is firmly embedded in our national development frameworks, particularly the 6th National Development Plan, which just came into online earlier this year, in July this year in particular, and the forthcoming reproductive, maternal, newborn, child, and adolescent health and nutrition strategy, which is a 5-year strategy due for adoption this year. Namibia has made some notable progress in reducing maternal, newborn, child, and adolescent morbidity and mortality. Yet, we acknowledge and admit that the pace of decline remains insufficient to meet the 2030 Sustainable Development Goals. Our maternal mortality ratio remains high, coming in at 139 per 1,000 live births, while neonatal and under 5 mortality rates stand at 24 and 41 per 100,000 live births respectively. These figures, they don't lie. They remind us of the urgency to accelerate action in these areas of outcomes. What has Namibia done to date? Earlier this month, Chairperson, Namibia rolled out the introduction of HPV vaccine in public health facilities, and that complements what the private sector have said. We are coordinating with the ministry responsible for education in order to improve outcomes in this area. With these remarks, Chairperson, Namibia fully supports the flagship strategies that are illustrated in this technical paper. Thank you, Chair.
Thank you.
Liberia, Mauritius.
Thank you, Honorable Chair. Liberia has made some progress in accelerating maternal, newborn, child, and adolescent health and well-being. Areas of intervention include scale birth attendance has increased to 90%. This is due to training of midwives, opening additional midwifery schools. All our referral hospitals have specialized obstetric and gynecologist doctors. We have improved infrastructures and quality of care for women, newborn and adolescent, availability of essential drugs and equipment in the hospital and public health clinics, especially the use of uterine drugs to prevent hemorrhage. We have included more services in all our hospitals and clinics, increased supervisions. We have the community health assistance program within the 15 counties and within 5 kilometers of the public health clinics. This has increased our referrals rate. ANC, that is the antenatal care visit for, has increased. The uptake of RPT has also increased, and the use of insecticide treated net has also increased. We are conducting nationwide review of maternal and newborn death to prevent reoccurrence. Liberia has also adopted the WHO standard on newborn health, improved equipment for newborn at the health facilities. Immunization services for newborn and children have also increased, including malaria vaccines. Newborn indicators have been integrated into the
Merci de conclure, s'il vous plaît.
Okay. Despite these challenges, despite this gain made, Liberia is still challenged with some regional and global targets that include our maternal mortality rate is at 742 and 100,000 live births. Our unaltered mortality rate is at.
And I'll give the floor to Mauritius, and Zambia will prepare. Mauritius, please.
Thank you, Chair. Mauritius has made steady progress in advancing the health and well-being of women, children, and adolescents through sustained investments in its health sector. But Mauritius faces the double burden of diseases with the rising rates of non-communicable diseases, including diabetes, obesity, cardiovascular disease, and mental health disorders, along with ongoing challenges in sexual and reproductive health, adolescent well-being, and maternal health. Emerging risks such as declining fertility rate, gender-based violence, substance abuse among children, and social inequalities further underscore the need to transform health system to be more resilient, inclusive, and people-centered. Despite commendable achievements in the service delivery in health outcomes, Mauritius continues to face a range of challenges regarding targeted policies and programmatic action to sustain and accelerate progress towards better sexual, reproductive, maternal, newborn, child, and adolescent health. Some of the priorities of health system transformation in Mauritius to reinforce primary health care are integrate maternal, child, adolescent, reproductive health, and mental health services within PHC, expand outreach services to underserved communities and ensure adolescent-friendly health services. Have also to advance a women health through gender-responsive life course approach to promote well-being and equitable workforce participation, support informed family formation and fertility decisions, focus on preventable maternal death and addressing the overuse of cesarean sections through improved clinical guidelines and audits.
Conclude, please.
Scale up preconception care services and improve fetal anomaly screening programs. Thank you.
Merci.
Thank you. Zambia, thereafter Lesotho. Please try and respect the time allowed.
La Zambie.
Is Zambia here?
So Zambia is committed to improving the health status of our population, including that of our women and children. In the last 25 years, Zambia has achieved the following: reduced maternal mortality rate from 729 to 195 per 100,000 live births. Under 5 mortality has also been reduced from 168 to 42 per 1,000 live births. Infant mortality has also reduced. Neonatal mortality has also been reduced from 37 to 17 per 1,000 live births. What are the drivers of this success? One, political will. The Zambian presidency closely monitors the above indicators through the Presidential Delivery Unit. Increased health financing, which we've been talking about, increased human resources, both in numbers and skills, community involvement through polyvalent community healthcare workers, infrastructure improvements, including the fact that all the 3,600 health facilities in the country have a maternity wing. And then all the programs related to women and children are actually managed with information derived from data. Set against these gains, challenges still exist. Health system inequities between rural and urban, physical barriers, community level challenges, including traditional norms, early marriages, personal challenges, especially poverty at household level. Going forward, Zambia endorses the proposals by the Secretariat. Zambia also appeals to all stakeholders, donors, researchers, and the academia to continue supporting this work through financing, alignment of normative guidance, joint planning, equipping, and routine monitoring and evaluation of the portfolio. Thank you.
Thank you. Now Lesotho, thereafter Zimbabwe.
Thank you, Chair. Zimbabwe has noted the progress in the report, and Zimbabwe is committed to improving the health and well-being of its citizens, particularly women, children, and adolescents. The country has made significant progress in reducing maternal mortality, with the ratio declining from 652 maternal deaths per 100,000 live births in 2015 to 212 per 100,000 in 2024. This achievement is a testament to the concerted efforts of health professionals, policymakers, community leaders who have worked tirelessly to enhance maternal care services, increase access to skilled birth attendants, and improve emergency obstetric care. Despite these gains, challenges persist, including an increase in neonatal mortality from 29 per 1,000 live births to 37 per 1,000 live births, contributing to stagnation in under 5 mortality rates, high rates of teenage pregnancies, which threaten the gains made in maternal mortality and require a comprehensive and multi-sectoral response. To accelerate progress, Zimbabwe will prioritize system-wide reforms and innovative domestic health financing that is efficient, predictable, and equitable. Increase the number of level 2 neonatal care units. Elevate the quality of care through strengthening respectful, evidence-based care and continuous quality improvement. Deploying digital solutions in care and a multi-sectoral approach to prevention of teenage pregnancies, while ensuring adolescent-sensitive maternal care. By uniting around evidence-based, community-driven, and multi-sectoral strategies, Zimbabwe will transform the health system to better serve women, children, and adolescents, protect the gains made, and pave the way for a healthier, more prosperous Zimbabwe. Zimbabwe reaffirms its commitment.
Please conclude.
For development goals, particularly goal number 3 and goal number 5. I thank you.
Merci.
Thank you. We're going back to Lesotho. Lesotho has the floor. Thereafter, Comoros.
Thank you, Chair. Lesotho reiterates its unwavering commitment to accelerating progress in the health of women, children, and adolescents. Despite important gains, the country continues to face significant challenges, with maternal mortality standing at 530 per 100,000 live births and neonatal mortality at 26 per 1,000 live births, according to the 2024 Lesotho Demographic and Health Survey. To address these persistent challenges, the government introduced the M-Mama emergency transport system in 2019 with partner support, and by 2024, the government took the whole responsibility. In 2023, Lesotho introduced competence-based curriculum in midwifery training and a licensing framework to strengthen the professionalism and regulation of midwives. This was completed in 2024 by the establishment of simulation training centers at the tertiary hospital and 4 district hospitals. The centers are enhancing clinical competencies and promoting a team-based approach to the maternal and neonatal emergency care. To reach adolescents, a toll-free call center was established this year, complementing our adolescent health corners in hospitals. We also opened a multi-purpose safe house for survivors of gender-based violence, providing both protection and vocational training. In partnership with UNICEF, a gender barrier analysis was conducted to inform gender-responsive tools and community engagement. This work will build the capacity of our immunization and adolescent health programs. These reforms will be vital at advancing the broader universal health. Please conclude. SDG 3 agenda. Thank you.
Comoros, you have the floor. Guinea should get ready.
La parole est donc à la Guinée-Conakry, puisque les Comores semblent avoir décliné.
Well, because Comoros has withdrawn its request for its floor, so Guinea-Bissau should get ready. We didn't ask for the floor, Chairperson. It was Guinea-Bissau that requested for the floor. So Guinea-Bissau has the floor then.
Thank you, Mr. Chair. Guinea-Bissau welcomes the important initiative of accelerating progress for the well-being and health of women, children, and adolescents.
De saúde pública para todos, em particular para as populações mais vulneráveis, sobretudo as crianças e as mulheres. Apesar dos desafios significativos, o país registrou progresso. A redução da taxa de mortalidade, que passou de 746 em 2018 para 548 mortos por 100 mil nascidos vivos em 2022. Este avanço foi possível graças ao conjunto de medidas estratégicas implementadas a nível do nosso país, entre os quais a melhoria das infraestruturas de saúde, a reabilitação das maternidades e equipamentos, reabilitação dos bancos de sangue, sobretudo para atendimento das emergências obstétricas, envolvimento ativo dos agentes de saúde comunitários, que desempenham um papel crucial na sensibilização das comunidades, no acompanhamento das grávidas e na promoção de boas práticas seguras da saúde materno e neonatal. A formação dos profissionais de saúde em cirurgia obstétrica, ecografia e anestesia, e a integração de serviços de saúde comunitária a nível de diferentes programas de saúde pública. Muito obrigado.
Merci. La parole est au Mozambique et le Niger se prépare.
And then Niger.
Muito obrigado.
Thank you very much.
Quero primeiro saudar o relatório aqui apresentado, dizer que a saúde da mulher, adolescentes, jovens e crianças são uma prioridade em Moçambique. A mortalidade materna e infantil ainda são um grande desafio nos nossos países. Os adolescentes e jovens enfrentam desafios significativos em saúde sexual e reprodutiva, mental e nutricional. Os sistemas de saúde precisam de transformação profunda para atender às necessidades de todos. Esta transformação pressupõe serviços de qualidade integrados e resilientes, disponíveis em todos os níveis da atenção.
Estamos a investir em 3 frentes: fortalecer, capacitar e reter a força de trabalho e saúde, promovendo
of healthcare workers. We're focusing on specific skills that they can adopt and
vacinação, planeamento familiar, rastreio de doenças, cuidados pré-natais e serviços de saúde mental para adolescentes e jovens. O engajamento comunitário para garantir que a voz daqueles que mais precisam seja ouvida e valorizada. E a investigação operacional. A transformação dos nossos sistemas de saúde não é apenas uma necessidade, é uma oportunidade histórica para garantir que cada mulher, cada criança e cada adolescente e jovem possam viver com dignidade, saúde e esperança. Que ninguém morra por doenças evitáveis. Moçambique acolhe este relatório.
we welcome this report. We're going to work towards its achievement. Thank you.
Merci. Le Niger et le Mali.
Thank you, Niger, followed by Mali. Thank you, Chairperson. Niger takes good note of the excellent situation report and congratulates the Secretariat for including the item on the agenda. Like other countries, our nation is facing security crisis, the harmful effects of climate change, and health emergencies that particularly impact the health of women, children, and adolescents. Regarding the major challenges of maternal and infant mortality and morbidity, Niger, as part of its efforts to implement the Maputo Plan of Action, specifically concerning the rights of African women, has adopted a 2022-2026 strategic plan for reproductive, maternal, newborn, child, and adolescent health and nutrition plan and an investment plan. It has developed a national action plan for family planning, a national strategy for the elimination of obstetric and non-obstetric fistula, a plan for the reduction of neonatal mortality, and a national multi-sectoral operational plan for adolescent and youth health. Niger has also institutionalized maternal and perinatal death surveillance and response, including at the community level, and has declared maternal and perinatal deaths as a public health emergency. Consequently, a roadmap to accelerate the reduction of maternal and perinatal deaths was developed. Innovative, high-impact strategies are being implemented, including the SHEDEF initiative, which focuses on the 4 main causes of maternal deaths, the mentorship approach to strengthen the capacity of human resources for emergency obstetric and neonatal care, the mobilization of domestic resources through a telethon that raised over $2 million to help reduce maternal and perinatal mortality. Regarding progress, encouraging results have been recorded. Thank you. Please conclude, Chairperson. In conclusion, Niger supports the excellent reports and encourages the WHO to continue its advocacy efforts to support our countries in their journey towards achieving universal health coverage, particularly for this vulnerable segment of the population. Thank you. Thank you. The floor goes to Mali. Thank you, Chairperson. Mali would like to thank the Secretariat for the quality of its document and reaffirms its commitment to accelerating progress in the health and well-being of women, children, and adolescents. Despite the progress made and the reduction of neonatal, maternal, and child health, the challenges are great. Our country has put in place robust policies. We have free cesarean sections. We organize national family planning campaigns combined with utero and breast cancer screening. And we also have an innovative health coverage system. Similarly, we have joined the GFF and the initiative of each woman, each child, and the results-based funding framework. In terms of reproductive health care, we have cultural barriers that are still very present. We want to integrate nutrition, gender-based violence, our CMNH services deploy mobile teams in crisis and insecurity areas, and then ensure that we have commodities right to the last mile, mobilize domestic and partner resources to fund the various strategies in the child survival strategy. We would like increased support to accompany the transformation of our health system that is key to attain SDGs and guarantee the right to health for all. Mali supports this document and invites the regional committee to approve the proposed measures. Thank you, Mali. We have already closed the list of speakers. I'd like to thank the distinguished delegates. Since I do not see any other requests for the floor by member states, I invite the representatives of member states from other regions, UN agencies, and other intergovernmental organizations to raise their nameplates. I remind you that you have 2 minutes per intervention.
L'IAEA a la parole.
Excellencies, dear Chairperson, distinguished delegates, the IAEA supports member states in Africa to address their development needs in different areas, including health. Over the past 6 decades, the IAEA has helped more than 110 low and middle income countries to establish and expand access to radiation medicine services for cancer management, with high focus on women's related cancers. Within the context of quality, safety, and secure clinical practice. As you are aware, cancer remains one of the leading causes of death in Africa, and most African countries have limited or no access to diagnostic imaging and largely lack radiotherapy services. The IAEA Rays of Hope initiative launched by the Director General, His Excellency Rafael Mariano Grossi, in February 2022 at the African Union headquarters, is helping countries to establish or expand radiation medicine services, including
Please conclude.
nuclear medicine and radiology. Thank you.
Merci.
Thank you.
La parole est à
l'ECSHC. Invite UICC, East, Central, and Southern Africa Community.
Honorable Chair, East Central and Southern Africa Community commend WHO for this timely and pertinent situational report and reaffirm our steadfast commitment to the global and regional efforts aimed at accelerating progress in health and well-being of women, children, and adolescents, key pillars in the broader vision of achieving universal coverage. Honorable Chair, in our African region, women, children, and adolescents continue to face significant and disproportionate barriers to accessing essential health services. These challenges are compounded by persistent inequalities in health financing, critical workforce, shortages, a fragile primary healthcare system, and mounting pressures of climate change and humanitarian crisis. Therefore, ex-health community calls on all stakeholders to intensify their investment in sustainable financing, health workforce development, and robust data system. These are essential to meeting the health needs of women, children, and adolescents in our region, so the universal coverage. With urgent conclude, please. Your time is over. With urgent unit, let us join forces to make universal coverage a tangible reality. Thank you, Mr. Chair.
Merci.
Thank you. Partnership for maternal, newborn, and child health.
Honorable
Chair. We welcome this important technical paper and commend the Regional Committee for keeping women's, children's, and adolescent health on the center of the Africa's Health Agenda. We particularly applaud the strong emphasis on capacity building, focused on strengthening the health workforce, access to essential medicines and health information systems, and on financing, including the call for sustained domestic resources. These are all critical foundations for resilient health systems that can deliver for women, children, and adolescents. However, we must also recognize the stark reality. Despite decades of commitments, progress remains too slow and uneven. Maternal, newborn, and child mortality rates in the region remain among the highest in the world. That's why PMNCH urges that alongside investments in capacity building and financing, there must be a much stronger push on accountability across all regional mechanisms. We know what works. The challenge is ensuring commitments are implemented, tracked, reviewed, transparently, communities, youth, and civil society. This requires clear milestones, regional peer review, and systematic reporting of measurable action.
Je vous remercie.
Thank you. We have already closed the list, but there are 2 member states from our region that are requesting for the floor. And we will go back to them. Ethiopia, floor, and then Algeria.
Thank you, Chair. I think our flags were up early, but it was not seen. Ethiopia commands the Secretariat for the timely technical paper. We welcome the regional gains in reducing maternal mortality, newborns, and the under 5 mortalities. The renewed emphasis on primary health care at the foundation goes very much aligned with our strategic plans. It's clearer more than ever that a holistic health system approach backed by the sustained political and leadership commitment is very critical to achieve meaningful change in the health and the well-being of women, children, and adolescents. Ethiopia believes achieved notable progress in the maternal, infant, and under 5 mortality, and expanded essential service coverage. We have scaled up high-impact, low-cost interventions and the new innovations such as emotive bundle package, basic emergency care package, and service integrations. Efforts are also underway to have a sustainable financing and increase investment to avail high-quality services by mobilizing new sources of resources from domestic and also elsewhere. Nonetheless, challenges remain. Access and quality are still uneven in remote areas. There are workforce shortage and the maldistribution and the gaps in data. The proposed flagship will help address those challenges, and the intensified support from WHO will be critical. Chair, we take note of proposed actions and the call for concerned effort of WHO and the partners to accelerate progress towards the shared SDG targets. I thank you. Merci.
Merci.
Thank you. Algeria. Thank you, Chairperson. I'd also like to thank the Secretariat for the report presented on this theme. Maternal and child health is one of the pillars of health, and we offer free medical consultation as well as antenatal and postnatal care and other services. We also do cancer screening for women. Algeria has noted a drop in maternal and child mortality. We have 16 deaths for 1,000 live births, and MMR has also dropped. The information campaigns are organized by the public authorities to inform families on the importance of antenatal and postnatal care. And we'd like to state that maternity leave has been increased from 3.5 months to 5 months, based on a new legislation that has been enacted in July. Thank you.
Merci, monsieur.
Thank you, sir. Thank you for those enriching contributions. I know that several non-state actors have requested to take the floor, and now I invite them to take the floor. I will start with the International Federation of Neurology.
Chairperson, delegates, the World Federation of Neurology and the African Academy of Neurology are grateful for the opportunity to address the Regional Committee for Africa on the crucial importance of brain health across all ages. Protecting neurological and mental health in women, children, and adolescents is a prerequisite for a healthy society, both in terms of overall health, well-being, as well as economic health. The WHO Intersectoral Global Action Plan on Epilepsy and Other Neurological Disorders, IGAP, and the IGAP Toolkit are important instruments for member states to use when developing sustainable healthcare systems and incorporate the needs of women, children, and adolescents. We emphasize the imperative to reduce the gap in access to neurological education and care. Thank you very much.
Merci, monsieur.
Sir, I'll give the floor to the DNDI.
Honorable Chair and distinguished delegates, DNDI welcomes Member States' commitment to improving the health of women, children, and adolescents. These groups face a disproportionate burden of neglected diseases like leishmaniasis and schistosomiasis, yet they remain underrepresented in clinical research, limiting access to safe and effective treatments. We commend the strategic focus on transforming health systems and urge member states to prioritize inclusive research and development as a cross-cutting enabler. In the WHO 77 resolution, member states committed to support R&D to address unmet needs of women and children, and action is needed. Member states should also strategize to
conclude, please,
in early drug development to meet their unmet needs. Thank you.
Merci beaucoup.
Very much. I'll give the floor for a joint statement from the Dental Association.
Oral and Craniofacial Research and the FDI, World Dental Federation, representing 10,000 researchers and 1 million dentists worldwide, welcome the focus on transforming health systems to advance health and well-being. Oral diseases affect every stage of life and are linked to adverse birth outcomes, impaired nutrition, speech and learning, and the devastating toll of norma are all largely preventable, yet often excluded from maternal, newborn, child, and adolescent health agendas. The WHO Global Oral Health Action Plan and the Bangkok Declaration calls for embedding oral health across health policies and life course programs. We urge member states to integrate oral health into antenatal, postnatal, and school health services, ensure equitable access to fluoride, strengthen oral health literacy for women and caregivers, and align oral health with nutrition programs, including reducing free sugars consumption in children. Thank you.
Merci.
You. Amref.
Thank you, Chair. Distinguished delegates, we welcome the discussion on Agenda Item 8. However, it is noted with concern that progress towards this ambition has been limited for many, and inequity remains a stark reality for most. Progress begins by ensuring that services are accessible and of sufficient quality at the point of need by adopting the lens of primary health care. We urge member states to prioritize 3 approaches to transform and reorient health systems towards PHC to ensure that the health and well-being of women, children, and adolescents is secured. 1, by building on commitments made in the WHO 78 resolution to strengthen health financing globally and eliminate financial barriers. 2, adopting a multi-sectoral approach to designing responsive systems and incentivizing cross-sector collaboration. And lastly, ensuring that policy reform processes are embedded in the principles of meaningful engagement, people-centered models of service delivery, and social participation. Thank you.
Merci.
You. Public Services International, you have the floor.
Thank you, Chair. PSI welcomes the technical paper on this agenda item and commends member states for the modest but commendable progress made in reducing maternal and child mortality. With 70% of maternal deaths and 55% of under 5 deaths in the world occurring in the Africa region, the situation is very worrisome. We must address the root cause of this inherent problem through adequate public funding of health in line with the 15% health budgetary provision of the Abuja Declaration to accelerate progress in improving health systems, making available safe blood products, and more importantly, improving the general health and well-being of women and children. Additionally, investment in developing the health workforce through education, training, and decent work, as well as the active involvement of health worker organizations in the health policy process are fundamental in curbing this disturbing trend. PSI therefore calls on member states to do more in safeguarding the health and well-being of its women and children.
Conclude, please. La parole est maintenant à la Société Royale du Commonwealth pour
The Royal Commonwealth Association.
Depend on fully integrating person with disability into health system strengthening, representing 1 in 6 people globally. That inclusion is a crucial measure of member state commitment to equity and USC. The WHO Global Report on Health Equity for Persons with Disability highlights multiple avoidable systemic barriers that contribute to poorer health outcomes for women, children, and adolescents with disability. For example, discriminatory attitude toward women and girls with disability often result in their exclusion on sexually represented health services and delayed or denied in maternal care. We urge member states to embed Resolution WHA 74.8 commitment and the global report's recommendation into their action across the 3 strategic flagship to transform health system in Africa region, including by ensuring inclusive health policies, funding workforce training and infrastructure development, and ensuring inclusive service delivery and monitoring across the continuum of care. Thank you, Chair.
Thank you.
La parole est maintenant à la Fédération des associations des étudiants en médecine.
At the Federation of Students, FAMSA.
Delegates, women, children, and adolescents remain the backbone of Africa's future, yet they continue to bear a disproportionate burden of preventable disease and mortality. Sub-Saharan Africa still accounts for 70% of global maternal deaths and nearly 2.4 million child deaths each year, while adolescents also face rising challenges of HIV, malnutrition, and limited access to mental health services. We therefore call on WHO and member states to expand access to essential services at the primary healthcare level, prioritize financial risk protection so no woman or child is denied care due to poverty, scale up community health work programs and digital health innovations, and ensure youth participation in decision-making, recognizing youth as partners, not passive beneficiaries. As IFMSA, we reaffirm our commitment to advocate, innovate, and stand with communities, because the health and well-being of women, children, and adolescents is not only a moral obligation, it is the foundation of sustainable development in Africa. Thank you.
Merci.
Thank you. I give the floor to Movendi International.
Thank you. Movendi International welcomes the commitment of member states to improve and promote the health and well-being of women, children, and adolescents. However, we are deeply concerned that this report does not address a key driver of preventable harm, alcohol. Alcohol poses a serious threat to public health in Africa, particularly for women, children, and youth. It's a major risk factor for maternal mortality, gender-based violence, child neglect, non-communicable diseases, and mental health issues, undermining progress towards key development goals. The rising harm from alcohol across African communities demands urgent action. We call on WHO and member states to prioritize alcohol policy within broader efforts to strengthen public health care and promote health equity. SAFER initiative offers a framework of intervention, and we are committed to supporting its integration into national strategies to protect the health and rights of African women and children to achieve the 2030 goals.
Merci. La parole est
Union for International Cancer Control.
Union for International Cancer Control applauded the progress made across African region in advancing the health and well-being of women, children, and adolescents. However, Union for International Cancer Control urged member states to invest in integrated RMNCAH and NCD services to deliver people-centered care by including people living with cancer and NCDC
to foster coordination and create an enabling environment to help and utilize guidance from WHO to prioritize interventions for women's health to maximize the dividends in health system. Also ensure the integration of core package of cancer and NCDC services basics and continue medical education and health packages. Lastly, we welcome the focus of a palliative and rehabilitation care supported by robust referral mechanism and urge government
Merci,
to
merci.
include
Thank you.
in cancer health service package.
La parole est maintenant
I'll give the floor for West African Alcohol Policy Alliance. Chairperson, distinguished persons, the West African Alcohol Policy Organization would like to support this agenda item. Unwanted pregnancies, gender-based violence, and mental health are closely linked to alcohol consumption. WAPA is inviting the Regional Committee of the WHO to envisage a progress report on the implementation of its plan during the next meeting in 2026. We would like to also extend this invitation to member states to strengthen their national systems and reduce the damage caused by alcohol that affects women, children, and adolescents in our region, because the effective implementation of the global alcohol plan is essential.
Merci pour votre
Thank you for your attention. I do not see any requests for the floor. The Secretariat is now invited to make any comments.
Chair, I think we recognize the timeliness of the recommendations in the technical outlined in the technical paper through the flagship initiatives, and look forward to working with you member states as well as with the partners that have expressed their support for the actions that are proposed. And therefore, we thank you very much for your contributions and the acknowledgement that we have witnessed through all the statements that have been received. Thank you.
Merci au secrétariat.
Thank you, Secretariat. Thank you for everyone's attention. The Secretariat has taken note of the remarks which have been made. Is the RC willing to adopt the regional strategy in the document AFR RC 75.5, accelerating progress in the health and well-being of women, children, and adolescents by transforming health systems in the African region? I don't see objections. In that case, it is decided. We are now going to move on to agenda item 11, addressing threats and galvanizing collective action to meet the 2030 malaria targets. This is pillar 1. The document number is AFR RC 75.8. RC 75.8. And Dr. Benido Puma will introduce this report. You have the floor, Doctor. You have 5 minutes. Thank you very much, Chair.
Pleasure to introduce the document titled Addressing Threats and Galvanizing Collection Actions to Meet the 2030 Malaria Target. Oh, I need... Excusez-moi, j'ai besoin de... J'aurais besoin d'une minute. So the presentation will focus on 3 points. The first one is, why do we need this framework? And then I'm going to provide a high-level overview of the framework, then conclude by highlighting some of the priority interventions and actions that are required to achieve malaria global technical strategy targets. We all know that malaria in this region remains one of the major killers with close to 400,000 deaths reported on a yearly basis. In terms of progress made in this region, as far as the policy side is concerned, we do have a global technical strategy, which was translated into a regional TVD strategy. We have what we call the high burden, high impact initiatives that aims at driving malaria response in high burden, high impact countries. The Yaoundé Declaration, which was adopted by member states. And then there are new bed nets and prevention treatments. And most importantly, this region has started rolling out malaria vaccine in a number of countries. Despite this great progress, there are several challenges that are persisting. One is none of the countries has achieved the GTS targets. In terms of funding, not only we are experiencing funding cuts, but there is also a gap of close to $4 billion US. We are also experiencing some insufficient coverage in terms of interventions. And lastly, given the ongoing humanitarian crisis and climate change, we're struggling to achieve malaria set targets. A number of interventions are proposed in the documents. They cover 4 areas. One, the health system strengthening area. Secondly, some of the flagships, multi-sectoral initiatives that are going on, and then the need to raise additional resources to address the malaria burden in this region. The need also for provision of technical support to countries in several areas. And then lastly, there's also a need to assure better coordination support given the broad range of partners who are involved in malaria response. As far as the coordination of support is concerned, one of the things we are doing is really which is suggested, is to document best practices in the prevention and response to malaria. Secondly, some of the malaria outbreaks that have been reported, especially in some countries from East and Southern Africa, there's a need to closely work with the emergency preparedness and response programs so as to be able to early detect these outbreaks and then respond to some of the malaria outbreaks. So these are a set of proposed actions which are submitted to the attention of the committee for your review and endorsement. Thank you.
Thank you, Dr. Mpoma. Now, we are going to open the list for member states to raise their flags. We're going to open the list first, and then we will suspend the point to restart tomorrow morning. So we're simply opening the list. We will continue tomorrow morning. If you would like to take the floor, please raise your flag.
Alors, pour les interventions sur la question que nous venons de clôturer,
regard to interventions on what we have just wrapped up with, you have Cabo Verde. Please lower your nameplate and let me call the countries Zimbabwe, Seychelles, Togo, Liberia, Gabon, Angola, Mali, the Gambia, Kenya, Chad, Mozambique, South Africa, Angola, Congo, Burkina Faso, Togo, Niger, Ethiopia, Eswatini, Equatorial Guinea, the DRC, Zambia, Uganda, and the Central African Republic.
Benin,
Benin. I've already called out Cabo Verde. That was the first country I called. Cabo Verde, Benin, Botswana. Madagascar. Tanzania. Zambia. It has been mentioned already. Please lower your name plate, please. Tanzania, Zambia, Mozambique. I think we didn't leave out anyone. I have the honor to of this special event organized on the theme eradication, transition, and sustainability. The Africa's Regions Polio Endgame. The event will present the progress and challenges related to the circulation of poliovirus in the African region and will determine the next phases of the transition for poliomyelitis in order to eradicate polio once and for all. The event will be coordinated by Mrs. Chipa Udwa, and I hereby cede the floor to her.
We will begin in just a few minutes. Please give us a few moments. That's fine. Okay. We know that we are running a bit behind schedule, but please bear with us while we make the transition to the next session. We hope that you can find the time to stay throughout. The next session is eradication, transition, and sustainability, the African region's polio endgame. So we're waiting for the distinguished panelists to join us here at the high table so that we can commence as soon as possible. All right, we are ready to begin this session. Distinguished delegates, observers, and members of the press. It is an absolute honor for me to be here with you at the 75th session of the WHO Regional Committee for Africa in this beautiful city. We find ourselves in Lusaka, Zambia. My name is Chika Odua, and I will be moderating this session. Firstly, I have to say that as a journalist, I am very much interested in the work of the WHO. And as a daughter of the soil, a daughter of Africa, I am very much inspired by the work that you all do to save precious lives here in this region, which we all lovingly call home. So I want to acknowledge and appreciate you all for the tireless efforts and the great impact being made on the ground to ensure that Africans not only survive, but also thrive in good health. It is truly a beautiful work that I imagine must require a great amount of passion, commitment, and selflessness. So once again, thank you all, and I'm sure I join the chorus of millions of people across this region to say thank you to the WHO Regional Committee for Africa. As I mentioned earlier, this session is called Eradication, Transition, and Sustainability, the African Region's Polio End Game. And I really like that word, end game. It has quite a bit of gravitas, so let us reflect on that word, end game. It is a powerful word to describe a powerful effort to permanently interrupt the transmission of all polio viruses and achieve eradication once and for all. And additionally, to facilitate the transition that would utilize existing polio structures to support other public health priorities. So that is what this session is all about. So for the next less than 2 hours or so, because time is clicking away as always, you will hear updates on polio eradication in the African region, concrete actions and commitment to strengthen polio response, surveillance, and routine immunization. Member states will also share progress updates, and of course, you will hear reaffirmations of commitment from crucial partners. So at this time, I would like to open the event to receive opening remarks. If the RD is with us, not quite sure, not yet. Okay, that's fine. At this time, let me explain the layout of what this session will be. This session actually features a part 1 and a part 2. Part 1 will focus on ending polio, on the effort to end polio outbreaks, while part 2 will hone in on the polio transition. Now is the perfect time to introduce the esteemed panelists who will be joining for this part 1. Okay, I'm just receiving a note that we will receive opening remarks. Representing the RD, we will have opening remarks. I'd like to call him forward at this time from Dr. Abdul Rahman Diallo, Director of Program Management, to give us the opening remarks.
Thank you very much. As I said, incoming DPM. Excellencies, Honorable Ministers of Health, distinguished delegates, partners at the Global Polio Eradication Initiative, colleagues and friends, good afternoon and welcome. Please allow me to convey the Regional Director's apologies. He's held up in a meeting and has asked me to represent him and deliver his opening remarks. So I'm delivering this message on his behalf. Ladies and gentlemen, thanks to steadfast partnership and tireless community efforts, we have achieved historic milestones. In 2020, the African region was certified free of indigenous wild polio virus. In 2022, the reimportation of wild polio virus into Southern Africa was swiftly contained. Madagascar closed its variant poliovirus type 1 outbreak this year. And the Democratic Republic of the Congo
is on the verge of ending type 1 transmission. These victories are hard-won and they must not be undone. Yet, variant poliovirus type 2 continues to circulate, particularly in the Lake Chad Basin and the Horn of Africa. Variant poliovirus type 3, once dormant, has re-emerged in 5 countries, revealing immunity gaps, unfortunately. In 2025 alone, hundreds of polioviruses have been detected across 15 countries. This is our critical window. GPI funding secured this year, but will shrink by over 30% in 2026. Cuts in US funding alone have already cost WHO more than 100 essential staff and $100 million annually for polio. The choice before us is stark: act decisively now or risk losing the progress we have fought so hard to achieve. WHO works with governments and our GPEI partners, UNICEF, Rotary International, the Gates Foundation, the US CDC, and Gavi, the Vaccine Alliance, to reach every child. This year, more than 200 million children in the region have received at least 1 dose of polio vaccine. The Gates Foundation has strengthened Africa's laboratory capacity. Rotarians drive local engagement. UNICEF leads community mobilization. US CDC provides technical guidance, and Gavi ensures vaccines remain available and affordable. This partnership is the backbone of our success. But polio eradication is not the end. It is the beginning of a stronger, more resilient public health system. We must retain and repurpose polio assets, skilled vaccinators and mobilizers, surveillance officers able to detect any disease early, strong laboratories, micro-planning tools, and mapping systems that can deliver measles, yellow fever, and routine childhood vaccines and maternal health services, even to the hardest to reach areas. This is already happening. In Angola, polio assets have supported the cholera response. In the Democratic Republic of the Congo, they have strengthened mpox surveillance. In Kenya, emergency operations centers coordinate responses to multiple health threats. And in Malawi, polio-trained staff are integrating immunization with preparedness planning. This is our vision: to turn the success of polio eradication into a permanent foundation for public health resilience. 15 countries in our region are designated as polio transition priorities, including Angola, Cameroon, Chad, DRC, Kenya, Mozambique, and Nigeria. The other 32 have already transitioned successfully. The challenge now is to sustain these essential functions as global funding declines without losing the skills, systems, and partnerships built over decades. To finish the job, we need 4 things: study-first political leadership, timely high-quality outbreak response, and bold coordinated transition plan, sustained partner and domestic investment. Excellencies, ministers, colleagues, ladies and gentlemen, Africa has beaten wild polio twice. Now, we must end all variants, safeguard our gains, and build systems that will protect generations to come. We have the evidence, we have the infrastructure, we have the will. Let us now deliver the legacy. Thank you very much.
Thank you, Dr. Diallo, for setting the tone for this session. Now is the perfect time to introduce the esteemed panelists who are joining Dr. Diallo for part one. We have, and we're very pleased to have Dr. Mohamed Gedi, the coordinator for the WHO African Region's Polio Eradication Program. Thank you very much for joining us, sir. We also have joining us on this first panel is Dr. Lydia Yasmin, Secretary General of the Ministry of Health of Madagascar. And Dr. Yasmin is representing the Honorable Minister of Public Health, Professor Dr. Zeli Randria Manatanai. Thank you so much for joining us. We also have joining us for this first panel is Dr. Chris Elias, representing the Gates Foundation as the chair of the Polio Oversight Board of the Global Polio Eradication Initiative and president of the Global Development Program for the Gates Foundation. Thank you so much for joining us, Dr. Elias. We also have Dr. Sadia Nishtar, the Chief Executive Officer of Gavi, the Vaccine Alliance, and we're very much aware that we have to keep to time so that she can stay with us for the rest of the program. And we also have joining us is Dr. Didione Mwamba Kazadi, the General Manager of the National Institute of Public Health in the DRC. He is representing the Honorable Minister, Dr. Samuel Roger Kamba Mulanda. Bienvenue, monsieur. Parts 1 and 2 will kick off with a visual presentation from Dr. Gedi, and then a brief video followed by 15 minutes of panel conversation, and then we will take it to the floor to hear from the member states. Very important to hear from you all. Delegates will have 3 minutes to make interventions and ask questions. And then this session will close with closing remarks from Dr. Elias and then from Dr. Abdurrahman Diallo. At this time, I would like to yield the floor to Dr. Gedi to make his presentation, and he'll be giving us a very profound overview of the polio situation in the African region. So if we can please put his presentation, there we go. Yes. Dr. Gedi.
Thank you. Thank you, Chika. I'll present to you a few slides on the progress, challenges, and plans to reaching to zero polio in Africa. This first slide is the situation of the wild polio virus. The last indigenous case of wild polio virus in the African region was in 2017 in Nigeria. This was a huge victory then, considering that at the time, northern Nigeria faced one of its most challenging security constraints, resulting in certification of Africa as polio-free. However, in 2001, we got a wake-up call. Pathogens do not have borders. Africa was reinfected through importation from Pakistan. The outbreak in Malawi and Mozambique brought out relentless efforts, sense of emergency, and coordinated and intense response activities across all the neighboring countries. Over 60 million children and more than 200 million doses were delivered to stop the virus. These actions proved decisive and saved the rest of Africa from reinfection. For the last 3 years, Africa is wild polio virus free. The other type of polio viruses that we face is the variant polio virus outbreaks. Type 1, the number of infected countries reduced from 4 to 2, while the number of isolates reduced from 15 to 3. Indicating a reduction of virus isolate of 67% in the last 1 year. Madagascar was a great victory, with an outbreak that lasted 4 years and paralyzing many adult children. Many adults stopped. Again, the key was political commitment, with the First Lady, the Minister of Health, and everyone leading from the front. The second type of variant polio outbreak that we face is the type 2. Here is where we have many countries still infected, even though there is a reduction in the number of virus isolated by close to 60%, and a reduction of infected countries by a third, with most of the countries in Southern and Western Africa stopping transmission. Type 2 still remains a challenge. The like isolates this year. While in East Africa, Ethiopia remains priority. Type 3 outbreak also affects 4 countries, with recent isolates in the Lake Chad region being a cause of concern. And outbreak response activities should be prioritized with a sense of urgency. Political commitment and government leadership is the foundation and the cornerstone of stopping transmission of polio. Malawi, Mozambique, Madagascar, and indeed many of the countries that have succeeded is because the response efforts was done with a sense of urgency, and the government led the response activities from the front. We need innovations and target plans to reach to zero, especially in the most difficult areas. Use of GIS technology in micro-planning, tracking of vaccinators during the campaign, One Health approach, especially for hard-to-reach and nomadic populations, real-time reporting and monitoring, as well as use of technology in strengthening our surveillance is key to reaching to zero, especially in the geographies that we have issues. We also need to accelerate routine immunization and other priority health interventions. The communities that are infected with polio are also deprived of other services, and therefore integration of polio efforts with other health interventions such as vitamin A supplementation, deworming, reaching interventions for malaria and NTDs are very important, but also using the polio infrastructure to support routine immunization and the intensification interventions for routine immunizations, such as the big catch-up, is key. Early detection of outbreaks is fundamental to prompt response. The expansion of the ES and wastewater surveillance is key to achieving polio eradication. From just one country in Nigeria in 2011 with environmental surveillance, today we have the entire Africa covered, with 46 out of 47 having environmental surveillance sites. This has resulted in earlier confirmation of outbreaks in the region and therefore timely response activities. The expansion of laboratory testing and sequencing has also been another proud moment for the region. For the first time in Africa, all samples in Africa are cultured in Africa and sequenced locally in 4 labs in the region. In fact, we support outside of the continent and outside of the Africa region with support to Yemen, Djibouti, and Somalia. We've also leveraged on the environment, on the lab and the environmental surveillance system to do a multi-pathogen detection, including for SARS-CoV-2, influenza, mpox, cholera, among others. So this is what the roadmap looks like. The first WPV done. All outbreaks, ongoing outbreaks of VDPV2 is done for Madagascar and DRC, but there is an infection in DRC. We are on track in DRC, but at risk of not achieving the target in the Lake Chad Basin region. So in conclusion, I'd like to take this opportunity to appreciate the member states for the high-level political commitment to synchronize response activities across borders and timely response activities. As we move to zero, we need to continue to review performance and take corrective actions, especially in poor performing or low performing geographies. Acceleration of routine immunization is key. We've had also several orphan viruses in some of the areas, and reviewing gaps in surveillance to ensure early detection and response is also key. And finally, I think the reality is that we have to adapt to the new physical environment and raise resources locally. Thank you.
Thank you so much, Dr. Getty. That presentation is a great segue to the upcoming video from Chad, which shows how frontline workers are doing everything possible to ensure that no one is left behind. So please take a look at this video.
Le nomade voyage d'un pays à un autre, traverse une frontière à une autre, et la circulation de cette population d'un point A à un point B, surtout aussi un vecteur pour véhiculer la maladie. Et du coup, les enfants bien vaccinés sont très protégés et selon leur déplacement, constituent quand même, permettent quand même de répliquer contre toutes les maladies. On a réfléchi pour faire le polio pour les enfants et on a acheté aussi pour la petite. Et nous faisons aussi notre la région et va à maintenant, deuxième dose de BPI, 21, si c'est comme ça, c'est mon pays qui défend aussi pour mon pays, pour mes enfants.
So there you have it. In the beautiful diversity that we call humanity, nomads still dwell among us, some of the oldest human populations in the entire world. It is quite compelling to see that the WHO African region has not forgotten this very unique set of demographic nomads are being put into consideration. I know from experience as a journalist that nomads are not an easy people to reach. You may knock on the door and sometimes no one answers. So it is good to hear that WHO is still trying to make them part of their efforts. Human diversity is incredible indeed. So without further ado, let us commence the panel. The panelists will share lessons learned and recommendations. As part one is focused on ending polio outbreaks, I'd like to start with Madagascar. We heard a few words about the success stories being experienced in the country of Madagascar. Just a few months ago in May, the country marked 2 full years without any new detections of the virus. So congratulations
congratulations, Dr. Yasmin, to you. We all celebrate your country's achievement in stopping the transmission of the variant poliovirus type 1. I also understand that a state-of-the-art laboratory is in place to bolster your country's efforts to survey and detect polioviruses as well. Well done. So my question for you, Dr. Yasmin, as the Secretary General of the Ministry of Health for your country, can you share the lessons that were learned, key lessons that were learned from the polio response, lessons that you feel other countries can take from? Because if we break it down properly, the government was able to coordinate so many things at the same time, a response that included strengthening surveillance, coordinating a quality campaign that's very clear, quality campaign, and also steering community engagement. So what lessons were learned from all of this?
Merci beaucoup, Madame la modératrice. Excellences, Mesdames et Messieurs, distingués invités. Comme expérience dans la gestion de l'épidémie de poliomyélite à Madagascar, comme contexte, suite au cas de CVD-PV type 1 détecté à Madagascar, nous avons fait cette campagne nationale de vaccination, dont 4 en 2023 et 3 en 2024. Les derniers cas détectés étaient en septembre 2023. Et l'OMS-AFRO a annoncé à l'occasion de l'Assemblée mondiale de la santé la fin de l'épidémie de polio, après l'évaluation, bien sûr, concluante faite par l'équipe au bras. Qu'est-ce qu'on a fait et comment on a procédé? En matière de gouvernance, il y avait l'engagement politique de haut niveau par Monsieur le Président de la République lui-même et Madame la Première Dame, ayant facilité la coordination, la mobilisation sociale et la mobilisation des ressources. Il y avait le lancement officiel de la campagne sous l'élide de la Première Dame, auquel elle s'est engagée pour être la marraine de la vaccination. Il y avait aussi l'adoption en Conseil des ministres de toutes les activités de vaccination faisant impliquer tous les autres ministères. Pour la coordination et la mise en œuvre, nous nous sommes alignés absolument aux directives et orientations de GPI et de l'OMS. On a rendu opérationnelles les structures de coordination. Il y a l'incident manager étant le point focal qui collaborait avec le GPI. Nous avons également fonctionnalisé le comité de coordination interagence CCIA décisionnel qui regroupe en fait divers ministres et également le CCIA technique. On a ainsi activé le centre des opérations d'urgence polio au niveau national avec la définition des mécanismes clairs de coordination nationale, régionale et des districts. On a adopté des approches d'intégration en mutualisant les ressources, intégration de la campagne polio avec d'autres campagnes ou intégration d'autres campagnes avec la campagne polio. Nous avons fait également la cartographie de la chaîne de froid, les déploiements rapides des intrants suivant le plan de distribution avec utilisation des drones ou des vols humanitaires spéciaux pour les zones difficiles d'accès. On a suivi rigoureusement les tableaux de bord de toutes les activités y afférentes. Et il y avait même le suivi direct par Monsieur le ministre lui-même avec interpellation, voire sanction allant jusqu'à l'abrogation au poste ou affectation disciplinaire des agents des régions et des districts qui sont peu performants. En termes de surveillance, il y avait l'extension des sites de surveillance environnementale et l'optimisation de la qualité de notification, d'investigation de cas de PFA par les régions avec collecte et transport sécurisé des échantillons en se conformant catégoriquement aux normes. Et concernant les campagnes de vaccination proprement dites, on a misé à ce que ce soit de qualité avec un mécanisme de coordination bien établi. Pour les 7 campagnes nationales, tous les moyens, toutes les stratégies ont été adoptées pour maximiser la couverture et surtout pour rendre cohérents les résultats administratifs avec les résultats de l'enquête LQAS. On a réalisé la microplanification exhaustive et ascendante, déployé des équipes mobiles spéciales dans les zones enclavées ou couramment à faible couverture. Nous avons engagé toute l'équipe de supervision afin d'être rigoureuse par rapport à la qualité de la campagne, notamment par rapport à la qualité des données. Et à propos de l'engagement communautaire, il y avait le portage politique de la Première Dame via son association et la mobilisation sociale par le biais des partenaires et de la plateforme des sociétés civiles. Il y avait donc l'implication des leaders communautaires, religieux traditionnels, ainsi que la mobilisation faite par le jeune ambassadeur de la vaccination. Il y avait l'engagement des opérateurs téléphoniques pour la diffusion des SMS gratuits et on a cartographie des poches de refus et dispositifs de retour d'informations. Que peut-on retenir alors comme recommandation pratique? S'assurer qu'il y ait un engagement de haut niveau, institutionnaliser le centre d'opération d'urgence polio avec un bon mécanisme de coordination, mutualiser les ressources, les interventions avec des approches diversifiées, ciblant chaque enfant, mettre en œuvre le plan de déploiement des intrants avec un accent particulier pour les zones enclavées, assurer une bonne qualité des données avec zéro tolérance en cas de rapport fictif ou de mauvaise foi, s'assurer de la qualité de la surveillance de paralysie flasque aiguë ou environnementale, s'assurer de la bonne microplanification et des supervisions strictes, et enfin structurer l'engagement communautaire avec mapping des influenceurs et mobilisation de toutes les parties prenantes pour être le messager sans rater à la moindre occasion. En conclusion, le succès de Madagascar est un puissant rappel que l'éradication de la polio n'est possible qu'avec un effort coordonné, une surveillance robuste, des campagnes de vaccination de qualité et une forte appropriation de la part des communautés. La volonté politique alliée à l'innovation et à l'engagement local est la clé pour mettre fin aux épidémies de la polio, même s'il y a des limitations des ressources. Je vous remercie.
Excellent. Thank you so much, Dr. Yasmin. A well-concerted effort surely paid off. Well done. Well done. Thank you so much for that. And we'll still come back to you to talk about the polio transition experience in Madagascar as well. Thank you so much. While we still have the CEO of Gavi with us, let's now talk about partnerships. Gavi, the Vaccine Alliance, has been there through the highs and the lows of the fight against polio virus. So Dr. Nishtar, I'd like to bring you into the conversation at this time to talk a bit about Gavi 6.0. Priorities for polio eradication, the strategy for 2026 to 2030 places a great emphasis on something that was just mentioned by Dr. Yasmin, country ownership. Countries really need to own what we're doing here. It is part of the effort to end the polio virus once and for all. So therefore, Dr. Nishtar, can you tell us, how do you see Gavi 6.0 complementing the goals that are already in place for polio eradication in the African region?
So thank you very much for giving me the floor, and it was fascinating to hear about the efforts in Africa to tackle the problem, and thank you for that brilliant overview. In terms of your question, polio eradication is deeply embedded in Gavi 6.0. It's one of our priorities. We actually have a strategic overlap because one of our objectives is to reach out to zero-dose children. And the objective of the polio program is also to reach hard-to-reach areas. So there's a natural synergy between the work that we do. The other strategic overlap is the salience of routine immunization. That's the bread and butter of what we do. And the polio program, that's an essential bedrock. We use the same systems, we interface with the same stakeholders, we have the same policy avenues. So at a strategic level, there is complementarity, and that complementarity has been reinforced in 6.0. We also have a lot of programmatic synergy and programmatic integration already playing out, and that programmatic integration and synergy is being further reinforced in 6.0. You laid out one of the speakers laid out the entire ecosystem of how the polio eradication efforts get underway on the ground. There is a whole range of agencies that play their part, including WHO, the polio program itself, Gavi, CDC, and other partners. So one of the roles that we play is to finance the IPV vaccine standalone, and increasingly the hexavalent vaccine, and both of these have been included as the vaccines that we will continue to support in 6.0. Of course, we piggyback on each other a lot. In many countries, in many large countries, the way we identify zero-dose children is because we work very closely with the polio program. And of course, a lot of times polio uses the routine immunization infrastructure. So there's another programmatic synergy there. We have increasingly been co-delivering vaccines through routine immunization and campaigns and big catch-up activities. I mean, the integration of, in Pakistan, the integration of polio vaccination into the measles campaign forthcoming in Q4 this year is an example. And there are many other examples of how we integrate our activities during big catch-up campaigns, during zero-dose campaigns, during routine immunization and other campaigns. And then, of course, there's a huge joint learning agenda. And we share notes from our learning investments very actively. Gavi heavily invests in fragile contexts. There is a program called the Zero Dose Implementation Program, and there are learnings which we as close partners share. One of the things that we learned from the polio program's investments, and I'm just giving you one snippet example, there are hundreds others, is their investments in artificial intelligence layered on top of geospatial mapping to identify hard to reach areas and difficult pockets. And these are things that we share actively and then scale up as required. We also have alignment in 6.0 on what countries need to do, strengthening routine systems, cross-border collaboration, domestic resource mobilization, and essentially new ways of working. There's a deep realization that we have to, in this extreme environment of resource constraints, we have to find new ways of working. We have to integrate better. We have to exploit synergy better. That countries have to step up with reference to domestic resource mobilization, and that we as external partners, with the advantage of bringing global tools to the table, must play a part in empowering countries. So country ownership is a very important part of 6.0 and the Gavi Leap. And that is what is very saliently important for GPEI as well. And as I mentioned in the Lake Chad Basin polio discussion in the morning, this is not theory that I'm sharing with you. There is practical, there are practical examples of how these things are playing into implementation. The boards of Gavi and the Polio Oversight Board have met together for the first time. A few weeks ago, I wear two hats here. I'm the CEO of Gavi, but I'm also a member of the Polio Oversight Board that Chris Elias chairs. So our boards have met for the first time, and our boards have agreed on the need to improve targeting and coverage of routine vaccines, including IPV and Hexa. Both the boards have agreed that there has to be a more systematic and comprehensive approach to integration. We at Gavi is calling for merger at the last mile as part of the Gavi Leap. And both the boards of Gavi and POB agreed that there needs to be systematic, more mandatory integration. So let me assure you that Gavi 6.0 will accord high priority to polio eradication efforts, and that we will continue to coordinate very, very closely.
Thank you, Dr. Nishtar. There were a few buzzwords that stuck out to me: strategic overlap, synergy, and piggyback. So thank you for giving that commitment to sustain the efforts that are on ground for the WHO. Let's now bring the DRC into the conversation. We have Dr. Kazadi representing the National Institute of Public Health for the DRC. We heard a bit earlier about some of the responses coming from the DRC. And the DRC, as many of us know, is operating in a context that is quite complex. However, the DRC has made remarkable progress towards stopping the transmission of variant poliovirus type 1 and type 2. They are dealing with an environment that includes conflict, many of us know this, and also competing health priorities. And by that, I am referring to the Mpox, I'm referring to cholera as well as measles outbreaks. And also, Dr. Kazadi, if I can just ask the question, what additional support or innovations would help your country's Ministry of Health to accelerate progress to stopping poliovirus transmissions in provinces where there are so many risks and complexities?
Oui, merci pour la question. Là, en RDC, j'aimerais circonscrire d'abord le contexte, comme vous l'avez dit, c'est marqué par plusieurs défis, notamment avec plusieurs flambées épidémiques de rougeole, de Mpox, choléra, qui frappent nos populations. Et malgré toutes ces épidémies, l'RDC demeure mobilisée et déterminée dans la lutte pour l'éradication de la poliomyélite. Et pour montrer cet engagement, juste rappeler le contexte qu'entre 2022 et 2025, la République démocratique du Congo a réalisé des exploits remarquables. C'est notamment celui de réduire de 99% les cas confirmés de poliovirus variant, et qui est passé de 540 cas confirmés en 2022 à seulement 7 cas confirmés pour 2025. Donc ces chiffres témoignent de la détermination de la RDC dans l'efficacité et démontre dans notre détermination dans la mise en œuvre efficace de nos stratégies et de la qualité de notre partenariat avec l'Initiative mondiale d'éradication de la poliomyélite. Alors, mais les défis demeurent, comme vous l'avez dit, c'est que nous sommes confrontés à des obstacles majeurs sur ce chemin avec l'insécurité qui touche pratiquement la majeure partie de l'RDC, notamment les provinces de l'Est, où nous avons plusieurs provinces qui sont touchées par l'insécurité, le Nord Kivu, le Sud Kivu, la province du Tanganyika, du Maniema. Et toute cette question d'insécurité entrave nos efforts de surveillance épidémiologique et de vaccination. Et à cela vient s'ajouter les déplacements de nos populations qui vivent alors dans des conditions sanitaires précaires et avec augmentation des risques des flambées. Et nous faisons face aussi à des défis logistiques complexes, notamment les ruptures de stock de vaccins, les retards dans le transport des échantillons et aussi la mise en œuvre tardive des campagnes réactives et parfois aussi la résistance communautaire à la vaccination. Alors face à cela, il a fallu avoir des stratégies d'adaptation. Alors face à ces défis, la RDC a développé une approche multidimensionnelle qui s'est matérialisée par d'abord le renforcement de la coordination locale en impliquant les forces armées dans les zones d'insécurité, aussi en travaillant au plus proche avec les autorités gouvernementales et aussi les acteurs non gouvernementaux. Deuxièmement, c'est aussi l'établissement de collaboration transfrontalière robuste et avec les pays voisins et la mobilisation active des organisations non gouvernementales locales, surtout pour la logistique et la supervision. Nous avons mis aussi en place des stocks tampons de vaccins et développé des stratégies de micro-planification au niveau de ces provinces prioritaires. Et nous continuons à mener une sensibilisation très intense de nos communautés avec le soutien précieux des leaders politiques, des leaders religieux et surtout des leaders communautaires. Alors, quelles ont été aussi les innovations qu'on a dû apporter au niveau de services et de la santé? Alors, concernant les innovations, la RDC a innové, a continué à innover pour surmonter ces difficultés. Et nous avons développé, par exemple, des corridors humanitaires pour assurer l'acheminement des vaccins, même dans les provinces en insécurité, sous occupation, où les aéroports ont été fermés, notamment au niveau du Nord Kivu, au Sud Kivu. Les corridors humanitaires ont permis d'acheminer les vaccins pour la vaccination de routine, et ce pour au moins 4 mois. Aussi, parmi les innovations, c'est les solutions numériques. Nous avons développé des solutions numériques avancées avec des micro-planifications digitales, le renforcement de la surveillance épidémiologique électronique et aussi l'utilisation de systèmes de paiement par les compagnies de paiement mobile, parce qu'on ne sait pas amener de l'argent dans des zones d'insécurité. Un autre modèle qu'on a eu à développer, c'est des modèles de campagne modulaires, donc qui sont adaptés dans les zones à conflit, où on a eu à avoir un cadre de riposte avec des modules indépendants qui sont adaptés à ces zones, aux conditions locales de sécurité, d'accès et de disponibilité de ressources. Et une autre innovation qu'on a dû mettre en place, c'est le suivi en temps réel des activités de campagne de vaccination avec des tableaux de bord dynamiques, les cartes de risque et de priorisation de localisation géospatiale des cas de polio pour permettre de suivi en temps réel de ces campagnes de vaccination et des alertes. Et aussi, on a eu à avoir des espaces, des réunions de coordination pour les équipes techniques et des zones de communication et de briefing en interne et en externe lors des campagnes de vaccination. Donc, en conclusion, nous osons dire que la RDC se tient fermement aux côtés de l'OMS et de tous nos partenaires pour atteindre notre objectif ultime, qui est celui d'une Afrique et d'un monde libéré à jamais de la poliomyélite. Les progrès que nous avons réalisés avec cette réduction spectaculaire de 99% de cas de polio variant montrent le fruit d'un engagement sans faille, d'une résilience collective exceptionnelle et d'une innovation toujours constante et permanente. Il prouve que même dans les contextes les plus difficiles, comme celui de la RDC, l'impossible devient possible quand la volonté politique rencontre la solidarité internationale. Donc nous faisons un front commun pour protéger chaque enfant congolais et chaque enfant africain, enfant du monde, et ensemble nous pouvons écrire ce dernier chapitre de l'histoire de la poliomyélite et garantir un monde et un avenir sain et libre de poliomyélite. Je vous remercie.
Thank you so much, Dr. Kazadi, for painting such a realistic portrayal of what is happening in the DRC. It is indeed a complex picture, but it is an honest one. So thank you very much for that. As Dr. Nishtar had to leave in her place, we are very thankful to have with us on the panel, Tabani Maposa. Thank you very much for joining us, Managing Director for Country Delivery Department for Gavi. Thank you very much. Let us now move to the floor so that we could hear from the member states. This is your opportunity to pose a question to any of the panelists. So please, if you would like to just raise your card and keep your interventions to 3 minutes on the topic of ending polio outbreak. So please, if anyone would like to kick us off first from the floor, any of the member states here, ending polio outbreaks. We also have a few designated members who are prepared to speak. So if you're ready, just raise up your card and we will address you right away. Okay, we have delegate from Guinea. Can't quite make out where Guinea is. Okay. Is Guinea with us? Okay, I'm sorry, I couldn't see. So Guinea was the first country. I just want to ask for a few comments on the situation in Guinea, because Guinea was the first country to co-administer the BOPV as well as the NOPV2 vaccine. So I'd like to find out from the delegate from Guinea, how was this strategy impacted and how has it actually been carried out to control the outbreak and routine immunization efforts?
Merci, Madame la modératrice. Merci aux panélistes, chers membres des États. La Guinée a été le premier pays à signaler la circulation du variant de poliovirus de type 2, de type 3 en 2024, alors qu'elle était déjà confrontée au type 2. Ceci a entraîné le pays à mettre rapidement en place une riposte avec la co-administration du VPO-B et du VPO-N2, ce qui n'avait jamais été fait auparavant. Cette approche innovatrice est maintenant utilisée dans d'autres pays avec la co-administration des deux variants du poliovirus. Quels ont été les défis opérationnels et les succès observés dans la mise en œuvre de cette stratégie? En termes de planification, les défis ont été la coordination, la mise en place d'une coordination à tous les niveaux, niveau central, niveau régional, niveau district, sous-district et même au niveau communautaire. Appuyé par une logistique de distribution de porte-vaccins homologués, l'utilisation d'une seule et même fiche de pointage pour les deux antigènes, l'administration des vaccins, sécurité de l'administration de 4 gouttes au lieu de 2 gouttes, en s'assurant qu'on a 2 gouttes pour chaque type d'antigène. La communication, l'adhésion et l'engagement de la communauté a permis de faire le succès. Pour aller vite en termes de succès, nous avons enregistré des gains de temps. La co-administration a permis de réduire considérablement le temps nécessaire à l'organisation de 2 campagnes en les emmenant en une seule. Des gains financiers. Cette campagne devient moins coûteuse à la place de 2. Nous avons enregistré le coût unitaire par enfant de 0,96 au lieu de 1,77 $ par campagne séparée. La sécurité vaccinale, moins de cas de MAPI ont été observés. Dans le cas de la Guinée, au cours de la campagne, nous avons notifié juste un seul cas dans une de nos régions qui a été prise en charge. La communication et l'adhésion communautaire, il faut noter que l'implication des autorités locales a été cruciale dans l'acceptation des 2 vaccins et a permis de lever les réticences. Nous avons utilisé aussi le GTS, le système de tracking, dans l'implémentation de la campagne, pour faire le suivi des districts prioritaires, ce qui nous a permis de suivre les équipes de vaccination et visualiser les couvertures géographiques effectives en zone rurale.
If you can just round up, sir. Thank you. Thank you very much.
L'impact, d'accord.
I could take it there, sir. Thank you very much. We understand, and certainly the co-administration of both of these vaccines was quite innovative. Thank you very much. Let's now hear lessons learned from Nigeria. Nigeria remains a critical country in the fight against polio due to its sheer size and complexity. The country has implemented a strategic shift to improve the quality of the polio campaigns conducted this year in 2025. So I'd like to ask the delegate from Nigeria, could you please elaborate on the rationale and the key points of the strategic shift and the progress made? Thank you very much, Nigeria.
Thank you very much. And to appreciate the team on the high table for the support they've been giving Nigeria and other countries affected. We had to make a strategic shift because of the persistent challenges we've seen in our country that is affecting the circulation of the variant type 2 virus and type 3 that have just been detected. We had challenges such as poor team quality, those that go to the field, non-compliance, inaccurate data, and weak accountability. And as a result of this, we make this strategic shift. And what did we do? Campaign quality. We ensure that traditional leaders in the communities that are affected are now the one selecting the teams that we move from one place to the other to ensure vaccination takes place. We also deployed international independent observers to validate the training, the direct observation of house-to-house campaign, vaccination campaign, and independent supervisors of these teams. We deployed staggered campaigns for stronger oversight. We also deployed additional instruments for advocacy, communication, and social mobilization by engaging local civil society organizations who are very familiar with the area, and they engage in driving demand. They help assisted in resolving non-compliance and also expand non-compliance resolution teams. On data, enumeration of all children and the use of identify, enumerate, and vaccinate strategy for accurate micro-planning and vaccination tracking. And lastly, accountability, real-time performance tracking, and strict enforcement of accountability across all stakeholders. So these were the strategic shifts we had to do, and it has given us some encouraging results. More local governments, additional about 37% of more local governments have now been covered. Vaccination coverage jumped by 7% using the geo evidence, and vaccination coverage from 81% to 84%. And we deployed the loss quality assurance sampling that has given us a pass rate from 85% that we used to know to 93%. And this happened between April and June. And we intend to intensify effort in this direction.
Thank you very much. We appreciate those lessons learned. And we've made several references this evening to the Lake Chad region, which continues to experience an intense circulation of the variant poliovirus type 2. I'd like to now call upon the delegate representing Chad to hear what mechanisms that the country of Chad has put in place to strengthen cross-border coordination for polio vaccination and surveillance. If we can hear from the delegate representing Chad, please.
Merci, Madame la modératrice, Mesdames et Messieurs les membres du Présidium, distingués invités. Je voudrais très sincèrement vous dire merci pour ces deux questions et rappeler surtout que le Tchad continue de faire face à une circulation active du poliovirus dérivé de type 2 avec un risque élevé de propagation, bien évidemment transfrontalière, avec des pays comme le Cameroun, le Nigeria, le Niger et la République centrafricaine. Conscient de cette menace, nous avons mis en place plusieurs mécanismes pour renforcer la coordination régionale et éviter que les populations mobiles, les populations nomades que vous avez vues tout à l'heure, les populations insulaires ou encore les populations déplacées ne soient exclues des campagnes. Je voudrais rappeler surtout que les populations nomades, par exemple au Tchad, la santé de l'enfant du nomade ne le préoccupe pas autant que la santé de son animal. C'est un mode de vie qui est comme ça et c'est très difficile de pouvoir les sensibiliser. Il va falloir déplacer pratiquement les services auprès de ces populations qui se déplacent tout le temps à la recherche de pâturage. Quels sont les mécanismes que nous avons mis en place? Premièrement, nous participons aux campagnes synchronisées régionales avec le vaccin NOPV2 organisé avec les autres pays du bassin du lac Tchad, visant en réalité à couvrir un peu plus de 83 millions des enfants de cette sous-région. Et cette approche simultanée permet en réalité de réduire les risques de réintroduction du virus d'un pays à un autre. Deuxièmement, le Tchad a intensifié également la surveillance des PFA et environnementales, particulièrement au niveau de la capitale N'Djamena et dans les zones frontalières, afin de détecter rapidement toute circulation virale. Ces efforts sont accompagnés par des mécanismes de partage des données en temps réel avec bien évidemment les pays voisins que je venais de citer tout à l'heure, mais également avec l'OMS Afro. Dernier point, c'est plutôt les plans conjoints de riposte transfrontalière qui sont en réalité mis en œuvre, et cela inclut des réunions techniques régulières avec des pays comme le Niger, le Cameroun, la RCA ou encore le Nigeria, pour harmoniser ensemble les calendriers de vaccination et coordonner les différentes interventions. La dernière partie de votre question, nous insistons pour dire que nous travaillons avec les partenaires humanitaires présents sur le terrain pour cibler spécifiquement les populations mobiles, réfugiés, nomades, déplacés, et particulièrement dans l'Est de notre pays, où se trouvent des centaines de milliers de réfugiés soudanais, comme vous le savez. Et ces partenaires nous aident à déployer des équipes mobiles, à impliquer également les leaders communautaires et à assurer que la vaccination atteigne les zones difficiles d'accès. Notre objectif est bien évidemment d'interrompre la transmission d'ici décembre 2025. Mais pour y arriver, nous avons besoin du soutien continu des partenaires techniques et financiers, notamment pour assurer un financement flexible, garantir l'approvisionnement en vaccins et renforcer la logistique et la communication sociale.
Thank you, sir.
Merci.
We have to end you there. We appreciate your remarks. We have a question or a remark coming from the delegate representing Angola. For Angola, I will yield the floor to you to raise your remark or question.
Muito obrigada, senhora moderadora. A Angola está atualmente a gerir surto de polivírus derivado de vacina tipo 2, oficialmente confirmado no dia 13 de março de 2025, após a detecção de vírus na província de Bengala. Até o momento foram confirmados 20 casos em 8 das 21 províncias. Este surto foi classificado como uma emergência do nível 2 e está a receber uma resposta coordenada em todos os níveis, com forte envolvimento dos governos provinciais e municipais e apoio essencial da Iniciativa Global da Erradicação da Polio, e estamos a agir com rapidez para conter o vírus. Todas as províncias afetadas já realizaram pelo menos uma ronda de vacinação. A vigilância, paralisia flácida aguda e vigilância ambiental foram intensificadas, e estas medidas são fundamentais para deter rapidamente novos casos e interromper a transmissão. Entre os dias 13 e 15 de agosto, concluímos a primeira fase da campanha nacional de vacinação e tenho orgulho de informar que atingimos 95% da cobertura administrativa. Mais de 6,8 milhões de crianças com menos de 5 anos foram vacinadas. Isso só foi possível graças ao apoio integral da GPI, que financiou tanto as vacinas como os custos operacionais. Estamos agora a preparar a segunda fase, agendada para os dias 5 e 7 de setembro. No entanto, os nossos esforços enfrentam desafios. Uma epidemia de cólera que ocorre em simultâneo está a pressionar o nosso sistema de saúde, especialmente nas províncias mais afetadas. Estamos a trabalhar para melhorar a logística e a coordenação, garantindo que nenhuma criança fique de fora destas crises sobrepostas. Quero ser claro, o surto de pólio continua localizado e estamos a fazer tudo o que é necessário para manter o seu controle. Agradecemos à OMS e todos os parceiros, nomeadamente a Gavi e a Unicef, a Fundação Gates, neste momento crítico. E que podemos concluir esta missão e garantir que a polio não tenha futuro mais no nosso país. Muito obrigada.
Thank you very much. I'd like to invite Dr. Getty to respond to the delegate from Angola.
Thanks, Chika. I think it was more of a comment on how they're doing. But I think the recurring message is, a sense of urgency, coordinated response activities, and intensification of the response activities. WHO, other partners, including UNICEF, are on ground to support. Angola is one of the countries that is prioritized as an outbreak response country, and we're there to support. Thank you.
Thank you, Dr. Getty. Now let's go to the member state. Tanzania would like to make a remark. If you can just keep it to 2 minutes, please. We're quite low on time. Tanzania, 2 minutes.
Thank you, moderator. The last indigenous white polio case in Tanzania was in 1996, and the country achieved the white poliovirus polio-free status in 2015. However, in 2003 and 23, there has been an importation of circulating vaccine derived polio type 2 from AFP cases. But also there has been environmental isolation for the first time, which has continued from 2024 to 25 in a single region in Tanzania. The isolation of the vaccine derived polio virus type 2 in the country, together with the other gaps like suboptimal AFP, surveillance in some districts, inadequate vaccination coverage, low population immunity, and the frequent population movements across the borders are the indication that the country is still at risk, and therefore highlights the necessity of maintaining the global polio eradication initiative infrastructure. To sustain the white polio-free status, Tanzania has in place policy guidelines to ensure that all eligible children are vaccinated through routine immunization, catch-up, FIRI, and supplemental immunization activities to attain high population immunity to poliovirus. So Tanzania is committed to ensure that polio eradication goals are realized within the set timelines. Thus, we'll continue to implement the polio eradication activities in accordance to guidelines focusing on integrating polio essential functions that include detection, sample referral for laboratory testing, and outbreak responses within the existing surveillance systems in the country.
We have to end you there. Thank you so much. Thank you. We appreciate your remarks. And lastly, I'd like to give the floor to the delegate representing Mozambique for an intervention. 2 minutes, please. Mozambique.
Muito obrigado pela palavra. Queria também aproveitar esta oportunidade para partilhar a experiência de Moçambique. Moçambique, em 2022, registrou um total de 8 casos do poliovírus selvagem tipo 1. Frente a esta emergência, o país priorizou intervenções imediatas para cortar a cadeia de transmissão através de campanhas de vacinação e reforço da vigilância ativa, da paralisia plácida aguda. Paralelamente, implementamos medidas para reforçar o programa alargado de vacinação e consolidar um sistema de vigilância integrado, robusto e eficiente. A resposta à poliomielite no país foi particularmente complexa. Moçambique lidou simultaneamente com o poliovírus selvagem tipo 1, o poliovírus circulante derivado da vacina tipo 1 e o poliovírus circulante derivado da vacina tipo 2. Adicionalmente, a identificação de casos de poliovírus 1 em crianças acima dos 10 anos exigiu ajustar a faixa etária de vacinação no nosso país, passando de 5 anos para menores de 15 anos. Apesar desta complexidade, Moçambique realizou, até finais de 2024, 11 rondas de vacinação contra a poliomielite, num período de cerca de 18 meses, atingindo cerca de 23 milhões de crianças. Realizamos 2 rondas nacionais contra o poliovírus tipo 2 e alcançamos 20 milhões de crianças menores de 10 anos. É importante destacar que em todas as intervenções, as nossas coberturas administrativas superaram 100% e a avaliação independente de coberturas que confirmou a melhoria em cerca de 93%. O engajamento político nacional foi um favor decisivo. Moçambique está comprometido na erradicação da polio e muito obrigado pela atenção dispensada.
Thank you very much. We appreciate those interventions. Well, at this time, distinguished delegates and observers, members of the press, we have come to the end of part 1 of this session. We have gained many insights, including how Madagascar took the bull by the horns in its response to the polio virus. And also we learned what it truly takes to tackle the virus in the midst of ongoing conflict and other disease outbreaks. So a round of applause for the panelists, please. And as we end part 1 and prepare for the second part of the session, I would like to invite now Dr. Kazadi and Mr. Mamposa to exit the stage. And Dr. Yasmin, Dr. Elias, Dr. Getty will remain on the stage along with Dr. Diallo. So you can exit the stage while we can prepare for the next panel. So for part 2, we will shift our focus to the polio transition. And for this second panel, I would like to invite to the stage the esteemed delegate from Malawi's Ministry of Health. Please, a round of applause as she comes forward. Dr. Lillian Chunda, Chief of Health Services, representing the Honorable Dr. Chiponda, Minister of Health and Population for Malawi. Thank you so much for joining us. We are also very pleased to have joining us in panel number 2, Dr. Akpaku Kalu, the team lead for the WHO African Region's Vaccine Preventable Diseases team. Please, a round of applause as he makes his way forward to the table. Very weak applauses. Thank you very much, Dr. Kalu. The delegate from Kenya was not able to join this session, so therefore Dr. Yasmin has graciously agreed to remain for the second panel. As many of us know, currently there are 15 member states considered as priority for polio transition in the African region. Therefore, this discussion is a very important and timely one. So let's start once again with a presentation that will give an overview of the polio transition efforts. I'd like to yield the floor to Dr. Getty to make a second presentation.
Thank you, Chika, once again. So this presentation is on polio transition. As we inch closer to a polio-free world, polio transition is an opportunity to sustain the infrastructure that was set up to eradicate polio, to repurpose it for strengthening health systems, bolster global health security, and make progress towards a broader health goals. So in 2018, the World Health Assembly endorsed the WHO's Strategic Action Plan on polio transition. The plan had 3 goals: to sustain polio-free world, to strengthen immunization systems, including surveillance for vaccine-preventable diseases, and to strengthen emergency response, preparedness, detection, and response capacity. The endorsement of the Strategic Action Plan on Polio Transition gave birth to the global vision and the regional strategic plans, with a monitoring and evaluation mechanism, which was designed to allow for necessary flexibility and contextualization that is needed to achieve sustainable transition. The global vision positions polio transition within the scope of primary health care as a cornerstone for universal health coverage. It is context specific. It has 3 impact goals and 4 strategic objectives that is applicable to all countries. However, there are 4 operational goals that are flexible and dependent on the context in the regions, different contexts in different regions and different countries. So since then, 32 countries out of 47 member states have transitioned out of GPI funding, with polio functions integrated in broader vaccine-preventable disease systems, and 15 transition priority countries. However, all the countries are supported by GPI for outbreak response activities. So countries are expected with this plan and vision to develop sustainable, costed transition plans where functions are outlined with clear implementation roadmaps. So here is a slide of how polio infrastructure enhances health service delivery. Polio resource and infrastructure continues to be used, from COVID-19 response to integrated surveillance, including the wastewater surveillance that I mentioned in my earlier presentation. Use of GIS technology, as well as new introduction, more recently, the rollout of HPV in the Comoros Island. Of course, challenges persist for transition to occur in the remaining countries. These include competing development priorities, other humanitarian emergencies that happen in these countries, and reduced domestic fundings. It's also challenging to transition in many of the countries while having an ongoing outbreak. The revised post-certification strategy has been shared with the member states for inputs and will be tabled at the World Health Assembly in 2026. So there is a need to align with the global vision and the region strategy as you develop the country-specific transition plans. Finally, I conclude by saying that transition is a key element to help us sustain a polio-free world and strengthen broader health security. We'll request the transition priority countries, which are 15 in our region, to prioritize the development of a sustainable and costed transition plans, which outlines key functions. Thank you.
Well, thank you very much, Dr. Getty, for that enlightening presentation about the overview on the polio transition process. Well, distinguished delegates and observers, I'd like to invite you all to imagine a world without polio. Let's take a look at this video on the screen. There should be sound on the video. Yes. Okay. If we can replay with the sound.
When the cholera outbreak started, our whole team immediately activated its surveillance network. The central and field polio team and resources were deployed to priority provinces and districts. We trained the local health workers to identify and report suspected cases quickly using the same methods that we're using for the dead poliovirus. We also helped to improve data reporting and deploy field teams to support case investigation in the affected projects.
So Africa's polio endgame challenges to take bold action. And that video reminds us that frontline workers, technology, and logistics are bringing the African region closer to the ultimate goal. So at the back of that video, I'd like to now begin with our panel, beginning with Dr. Yasmin. Madagascar is one of the countries that are transitioning. I'd like to ask, what has been the experience with the transition, and also how do you specifically plan to sustain the polio intervention infrastructure?
Merci beaucoup. À la suite de la déclaration de fin d'épidémie de polio, Madagascar a anticipé la transition en mettant en place un plan de transition visant à capitaliser les acquis et à garantir la pérennité des efforts de vaccination et de surveillance. En termes de renforcement des ressources humaines, des poules de jeunes médecins ont été formés en surveillance épidémiologique et en modules de vaccination. Ces professionnels qualifiés constituent désormais une expertise nationale disponible, pouvant être mobilisés comme consultants pour renforcer la prévention et la surveillance. Comme structure institutionnelle, la direction de la veille sanitaire et surveillance épidémiologique et de riposte, ainsi que la direction du programme élargi de vaccination, assure la surveillance des maladies évitables par la vaccination et des maladies à déclaration obligatoire selon le règlement sanitaire international. Ces structures permanentes garantissent la continuité des activités de surveillance et de riposte. Pour les infrastructures logistiques et technologiques, un plan de gestion logistique incluant la chaîne de froid a été renforcé. Aujourd'hui, parmi nos 3000 centres de santé de base, 98% disposent des chaînes de froid solarisées, assurant ainsi la disponibilité et la conservation optimale des vaccins pour la vaccination de routine. Concernant la gouvernance, l'institutionnalisation du centre d'opération d'urgence polio a permis d'intégrer durablement la coordination dans le centre d'opération d'urgence en santé publique avec l'appui de l'Africa CDC. Comme la polio implique également l'approche One Health, notamment avec le ministère de l'Environnement, elle fait partie des maladies identifiées dans la feuille de route One Health de Madagascar à mettre en œuvre par la plateforme One Health. En conclusion, ces actions coordonnées ont permis à Madagascar de bâtir des capacités humaine, institutionnelle et logistique solide, assurant non seulement les maintiens des acquis de la lutte contre la polio, mais aussi le renforcement global du système de vaccination de routine et du système de santé global. Je vous remercie.
Those are very impressive numbers, Dr. Yasmin. Thank you for sharing that with us. Let's now turn to hear from Malawi. In May, Malawi celebrated its first anniversary after officially closing the re-imported wild polio virus outbreak. So what an incredible milestone. And we have Dr. Chanda here to speak on behalf of the Ministry of Health for Malawi. So Dr. Chanda, can you please comment on what the country is doing to make sure, similar question as I asked to Dr. Yasmin, that the infrastructure will exist as the country phases out of the GPEI support?
No, thank you for giving Malawi this opportunity. I think to begin with, what we need, I think in Africa, in all countries, is to strengthen primary health care. Where we have disintegrated primary health care, then all systems will fall apart. And I believe as much as we're talking of polio, but we also have other diseases at a community level. And all these things will be integrated at the primary level. So for sustainability, the only effective, cheap way of sustaining all these interventions is to strengthen the primary health care. So it is an honor for Malawi to share our experience as we move forward in sustaining essential polio functions after closure of an outbreak in May 2024. We've celebrated 1 year as Malawi, but also this serves as a testimony to the power of solidarity and coordinated response across the African region. So as we transition from global polio eradication initiative support, Malawi has taken several measures to safeguard the hard-won gains that we've had for the past years or so. So to begin with, what we're championing is an integrated system-wide approach, which has to be community-led with a primary focus on primary health care. So in April this year, we convened a national polio transition planning meeting, which brought together several stakeholders, including government, non-governmental, civil society, as well as community leaders. Their task, essentially, this committee is to prioritize the national oversight of the critical functions that will include surveillance, continual routine immunization and outbreak response, integrating the polio assets such as trained health personnel, surveillance networks, and also rapid response mechanisms into the broader public health systems. We are also strengthening routine surveillance and immunization as a country. As we all know that acute flaccid paralysis and environmental surveillance is a cornerstone for polio management. This in Malawi is fully coordinated in the expanded program on immunization. And in this department, we are coordinating all vaccine preventable diseases like measles, polio, and TB. Also for sustainability as a country, we have invested in cold chain infrastructure, and Malawi is a regional training hub for biomedical engineers in cold chain management, as well as vaccine logistics. We believe that strengthening this as a country will be able to sustain the gains that we have had as a country. And the other peculiar thing about my country is on capacity, human capacity.
We have a very robust community health workers, and these community health workers, they are on government payroll. And so far, we have almost 25,000 community workers, which are responsible for a population of 2,000. So for us, in terms of sustainability, we believe that we need to expand this national staff capacity, and also at the same time, we also need to mobilize domestic financing. Lastly, what we need as governments is to have ownership and also to integrate polio functions into the national strategies. We believe that this cannot be a standalone disease, but it has to be integrated at a community level. Thank you very much.
Thank you very much. And Dr. Chund, I really want to appreciate you for this poignant reminder that indeed primary health care is the very foundation for public health in many of our countries. Thank you so much for that. Now let's turn to talk about the role of routine immunization. And I'd like to hear from Dr. Kalu on this particular question. What is the role of routine immunization during the polio transition? And can you talk about how we can strengthen routine immunization and population immunity in countries that have transitioned to prevent future outbreaks? As we know, high essential immunization coverage with both types of vaccines is a cornerstone of the polio eradication strategy.
Thank you very much. Actually, Malawi started answering the question by telling us strengthen primary health care. We know that routine immunization is the foundation of polio eradication. There will be no eradication without strong routine immunization. And that is the reason why the Immunization Agenda 2030, the core indicator is all countries and all districts achieving 90% coverage with all vaccines. All countries, all districts, all vaccines, 90% coverage or above. The essence of that is to interrupt transmission of any disease, including polio. And the only way to deliver that is districts having the capacity they need to deliver. And to build that capacity, it means our governments working with partners, working with corporate citizens must work together to leverage public sector resources, corporate resources, and resources available among partners to ensure that the capacities within governments, within the primary healthcare system are strengthened to ensure that they have the capacity to find and vaccinate the last child. Secondly, we need to be able to deploy technologies. We are in 2025. Technologies are available to enhance access, coverage, and quality of immunization services. We need to deploy technologies to find which districts are lagging behind. In the office back in WHO, we looked at, using the WENIC data that was just released, we looked at all the countries, and we found, surprisingly, that 70% of the countries in the African region are either performing moderately well or high. Only 30% are performing low. And when we look at the districts country by country, a country in Southern Africa, we found that 70% of districts are performing poorly. So the capacity to use data to drive action, that we need to build into our routine immunization systems. Every year, each country, every year, each district should look at the data to determine which are the districts to prioritize, which are the sub-district areas to prioritize, which are the countries to prioritize from regional perspective, and support them to deliver and achieve the Immunization Agenda 2030 targets. If we do not do that, there will be a reversal. But if we are to sustain polio eradication, we must be able to build capacities to use data to guide our investment. And finally, leveraging resources. There are resources available in our countries. We need to invest to leverage corporate resources, public sector resources, community-owned resources, and ensure we use them to support strengthening of delivery systems. When we do this, we believe that we'll be working differently and achieving different results. So sustaining the transition we're expecting is possible, very possible, if we work together using data to guide our investments and integrating technologies in strengthening primary health care. Thank you.
Thank you so much. As we know in this information age, data is the new gold, right? But Dr. Kalu, if I can please come back off of that, what are the barriers? I know it's quite complex, but in your mind, what are the top 3 barriers to achieving these recommendations? I know it varies from each of the regions here in the Africa region, but just generally with the overlap, what are the barriers stopping these recommendations from really reaching its maximum fruition?
I think that one major barrier is risk aversion. When the old guys like me are in charge, we are very technology averse, and we need to be able to overcome that and adapt technology.
Thank you for the honesty.
Secondly, we verticalized immunization. It's time to reintegrate immunization into primary healthcare. Thirdly, immunization services or primary healthcare have been regarded as poor health for poor people. It's not true. It's actually good access to health services. But we need to improve the quality, we need to improve access, we need to ensure that the health workers are available. And how do we do that? Technologies are available to ensure that we can achieve universal access to trained health workers in our countries using technology. Remember, 5 years ago, there was no platform for you to hold remote meetings, but now it's existing. We are using the same in the Western world to access health services. Why are we shy of that in Africa? We need to be bold and audacious and introduce technology. This is 2025, and it's doable. Thank you.
Thank you very much, Dr. Kalu. Appreciate that. Now, let us hear from the member states on the floor. If you have any commentaries, please indicate with your card, and we have people going around to take note. Any comments towards the panelists or any interventions from the experiences in your own countries, please do share. We have about 10 minutes remaining for this session. And if you can, keep your remarks on the topic of the polio transition. We have a commentary from Niger. I yield the floor to Niger. 2 minutes, please.
Merci, Madame la modératrice. Merci, chers membres du panel, Mesdames, Messieurs. Le Niger, à l'instar des autres pays, a connu aussi une accumulation de cohortes d'enfants non vaccinés du fait de l'impact de la pandémie de la COVID-19 et des autres urgences sanitaires ayant eu des effets sur les services de la vaccination. Afin de combler ces lacunes immunitaires chez ces enfants, le Niger a adhéré à l'initiative du grand rattrapage que j'ai personnellement lancé le 17 avril 2025. Cette intervention est d'envergure nationale concernant les 72 districts de notre pays et se passe dans 88% des centres de vaccination, dont 1339 centres de santé intégrés sur les 1525 centres de santé du pays. Le Big Catch-up est mis en œuvre selon une approche intégrée pour offrir davantage de soins aux femmes et aux enfants. Les autorités administratives, les leaders coutumiers et religieux ont été mis en contribution pour soutenir l'adhésion des populations à la vaccination. Aussi, des interventions spécifiques sont utilisées pour atteindre et vacciner les enfants des zones d'accès difficiles, notamment la collaboration avec les forces de défense et de sécurité, l'utilisation des notables communautaires et des femmes relais issues des dites zones. Enfin, nous avons renforcé l'intégration systématique des Big Catch-up lors de toutes les activités de campagne de masse en matière de santé qui constituent des opportunités supplémentaires d'équité dans les soins de santé. Mesdames, Messieurs, je vous remercie.
Thank you very much, Niger. Now, let us hear from the member states on the floor. If you have any commentaries, please indicate with your card, and we have people going around to take note. Any comments towards the panelists or any interventions from the experiences in your own countries, please do share. We have about 10 minutes remaining for this session.
Merci, je vous remercie.
Thank you very much. I have heard a bit about the Big Catch Up initiative, so thank you very much for shedding a bit more light on that initiative. Any other commentaries at this time? If not, we can turn back to the panelists for the closing remarks. All right, well, it's time to bring part 2 to a close. From the panel and floor interventions, just a moment, we may have another one. Okay, yes. Okay, Ethiopia, I yield the floor to you. You have 2 minutes for your intervention.
Thank you. Thank you so much, Chair, and thank you for the panelists. We are very much energized on these renewed initiatives. And, you know, Ethiopia is one of the target countries on zero-dose children. And as distinguished delegates and the panel said, it's not only about the polio, it's increasing the routine immunization and working on the challenges that we are facing. So we are asked to play a regional leadership role in the Horn of Africa. You know, as it was presented, Ethiopia becomes also have some challenges in outbreaks or regarding with CVDP V2. Which we had reported significant number in 2025, and population displacement, service interruptions due to some of the conflicts are also a challenge, and difficulties in the last mile delivery as usual is also an issue, but we worked very diligently to alleviate those problems through partnership. Like we reached to 23 million children in the yearly campaign that we did, which was integrated as presented with other activities, including all child health activities to the rural areas. And we used different modalities and fostered inter-regional coordination and also cross countries to other neighboring countries like Somalia, Kenya. We worked together in the campaigns. There are a lot of experiences, and we hope we will come back in another area with the time shortage. Thank you so much.
Thank you very much. And indeed, Ethiopia has made commendable progress in strengthening routine immunization and significantly reducing the number of zero-dose children. Looks like we have another remark. The delegate representing South Africa, if you can please make your remarks within 2 minutes. South Africa. Is South Africa prepared? Okay, just a moment. Yes, South Africa. You have the floor.
Thank you very much, Chair. I'm very sorry. I had to go to answer to some call. I was asked to respond to 2 questions, Chair.
Sure, yes. So if I can present the questions, Yes, if you don't mind. Can you talk about how the enhanced capacity is contributing to timely and quality detections of polio virus across your region and contributing to effective outbreak responses? Also, if you don't mind just sharing with us what lessons can be drawn from South Africa's experience to strengthen lab networks and genomic capabilities across the continent. Thank you, sir.
Thank you very much. Prior to February 2025, there was only 2 accredited sequencing laboratories in the region. It was the NICD, or National Institute of Communicable Disease in South Africa, and the other one was in Ghana. In line with the GPSAP 2022 to 2024 Objective 4, 2 additional labs were identified for expansion of Sanger sequencing. That was in Uganda and in Nigeria. The National Institute of Communicable Disease Polio Lab played a pivotal role with parallel testing samples from Uganda prior to accreditation, accrediting both laboratories in February 2025, and currently reviewing all sequencing results generated by these two labs before they were officially reported. Samples for sequencing previously shipped to Center for Disease Control are now being sequenced in the region, no longer in the CDC in the US. The expansion has led shorter turnaround times for sequencing, which in turn result in a more timely response following the identification of outbreaks. Thank you. I don't know whether I must move over to answer the second question.
If you can, within 20 seconds.
Yes, the second question was, what lesson can be drawn for South Africa's experience? And our response, a strong national capacity can serve as a foundation to support and strengthen regional laboratory networks. Maintaining robust quality control systems is essential to ensure confidence in genomic surveillance. Sustainable laboratory networks require long-term investment in skilled personnel, infrastructure, and equipment.
Thank you so much. We have to end there. We appreciate your remarks. Well, it is time to bring part 2 to a close. And from the panel and the floor interventions that we heard some clear perspectives on how the WHO and member states are leveraging existing polio intervention infrastructure to support other crucial public health priorities. So thank you very much for your time and your attention. And I'd like to invite Dr. Elias to make his closing remarks and to perhaps give us a rousing call to action. Thank you, Dr. Elias. Would you like to stay there or speak here at the podium?
I'll just stay.
Okay, perfect. Thank you, sir.
So it's a pleasure to be with you this evening in my role as the chair of the Polio Oversight Board. I want to start by thanking the regional director, Dr. Janabi, and the incoming DPM, Dr. Diallo, for including this session on the regional committee's 75th meeting. I think it's quite timely, quite important, and as we've heard from all of the member states, quite doable. I in particular want to thank the member states, those who were on the panels, as well as the comments from the floor, because I think you've really distilled the essence of what's brought us to where we are and what we need to do to finish. At the very beginning, our moderator referred to the polio endgame and said she liked that term. If you haven't heard that term before, you've probably not played chess, because in the game of chess, the endgame refers to the final moves that a successful player makes in winning the game, in basically cornering and containing the king of the other side. And if I think about the end game for polio, to use that chess analogy, we've got very few pieces left on the board. Since the World Health Assembly declared the goal of polio eradication in 1988, 120 countries, many of them represented here, have succeeded in eradicating all or most forms of the polio virus. But there are a few pieces left on the board. And I think there are three that if I tried to distill the comments that people made from the specific epidemiology of the 47 countries here in the Afro region. The biggest piece was the opponent's queen, that big, powerful piece. That was the wild polio virus. And this region succeeded in being certified. The last case, as we saw from Dr. Getty, of endemic wild polio virus was in 2016 in northern Nigeria. The region was certified free of the wild polio virus in 2020. It was one of the brightest spots in that dark year of COVID-19. Since then, we were tested again. That piece tried to come back on the board in Malawi and Mozambique in 2021. There were 8 cases. And as you heard from both our colleagues from Mozambique and Malawi, quick action, dedicated action, integrated action. That in Malawi, I believe they integrated the polio campaigns, both with measles and cholera campaigns, succeeded in finishing that outbreak. It was certified, officially closed by the WHO last year. So the region has largely succeeded already and face the challenge of reintroduction of wild poliovirus. That was the biggest challenge. The next piece left on the board are the circulating variant polioviruses of type 2. This is a legacy from when we made the switch from trivalent to bivalent oral polio vaccine back in 2017. At the time, we thought we would only have a few outbreaks and they would be quickly contained. That's what the modelers all indicated. The models were unfortunately wrong. We're still chasing that variant poliovirus type 2 in critical areas like the Lake Chad Basin, like the Horn of Africa, and then until recently in the Democratic Republic of Congo. But we're making progress. The number of cases and the number of geographies that are affected, the number of LGAs in Nigeria, as our colleague described, are shrinking. Not as fast as we'd like, but we're getting there. And we know what it takes. And I'll include that in my final comments about a call to action. The third piece left on the board is the occasional outbreaks of variant polioviruses types 1 and 3. And these emerge from the current use of the bivalent oral polio vaccine in the places with the lowest routine immunization. When they emerge, we usually are able to pretty quickly contain them by doing a few high-quality campaigns. But until we are able to stop using that vaccine, we will continue to see emergence in places where the routine immunization is low. So what do I take from all of the rich discussion and presentations we've had today? I think there are 5 key things that if we keep them from front and center will help us finish the job in short order. The first is surveillance. You've heard about it from multiple presentations. It was key to the containment of the wild poliovirus outbreak in Malawi and Mozambique. And it is being facilitated by what Minister Matsaledi just talked about, more capacity for rapid testing and sequencing of the virus here on the continent, not depending on sending the samples abroad. We're getting results faster because of that expanded laboratory capacity, and that allows us to respond more quickly. The second component in our call of action is rapid response, to know we have a problem and to move quickly. We had a very important meeting this morning with the ministers from the Lake Chad Basin where we talked about what are some of the operational challenges, the timely release of resources, the timely availability of vaccine for responding to type 2 outbreaks in particular, and the importance of micro-planning and the use of some of the technology tools that Dr. Getty highlighted, the geospatial information mapping, et cetera, and the strong GIS center that's been established at WHO Afro in Brazzaville. Thirdly, and we heard this again, I think, from multiple presentations, most recently from our colleagues in Nigeria, the quality of the response. Doing campaigns and missing the same children over and over again means we remain vulnerable and the virus continues to circulate. So the third, surveillance, rapid response, quality of response, and then as this panel, I think, has highlighted, the importance of routine immunization. We do not have variant poliovirus emergences in places with strong routine immunization. So the work that Dr. Sanya Nishtar talked about in her comments in Gavi 6.0, the importance of reaching zero-dose children as part of that ambitious Gavi strategy for the next 5 years, working with many of the member states here is going to be critical. And I think what our Dr. Kalu and our colleague from Malawi emphasized very recently, routine immunization shouldn't be a vertical program. It should be a key component, perhaps the most important indicator of a functioning primary healthcare system, which is, of course, the road to universal health coverage. So I think we've had a great conversation. I think we've heard a lot of specific examples that make us realize that this is doable. It's been done for wild poliovirus. It can be done for the variant polioviruses. And we just need to keep our focus on surveillance, rapid response, the quality of our response, routine immunization, and building a sustainable primary healthcare system for every country so that no child remains vulnerable to paralysis or death from any form of the poliovirus. Thank you.
Thank you so much, Dr. Elias. My takeaway from your remarks is that there are a few pieces left on the board. Thank you so much for that. We are very fortunate to have representing the RD, Dr. Janabi with us, Dr. Diallo. So I'd like to yield the floor for you to give your closing remarks and any calls to actions from your end. Thank you, Dr. Diallo.
Thank you very much. I just want to acknowledge Dr. Janabi, who just walked into the room, and he's asked me to actually do the closing remarks, as he just said. So thank you very much. For a change, I'm going to speak in French. I spoke in English for the opening remarks. I'm going to close in French. Non, comme Chris Elias vient de le dire, nous avons assisté à des présentations vraiment, vraiment formidables. De la présentation de Madagascar, je pense qu'on peut tirer 4 points intéressants. Encore une fois, la volonté politique. Avec la volonté politique, avec une bonne gouvernance, avec une gestion technique de proximité appropriée et un suivi au quotidien, on peut vraiment venir à bout de ce gros défi qui est la poliomyélite. Elle est rentrée dans les détails. Nous avons entendu, quand on parle d'engagement politique, au plus haut niveau, l'implication des chefs d'État, l'implication des premières dames, etc., etc. Et surtout au niveau gouvernance, on a vu qu'au niveau Conseil des ministres, quand il y a une coordination entre plusieurs agences, entre plusieurs entités gouvernementales, il y a vraiment des efforts qui peuvent aboutir à des résultats positifs. Du côté de la République démocratique du Congo, c'est la même chose. Malgré les défis contextuels entravant les efforts, nous avons vu des approches vraiment innovantes, y compris la mise à contribution des forces armées congolaises, l'implication des autorités locales, les ONG locales. Et aussi, nous avons entendu des innovations vraiment intéressantes, y compris l'ouverture de corridors humanitaires et l'utilisation de technologies numériques pour venir encore une fois à bout de ce défi. Et également des exemples vraiment pertinents de plusieurs autres pays, y compris la Guinée, le Nigeria, le Tchad, l'Angola, la Tanzanie, le Mozambique et le Malawi. Ça, c'est au niveau pays. Et quand on voit au niveau global, nous avons entendu la directrice générale de Gavi, son engagement, elle a parlé de Gavi 6.0 et elle a fait le lien entre cette stratégie et encore une fois le défi que nous avons en face. Elle a parlé, par exemple, des attentes des enfants qui n'ont jamais été vaccinés, 0 dose, de tous les investissements sur les programmes de vaccination, à partir desquels on
immunization programs from which we can develop a synergy to tackle this issue that we are facing. In a nutshell, like I said before, today we've got science, we have evidence, we have the knowledge, we've got a commitment. We are centered around one cause and with instruments that we need. In actual fact, nothing prevents us from
in
the second part, I found the discussion on transition very interesting. Once again, there were so many lessons learned, how the polio control can to do other things.
Comment dirais-je, à toute l'infrastructure dont on dispose. J'utilise souvent un exemple. Permettez-moi de le partager avec vous. Quand la Guinée en Afrique de l'Ouest a eu l'épidémie de la maladie à virus Ebola, nous nous sommes mis à construire des centres de traitement épidémiologique qu'on a appelés CTP. Nous avons opté pour les infrastructures fixes en dur. Et vraiment, c'était des infrastructures très bien qui séparaient les cas suspects, des cas probables, des cas confirmés. Tout le monde nous a dit, mais qu'est-ce que vous allez faire avec ça quand Ebola va passer? C'est énorme. Dans tous les districts sanitaires, vous les avez construits. En vérité, après l'épidémie, nous avons décidé de les recycler et de les utiliser pour certaines maladies particulières telles que la rage, telles que la méningite, telles que le choléra, etc., etc. Et ensuite, personne ne pouvait savoir qu'il allait avoir la pandémie au Covid-19 et ces centres ont servi. C'est de dire qu'aujourd'hui, tout ce que nous avons investi dans la lutte contre la poliomyélite peut en fait resservir dans le cadre d'une transition. En tout cas, je saisis cette opportunité pour réitérer l'engagement de l'OMS à travailler avec tous les partenaires impliqués et avec tous les États membres pour venir à bout de ce gros défi qui est la poliomyélite. Qu'il s'agisse de renforcer le système de santé, qu'il s'agisse de faire l'appui au programme de vaccination. En tout cas, nous nous mettons aux côtés des États membres pour non seulement en finir avec la poliomyélite, mais assurer une transition optimale. Donc l'appel de chez nous, vraiment, l'éradication est atteignable à condition que nous restons unis, vigilants et persistants. Nous lançons un appel au gouvernement et à tous les partenaires de transformer l'engagement que nous avons, l'engagement en politique, en financement et surtout en action, comme disait Chris tout à l'heure. Et nous devons obligatoirement innover, intégrer pour protéger les acquis que nous avons à date. Donc, je saisis cette opportunité pour remercier mesdames et messieurs les ministres, les chefs de délégation, représentants des États membres, les partenaires, tous les acteurs de la lutte contre la poliomyélite et aussi tous ceux qui ont participé à l'organisation de cette session.
In organizing this session, which is an extraordinary. Before I end, my colleagues of the WHO requested me to convey a message to all member states. And it's about having your inputs, your contributions and comments on the post-certification strategy that we shared with member states. So please do not forget this strategy and thank you for your attention.
Well, that was a first-class summary. Thank you so much, Dr. Diallo. Very much appreciated. Well, distinguished delegates and observers, this special event, Eradication, Transition, and Sustainability, the African region's polio endgame, has officially concluded. I'd like to now invite the panelists to exit the stage. This brings, therefore, the day's session on the second day of the 75th session of the WHO Regional Committee for Africa to a close. I'd like for you all to know that there is an event starting in a few minutes. So if you still have the space to stay for that one, the event is called From Commitment to Action, Accelerating Domestic Investment and Multi-Sectoral Leadership for Health in Africa. And it takes place in this same room, if I'm not mistaken. Yes, it takes place here. Also, if you have not, do take a moment, perhaps tomorrow in the daylight, to visit the virtual reality exhibition outside in the parking lot. It's very fascinating. I'm sure you all can learn quite a lot. Thank you very much. It has been quite a pleasure and an honor to be with you this evening. I would like to now yield the floor to the Secretariat for logistical announcements. Thank you once again.
Thank you very much, Chika. Dear ladies and gentlemen, while waiting for the transition to side event 3, I would like to share some information regarding departure. A link and QR code for departure details, including flight number, departure time, and hotel, will be displayed or is displayed on the screens for your information. For VIPs, departures will take place from the same entry point used upon arrival. For all other delegates, buses will leave from the hotels 3 hours before the departure time shown on your ticket. You will then proceed through the normal departure process at the airport. Should you need any assistance, please contact the travel desk located in the back of the plenary room next to the interpretation booth. A lost and found desk is installed just next. Several items have been handed in already. If you have misplaced anything, please check. Thank you for your attention.
Okay. Okay. That's fine. 1, 2, 1, 2. Still. 1, 2. 1, 2, 1, 2. Yeah.
Thank you very much. Thank you very much. It's not enough. Thank you very much indeed. We need the microphones on, please. Thank you very much indeed. Kindly take your seats. Thank you. The side event is about to begin. Can we have all the microphones on, please, so we can be heard? Thank you very much indeed. I would like to invite our first tranche of speakers to the stage. They're going to be helping us with the welcomes. Do we have Professor Mohammed Yaqub Janabi, WHO Afro Regional Director? Thank you very much. Do we have Dr. Elijah Muchima, MP, Honorable Minister of Health, Zambia? Someone's going to tell me that they're sitting in for him. Do we have Professor Julio Rakoto Nerina, Director, African Union Commission, Department of Health, Humanitarian Affairs and Social Development? Dr. Ngas Ngondo, Principal Advisor to the Director General of the Africa CDC. Mrs. Eunice Kamwendo, Director, Southern Africa Sub-Regional Office of UNECA. Mr. Peter Sands, Global Fund Chief Executive Officer. Mr. Thomas Ostros, Vice President of the European Investment Bank. That'll be a video message. And Mr. Samir Gray Johnson, Director, Human Capital and Institutional Development, AUDA NEPAD. Hey. Good to see you again. Thank you very much. Well, I don't think we've got all our participants, but we have at least some of them. Perhaps others will join us while we're making our remarks. Honourable Minister, good to see you again.
Thank you.
It's about 3 or 4 times today.
Thank you. Good to see you. Good. Okay. Good. Where do I sit?
Let's have a look.
Where?
How are you? Like cleverly.
Do we have a Global Fund place name, please? Yes, sir.
Oh, he brought one.
He brought his own. Wonderful. We have a quorum. Thank you very much indeed, everybody. We've got a lot of energy up here. We're going to try and transmit it to you in the room. So thank you very much. It's going to be a really excellent, dynamic and engaging session over the next hour and 3/4. We're delighted that you stayed on for us. So welcome to this side event on health financing. Sorry, can I have your attention, please? Thank you. Thank you. Thank you. Just to open this up, thank you very much. So this topic it is more crucial than ever. I mean, it's been building up all the time, but more crucial than ever, given the winds of change that are blowing through the international aid system, as traditional donors and partners retrench to concentrate on their own domestic issues. It's clearer than ever that without serious domestic resource mobilization here on the continent of Africa, it will not be possible to invest in complex African health needs, let alone achieve universal basic healthcare. So what's the latest thinking? How can strategic platforms like the Health Impact Investment Platform and the Program for Investment and Financing in Africa's health sector help get us to where we want to go? Well, in the first half of our session this evening, we'll hear from the WHO-RD, the Zambian Health Minister, the AU-HHS Director, the DG of Africa CDC or Reserve Representative, UNECA's Southern Africa Director, the Executive Director of the Global Fund, the VP of the European Investment Bank, and the Director of Human Capital and Institutional Development of AUDA NEPAD. And in the second half, Professor Francis Kasolo, thank you, African Union Head of WHO Office, will moderate a high-level ministerial and multi-sectoral panel, and then we'll have a dialogue, time permitting, with member states and partners. Let me first invite the RD WHO Africa Professor Mohamed Janabi to give us some opening remarks. Professor.
Honorable Minister, dear colleagues, I know it has been a long day, so I'll try to be as brief as possible. Good evening to everyone. It is an honor to welcome you to this high-level dialogue on domestic investment and multi-sectorial leadership for health in Africa. We are joining frontier with leaders who are shaping how health is financed, governed, and integrated into development priorities. So the conversation ahead of us in the coming few minutes will help translate ambition into results and build systems that are better aligned, better resourced, and better prepared for the challenges not ahead of us, they are with us now. So this gathering signals our shared intent to move from policy to practice and from commitments to measurable progress. Across our continent today, we have seen what is possible. And I'll cite some few examples. Since the year 2000, health services coverage has nearly doubled in most of the countries. Maternal and child deaths have declined. Living example of Zambia here. We are talking today of 85 deaths per every 100,000 live births. If you translate it, if we keep this pace, Zambia is going to achieve the SDG goal of having mortality less than 70 by year 2030. Life expectancy has increased, which one side, if you look at it, it's very good, but member states, we have to get prepared because age comes with its complications also. Yeah. So we are starting to think about geriatric medicine. How are we going to take care of the aged population? These gains reflect political will and strategic investment which has been done on health. And I'll share with you some few countries. Several countries are showing the way. Look at South Africa has allocated more than 15% of its national budget to health for more than a decade now. Botswana consistently covers more than 70% of all health spending from government revenues. Namibia, nearly 9% of its GDP goes into health. Cabo Verde is leveraging tax reform and partnership to improve efficiency. Rwanda, the community-based health insurance now covers 90% of its population, contributing to 80% drop in under 5 mortality. I was recently in Ghana for the Ghana Compact. The health insurance coverage in Ghana is 60%. Actually, I was talking with Honorable Minister here. We're trying to organize. Ghana should come and discuss with Zambia. How did they achieve 60% coverage? That is South-to-South cooperation, which we look forward. Yet, progress remains fragile. External assistance is declining. Debt burden are rising. Climate shocks, economic volatility, and protracted emergencies are testing already stretched systems. Primary health care, the foundation of resilient systems and the most efficient path to universal health coverage, remains chronically or malignantly underfunded. Fewer than a quarter of African countries have met the Abuja Declaration, and out-of-pocket spending remains pretty high. Actually, it's kind of recycling poverty, because I've seen it when I was still active in clinical practice. Out-of-pocket is pushing more than 1 billion people today into debt globally. But we are not starting from zero. The Health Impact Investment Platform launched way back in 2023 by WHO. Development banks still continue to mobilize funds. This will help strengthen our primary healthcare, pandemic preparedness, and climate resilient system. So we are ready. Where WHO is still working with some of our countries to align investment plans with the national priorities. We all recall the Lusaka agenda. The focus of one country plan offers a practical solution to reduce the fragmentation. It also offers a way to align partner support with national priorities, which is our goal. Each member state has got its priorities. So WHO is going to tie with those national priorities with our regional office and align it with them. I'll give you another example of domestic financing. Madagascar, modest airline levy generates over 5 million annually for malaria control. ECOWAS import levy now funds 70% of its regional health budget. So these models do work and they should be scaled up. So let's align efforts and rally behind the Africa-led, Africa finance, and Africa-owned systems, health system. WHO will remain to be a partner to this journey, so I look forward to the conversation this evening, learn from it, and see how we can progress on WHO side of you. I thank you.
Thank you very much, Adi Janabi, for those opening remarks. But as we have quite a lot of speakers in this first session and quite a number of others in the second session, I would remind all speakers to stick as closely as they can, because of the lateness of the hour, to the agreed times. So with these welcomes, let's try and power our way through and leave people wanting more. That's always the way I say, these are wanting more. So that being said, let me move to Dr. Elijah Muchima, Minister of Health, Republic of Zambia, for your approach to health financing, particularly DRM, given the urgency of raising domestic funds.
Thank you, moderator. First, the subject matter is quite crucial, very, very critical. We need to look at it with seriousness it deserves. Domestic funding is the way to go. The agencies like yesterday, dependence on
operating partners should be a temporary measure, not a permanent will. For Zambia, it depends mostly on the treasury. But the treasury is engulfed with a lot of demands: agriculture, education, to mention a few. But where do you place health? Now, there are calls for political will. The president of the Republic of Zambia, from what you have been hearing, stands tall and puts health number one. If it were possible, you would channel the whole entire budget to health to meet the infrastructure needed, medicines, equipment, manpower in terms of human resource. We are talking about ambulances, but importantly, mindset. As we move towards mobilization of resources, the demand for care also is quite high, demanding new equipment, the scans, x-rays, but within its own scope. Zambia has tried mobilizing flying doctor, buying aircraft to evacuate citizenry. But evacuate where? Within Zambia, yes. But cases like cancer, which are also in the increase, you need to evacuate them. Places like India. When you look at the budget allocation, it's limited. What do? We want to go the insurance way. Actuarial studies have recommended 5% contribution of an employer and employee. But mind you, Zambia mostly is compounded with poverty. Most people can't afford. And we're looking at former employee and formal employment. And also the legal framework, which we intend to change so that we can involve informal also to contribute to health insurance. We went to Ghana and to Rwanda to see how they are doing it. Rwanda's got two systems for the community and everyone else. Other countries have managed to move without any trouble. But with the political expedience, the moment you move someone wanting to rise to power, come and start condemning you. Meanwhile, you mean well. So these are issues we want to learn from Ghana. How we get around the resistance, and how do we move away and consistency in payments. At times, programs even more costly. Collect the little to push in. Health is key. Everyone, including medical doctors, get sick. And when you are sick, you don't prescribe your own medicine, you need to be admitted. One of you can afford using their own resources. Now, Zambia, with the portfolio, with these challenges, we have shifted. That shift goes to investment, making it the way to go. Partnering what we call public partnership. Allow investors to come in, we start producing. That way, to create employment. Also, the issue of people going to school, educating them, they will understand it will help us to deal with the mindset. Because if people are not educated, they will make public health difficult and the cost becomes too high. So the president, the political will, the president in Zambia, we want manufacturing. If institutions like TAVI, Global Fund, whoever it is, wants to assist us, they should not give us commodities, but they should help us set up manufacturing companies so that we can manufacture medicines within the country. And also collaboration with the neighboring countries. Botswana, Zambia, Tanzania. We need to come together. Also, insurance, we have also to look at reinsurance. Because some of the costs are quite beyond that. No matter how much you press your treasury, you won't have the required resources. The numbers in one constituency, in one district is not enough. But how do you buy them? And the demand is high. Look at the road infrastructure is also terrible. All of these are so source needing new. Despite the problems we have for COVID-19, drought, our budget keeps on increasing, but it does not increase to the measure that is required. Of course, the Abuja declaration, we are 12%, including implied expenditures. I think we are roughly at 15 or 16 there. Zambia wants everyone to be given an opportunity to live, go to the last mile. All clinics, all health centers now, as we speak, have got 95% and above of medication. But for how long? For how long?
Honourable Minister, that is indeed the question. For how long? For how long?
That's where we need to move away by investing, by encouraging investment within our economy. When we invest by manufacturing, by partnering with our colleagues, by bringing them together, by all of us here, if we came up with a project of manufacturing as CDC or WHO, to put up our own factories, it will be cheaper and we shall trade among ourselves. That way, it will help us resolve this difficult situation.
Honourable Minister, you make a very important point there, a hugely important point, and I'm going to move from that point, from the perspective of Zambia, to now get the perspective of the African Union Commission, because we want to try and move from the country perspective to the continental perspective now, with your permission. If I can do that now. So thank you very much, Honourable Minister.
Thank you.
Machina, thank you very much indeed. Now we have, just to my right, but one, Professor Julio Rapoto Mirina, Director, African Union Commission, Department of Health, Humanitarian Affairs and Social Development. These are just brief opening remarks. Please try to restrict yourself to just opening remarks so that we can hear from everybody. And then if we get the chance a little bit later to hear from people assembled, otherwise we won't be able to do so. Thank you.
Merci beaucoup, chers collègues.
Thank you very much, dear colleague. First of all, allow me to convey the greetings of His Excellency, the Commissioner in charge of Health, Humanitarian Affairs, Social Development in the Commission, given that she is unavoidably absent for similar activities. So she requested me to represent her, and it is a huge honor for me, ladies and gentlemen, to greet you, and above everything else, to wish resounding success to this meeting, because we're here at a very important moment for health in Africa, especially to translate the powerful statements and declarations that we adopted together into very concrete strategies. You know better than me that the objectives are very clear and ambitious. First, we need to transform, as I've just said, or match the rhetoric with deeds by increasing investments in health. Secondly, we need to transcend traditional methods and explore mechanisms that are achievable, anchoring our efforts to strengthen primary health care. Thirdly, we need to promote and start multi-sectoral discussions and to collaborate, ensure collaboration among the various departments and sectors. Fourthly, we need to take advantage of the unprecedented opportunities provided by the African Continental Free Trade Area to promote health insurance, cross-border health insurance, and finally, we need to expedite the implementation of all our commitments in sustainable funding. Ladies and gentlemen, the background of our discussion is well known, and we've taken due note of the progress that has been achieved. However, we are very aware that only a few countries have achieved the Abuja objective of 15%. It's not about a challenge only for the health sector. That is why I said earlier that we need to start a multi-sector approach. And I am convinced that with the expertise, the authority, and the collective political resolve in this hall, this room, we can move from mere discussions around these objectives and take concrete and achievable measures. So I would like to wish a very fruitful deliberations for all of us. Thank you, Prof, for your discussion. You need to spend 15%, but how do we go about this?
Budget, that was tremendous. Thank you very much indeed. Let's continue our discussion now. Let's move to the Africa CDC. The Director General is not with us, but we do have Dr. Ngas Ngongo, Principal Advisor to Dr. Kaseya. So please, votre allocution, s'il vous plaît, et bref.
Please be brief with your intervention.
Thank you very much, MC, Excellencies, Ministers of Health, and distinguished partners, ladies and gentlemen. Let me also start by just presenting the apologies from the Director General, who really wanted to be here with us, but then couldn't because of another very urgent commitment. But we feel honored at Africa CDC to join this discussion today as we reflect on how Africa can build a resilient, self-reliant, and sustainable health system that our people deserve. The Abdi reminded us something very important in his opening remarks, that over the last 2 decades, Africa has made remarkable progress. When you look at the life expectancy between 2000 and 2019, I think it has increased by 10 years, from 46 to 56 years. And also refer to the essential health service coverage that have also almost doubled from 24% to 46%. But what is important to say is that all that was driven by a strong political commitment, such as the Abuja Declaration, the Africa Leadership Meeting on Investing in Health, and the Agenda 2063 of the Africa we want. But I think what these achievements tell us is that when Africa leads, Africa delivers. Yet today, we are faced with so many challenges on the continent. We still have the aftershocks of COVID-19. We are experiencing the decline in external aid. We are seeing the mounting debt burdens. We have the effect of the climate change. We've seen also health emergencies that are on the increase, 40% between 2022 and 2024. All those do threaten to undo the progress that I've just mentioned. Now, as such, primary health care is then the backbone of our universal health coverage, but also the backbone of our effort to ensure health security on the continent. Yet, it remains severely unfunded. Now, the lesson is clear that Africa must strengthen its domestic financing and also the partnerships that place our destiny in our own hands. Now, Excellencies, from the Africa CDC perspective, I think we see the path to self-reliance anchored on 3 strategic priorities. Now, the first is the championing of health financing for increased sovereignty. As many of you remember, that Africa CDC in April launched the Green Book, which is the strategy on really boosting health financing in a new era to respond to the crisis Africa is going through right now. And what is important in that is that we are really working with President Kagame, who is the champion on domestic resources, to push the advocacy for our government to invest more in health. But in addition to that, Africa CDC is also promoting innovative financing strategies, recognizing that the fiscal space of our government also faces some limitations. But all that is very much in line with the Abuja Declaration that is pushing for 15% of the national budget allocated to health, but at the same time also leveraging some of the platforms like the Health Impact Investment Platform and the Auda NEPAD PIFA that allow the churning of resources through national priorities. But
Gogo, that's a really important first point. Would you go through the second and third really quickly? Thank you, because we're running way over. Thank you.
Yes, the second point is to build resilient primary healthcare, as the foundation of universal health coverage and health security. I think there are important areas on really improving the infrastructure, working on the digitalization, but also most importantly, scaling up community health workers toward the goal of 2 million community health workers that the head of state have already committed. And then the last is really to foster the political leadership. I think that is critical to ensure that all our leaders, both from the president to the ministers, do actually engage and give the leadership that is important for us to reframe health as an economic and security priority for the continent. I think with those, I would like just to say that what is true is that Africa that invests in health secures its people, secures its sovereignty, and secures its future. I think with that, we can act boldly, but not tomorrow. We need to act today. Thank you very much.
Thank you very much on the part of CDC. Thank you very much indeed. Let's get the perspective of the director of the Southern Africa Sub-Regional Office of UNECA, Mrs. Eunice Kamwendo. Your opening remarks, please, your perspective.
Thank you, Chair. I'd like to first start by apologizing. My director, actually, Ms. Kamwendo, unfortunately isn't able to be with us this evening. She had an emergency that she needed to attend to. I'm covering for her. And I will basically just talk through a few points, bearing in mind the lateness of the hour. So I'd like to start by just looking at the big picture issues we've been speaking about, health as sovereignty. Health financing, of course, we know is not just a technical or sectoral matter. It is fundamentally about Africa's sovereignty, resilience, and economic development. And the reality is that without strong domestic financing, Africa will remain vulnerable to external shocks and dependent on donors to protect its most basic human right, which is the right to health. When we consider the current situation, of course, numbers matter. And we've been speaking about a lot of those numbers today. In 2022, Africa spent 145 billion on health, US dollars, but governments contributed less than 41% of this amount. In 17 countries, more than 30% of all health spending is donor dependent, making health systems, as we know, fragile and unsustainable. We also know that out-of-pocket payments push 150 million Africans into poverty every single year. Let's consider for a moment what are the risks of underinvestment. We know that Africa faces the double burden of disease, infectious diseases like NCDs, diabetes and heart disease are rising fast. We also know that with Africa's population expected to reach 2.5 billion by 2050, well, weak health systems are not only a health crisis, they are a developmental and security crisis. Given the region's context, health financing is an investment, not a cost. Every dollar invested in health yields up to $4 in economic returns through improved productivity, education outcomes, and stronger labor markets. Closing the women's health gap alone could add 1 trillion annually to the global economy by 2040. Health is therefore a driver of inclusive growth, fiscal stability, and resilience. Focusing on the transformation imperative, what needs to change, we talk about this through 3 bold steps. Unlocking domestic fiscal space through tax reforms, debt for health swaps, and innovative financing mechanisms. Health being prioritized in budgets and not treated as a discretionary expense. Leveraging technology and digital tools, digital health solutions can reduce costs by 19%, improve efficiency by 30%, and cut medical errors by more than 50%. Remote health solutions could help reach up to 700 million Africans who currently lack access. And of course, this requires fully funded digital health strategies across our countries. Turning our attention to harnessing regional integration through the AFCFTA, we recognize the AFCFTA's approach gives us this opportunity to pool procurement of medicines and vaccines, strengthen local pharmaceutical production and supply chains, and harmonize regulations through partnerships such that we have with ADO-NEPAD, Africa CDC, and AMA. I'd like to just briefly speak quickly about the role of, I'm under time, Economic Commission for Africa.
Sorry, I want to be honest, I'm warm. Nobody has spoken to time. Nobody. I know it's a very, very important subject, but we want you to leave us wanting more. So I'll allow you to a little bit more.
Okay.
But everyone's got 3 minutes and nobody's been at 3 minutes.
Okay, so just ending on how ECA can help bridge gaps in financing, regulation, data, and technology. One of the approaches that we have with our partners is the AFCFTA Anchored Pharma Initiative and the Africa Digital Health Initiative. So working with partners such as Afri-Exim Bank, CDC, and others to build climate smart, resilient, and equitable health systems, ECA supports mobilizing impact investment platforms that link health with climate resilience and job creation. I'll stop there. Thank you.
Thank you very much. Very important message and a timely message. but we were trying to keep everything going so that we're not here till midnight. Thank you very much indeed. Important perspective from you, Nectar. Let's see if Peter Sands from the Global Fund, and every time I see you, Peter, we're talking about domestic resource mobilization, can deliver here. Peter, what's the vision? Why is it so important?
Well, actually, I'm going to use my 3 minutes, and all protocol observed, if you'll excuse me. I'll use my 3 minutes to explain why actually the Global Fund replenishment is critical to the agenda of achieving self-reliance across the continent. It may seem contradictory to focus on replenishing an external funder, but it isn't really. No one disagrees about the imperative to accelerate the pathway towards nationally led, nationally financed systems for health, no longer reliant on external support. But it is a pathway. It's not a switch. Too abrupt a transition will derail progress, cost lives, leave people behind. For pretty well every member state in the room, the two biggest sources of external finance for health have been for many years, on the one hand, the US bilateral programs, PEPFAR, PMI, USAID, and on the other, the Global Fund. You will have a direct experience of what's happened with the US bilateral programs over the last few months. We are acutely conscious of the role we play as the largest multilateral funder of health across Africa. Our role is to be a partner as you chart, as you lead a transition to self-reliance. We're a partner that wants to incentivize, encourage, support, but ultimately get out of the way. And we have got out of the way. We have exited 58 disease components across 52 disease components across 38 countries and expect to do another 12 in the transition from the current grant cycle to the next. Those are global numbers, not just numbers in Africa. But we're very actively also engaged with you through co-financing, through opening up WAMBO to domestically funded procurement, to working with you on public financial management, to working with the AU and Africa CDC on health financing advocacy, to transactions like blended finance, debt swaps, and so on. It's also critical that together we ensure that we get the epidemiology of the key diseases into a state where transition is possible. It's one thing to take on funding responsibility for a disease that is well contained and with the numbers moving in the right direction, reductions in infections and deaths and so on. It's another thing to take on responsibility for a disease that is exploding, for a pandemic that is out of control. To play our role as the Global Fund, to be your partner in the journey towards self-reliance, we need money. And that's where I need your support. Put very simply, if donors think they hear from you that you're already self-reliant and that you don't need external support from the Global Fund, don't be surprised if you don't get external support from the Global Fund, because we won't have the money. But if they hear from you that actually, yes, you're committed to an accelerated pathway of increased domestic resource mobilization, of controlling the way your health system programs develop, but that you need support from us during that pathway, then we will be there. And that is what I think is the right answer if we are to get anywhere near to the SDG 3 aspiration, the targets, both for the specific diseases, but also the overarching target of health and well-being for all, which is what the people of Africa deserve. Thank you.
Thank you very much, Peter. Thank you very much indeed. Right, let's move to Thomas Osteros. I think it's a video message, and Thomas Osteros is the European Investment Bank Vice President. Could we run that bit of VT, please?
Your Excellency, President Hakainde Hichilema of the Republic of Zambia, Honorable Ministers of Health, Finance and Planning, Your Excellency Ambassador Mahmoud, Commissioner for Health, Humanitarian Affairs, and Social Development of the African Union Commission. Ms. Nardos Bekele Thomas, esteemed Chief Executive Officer for AOTA NEPA. Dr. Sean Kasey, Director General of the CDC, Mr. Peter Sands, Executive Director of the Global Fund, esteemed development partners, colleagues, and distinguished guests, all protocols observed. Good evening. It is a privilege to address you today, even if we are in a world that grapples with interconnected challenges, pandemics, climate change, geopolitical and economic instability. We are probably seeing the highest degree of uncertainty in many decades. This certainly brings about challenges, but with challenges comes opportunities. Declining external aid calls for a rethink of how countries finance themselves. And for us, the European Investment Bank, the largest multilateral development bank in the world, this also calls for a rethink of our work. What can we do to really help countries invest in things that matter, in things that bring impact? Of course, there is no single solution to this complex challenge, but there is a way forward, a way that gives me hope. And that way is together, not governments alone, not WHO, not donors, not multilateral development banks, not the private sector alone, not any single actor on their own, but all of us working together as one global health financing team. At the EIB, we are a strong believer in international partnership. This is why we are teaming up with WHO, with the Gates Foundation, with Gavi, the Vaccine Alliance, with national governments, and of course with the European Commission, our closest. Let me give you a concrete example. As said, WHO and EIB have worked together for years, combining WHO's technical expertise with the EIB's financial firepower. And this is the logic behind the Health Impact Investment Platform, or HIIP, launched 2 years ago at the Paris and operational as from 2025. HIIP is already engaging with 17 countries, providing technical assistance that helps identifying priority health investments, costing them, and helping governments build credible, concrete, bankable investments. Plans that MDBs can support, align with national health strategies, national budgets, and the principles of the Lusaka agenda. One plan, one budget, one report. The platform aims to mobilize up to 1.5 billion euros in concessional loans to strengthen primary health care and build resilience in low and middle-income countries, notably here on the African continent, addressing not only immediate health needs, but also the broader socioeconomic determinants of well-being. This is what impact investment in global health looks like. And it is working. For example, in Ethiopia, a long-standing partner benefits from the European Investment Bank's support in progressing investment plans. In Burundi and Zambia, technical assistance will support the development of investment plans for primary healthcare aligned to country priorities, identifying concrete investable projects. The list of countries is starting to become long, and the outreach span is wide. From Kazakhstan, Uzbekistan, Tajikistan, and Kyrgyzstan, to the Maldives and Bangladesh, to African countries such as Morocco, Gambia, Guinea-Bissau, Angola, Cameroon, Senegal, Tunisia, Djibouti. And beyond the founding partners, WHO, EIB, and the Islamic Development, we are now also seeing a great opportunity to scale up the platform members even further. We truly believe that joining forces is the way forward. By combining MDB's financing with WHO's technical expertise, HIIP creates a sustainable health investment model that safeguards essential services, strengthens fiscal resilience, and drives progress towards universal health coverage, even and declining globally. Let me end by saying that at the EIB, we believe that health is not a cost to be contained. It is an investment in people, in stability, and in prosperity. So let's make that investment together. Thank you.
Thank you very much to Thomas Osteros, the Vice President of the European Investment Bank. Our final speaker before we move to our high-level multi-sectoral panel is Mr. Sima Gray Johnson, Director, Human Capital and Institutional Development at AUDA NEPAD. Sima Gray Johnson.
Thank you. Thank you very much, Henry. And I think in the interest of time, I will make 5 quick points under my 3 minutes. Yeah. The first point I want to make is that your development agency, the African Union Development Agency, focuses mainly on job creation, employment, entrepreneurship, and creating an enabling environment for investments and financing. And this is why we are convinced that by 2030, Africa's health economy alone is projected to reach about 259 billion, which is equivalent to the entire global coffee market. So PIFA, a Program for Investments and Financing in Africa's health sector, makes sense. That's the first point I want to make. And on top of that, we will be able to create some 60 million jobs if we stay on course on PIFA. The second point I want to make is the Program for Investments and Financing in Africa's health sector draws heavily from existing work done under the leadership of His Excellency President Paul Kagame on the ALM. And we are happy that we've been consistent in the national health financing dialogues. So far, we have about 11 countries. I don't want to go through the list, but the point we want to make on this second point is that we continue to encourage more African countries to undertake these national health financing dialogues, because it's through these dialogues that we are able to decipher the programs and the projects that require investments and financing. The third point I want to make is that we have worked closely with regional economic communities over the years, strongly with the African Union Commission, Africa CDC, to create what we call the regional health financing hubs. And these hubs are very critical for our regional economic communities, all 8 of them, because it is through these hubs that we are able to decipher the regional dimension that is needed for the projects and programs that must be implemented with a multifaceted and multidimensional perspective, so that we don't do it alone in country, but we have a regional approach. So we encourage more and more countries to be part of these regional health financing hubs. The fourth point I will make is that we also work closely with Africa. So we've heard from my brother, the work they're doing on food procurement, very important. The work on surveillance mechanism, the Africa Continental Free Trade Areas work in terms of prioritizing local production as one of the top priorities for trade. We also work closely on insurance portability, sales mobility. We're working very close with the African Union Commission to have a qualifications framework so that Africans can move within Africa. The skills we need and the education required to really spark what is needed. And we heard our esteemed Honorable Minister from Zambia harped on the need for education and skills. And finally, if we do not continue with these national health financing dialogues, we will not have a clearer picture of exactly the investments and financing portfolio to make it possible for Africa to really continue implementing its PIFA. Secondly, the issue of risk. The past 2 years, we have been in many dialogues across the world. We keep hearing that Africa is risky. We have to take a deliberate effort, and we have to be very decisive that it is our continent. It's just a perception, because trust me, Africa is profitable. I'll leave it here for now. Thank you so much.
Thank you very much indeed. I'm clapping because you came in at 3 minutes and 28 seconds. The leanest, I think you made me think, okay, I wanted to hear more. And we've all got to think about that mindset, pare it down, get to the point. That's what we're going to try and do, because we've got a lot of speakers here tonight. So thank you very much. And that concludes the first part of our evening. So thank you very much to you. And apologies as well, because I know that you, Dr. Juku, and let's have a look. Madam Nolene Nomtansankwa Bebe, we're meant to be doing a health financing presentation. We can no longer do that because of time. So I'm sorry. about that. That has to be nixed from the program. But let me thank you and all our speakers, Peter Sands, representative of UNECA, Dr. Ngongo, let's have a look, Professor Rakitonirina, Dr. Muchima, thank you very much, and Adi, thank you very much indeed for that first panel. Thank you. I believe the paparazzi here may want to take a photo if you want to assemble yourselves at the front. Thank you very much indeed for that first session. Where I think there. No, you can go there, right in front of the desk, in front of the desk.
Should be down.
No, they're there. Oh, okay, down. Okay, go down, yeah. And while our colleagues are taking their picture, just to let you know what's going to be happening in a moment or two, we're going to have our high-level ministerial and multisectoral panel. I'll be introducing and handing over to Professor Francis Kasolo, the WHO Liaison Office, African Union Head of WHO Office. So he is the main conduit between the WHO, Africa region, and the African Union. And he'll be moderating a panel, and we will have the Minister of Health from Cabo Verde. We will have the Chief of Staff and Director General of the Ethiopian delegation. We'll have the head of delegation of the Republic of Rwanda, the Deputy Finance Minister of Ghana, and the Permanent Secretary for Finance and Planning, Republic of Zambia, the President of the Africa Business Council, and the Director Industrial Development of the AFC-FTA. If you heard me announce your designation, would you please come up to the stage? Representatives from the AFCTA, from the Africa Business Council, Permanent Secretary for Finance and Planning Zambia, Deputy Finance Minister of Ghana, Head of the Rwandan delegation, Chief of Staff from Ethiopia, and Minister of Health from Cabo Verde. Thank you very much. Okay, thank you very much indeed. So we're about to commence our high-level ministerial and multisectoral panel. It will take just under half an hour. And then we will have a moderated dialogue, time permitting, with our colleagues here present. So let me hand over to Professor Francis Kasolo, who heads the African Union liaison, the WHO liaison with the African Union. Thank you very much indeed.
Thank you very much, Mr. Bonso. Just a message to the previous speakers that in the little package that you've been given, there is an assessment of the potential impact of external reductions on health systems and health financing vulnerabilities in Africa. I think it tells the story of what you were explaining to all of us. Excellencies, distinguished guests, colleagues, welcome to this high-level side event on health financing. Our theme tonight is from commitment to action, accelerating domestic investment and multi-sectorial leadership for health in Africa. This discussion, as we've heard, comes at a time when Africa and indeed the globe is facing serious physical constraints, declining ODA, and urgent health needs. Tonight, we have assembled a panel of government leaders, business, trade, and development financing leaders who are shaping health financing solutions on the continent. Mr. Bonso has introduced a panel, and I will immediately go to addressing the questions to our panelists. I'll start with Dr. George, the Minister of Health of Cabo Verde. Honorable Minister, Cabo Verde has mobilized innovative partnership to expand physical space for health. Could you kindly share concrete examples on how these partnerships have enhanced domestic financing in ways that could inspire replication across the continent of Africa? Honorable Minister.
Thank you very much. Dear panelists, MC, I was hoping, having been invited, that I could at least give you an idea about my country, Cabo Verde. It's so small, so many of you may not even know it. And if you got to know it, I think that it would be very useful. We need to state that in spite of what we are today, we come from a history of poverty, huge poverty. Really, Cabo Verde is a story of resilience. We had 500 years of colonization, and we went through a lot of cycles of poverty and of drought as a result of our link or our proximity to the Sahara Desert. And a lot of our population, we have been independent for 50 years. 800 per 100,000 lives. The infant mortality and life was about 55 years. 50 years later, we have gone through 3 more cycles. And this was a result of several factors. The first was about the political commitment and resolve, and also the resilience of Cabo Verde. Right from the outset, we recognize that we are a very poor country. We don't have any natural resources, and we are subject to climate change and our position. So the only richness we had was really our people, human capital. And this is how 50 years after our independence, we have invested in education so that we can have a better future. And this was how Cabo Verde won its independence at the global level. And this is now how we are gaining more recognitions. But since 1977, because of the different factors I mentioned, we came up with an initiative which promotes women's health. We had about 90% of women didn't have their partners living with them in the household. And this is how we had a change in the way we had how many skilled attendants at home. If we looked at infant mortality, we had the life expectancy of 55 years. But when we became democratic and independent, we then improved our life expectancy to 80 years for women and 75 years for men. It was political resolve and our resilience that enabled Cabo Verde to really make the most of every dollar and cent that was invested in our country. After we implemented the activities about women and pregnancies, and then next comes children. We invested hugely in immunization. In 1992, 1993, we were depending on UNICEF to receive funding. UNICEF was already supporting us so that we could cover 80% of immunization. And now we are really purchasing all our vaccinations. It's the state that is doing that. We have routine immunization for polio and for measles. And now we are moving on to HPV, hepatitis B virus. And we are doing this from the state budget. So this means that Cabo Verde has evolved from an underdeveloped country, has now become a middle-income country, and in 2025, it is actually considered intermediate and high level. And this is because we really made the most of our scarce resources. When we gained our independence, the budget allocated to health was 1.7%, but then we went onwards and upwards, and today we have 10 to 11%, which is dedicated to health. At the time of the COVID pandemic, it fell a bit, but then we raised it to 16. So this is as a result of political will. And political will also is linked with the awareness of the people and making sure that people knew how important it was to invest in health. But to respond directly to the question asked of me, I would say that at this time, the state budget is financing about 15% through its tax collections. And then if we look at the family household level, they spend about 54% on health expenditure. Now, our relationship with the private sector and with our partners, WHO, the Global Health, actually, we are at different levels according to which agency it is and the different areas. We have our traditional partners. Our relationship is based on the objectives which we are hoping to achieve. It's not a question of what we think is most important from the partners' perspectives, but also what Cabo Verde thinks is important for them and how we can best work together. And so we think that we have many. So I just want to wrap up now. We have many success stories. And we managed to certify free of polio in 2024. And then we had the success story with malaria, that we are malaria-free, and also from rubella. And also the mother-to-child transmission. This is a result of the investments that we have made, and we will continue. I could go on and on about this, and I will leave it here. If anyone would like to talk to me in the corridors, or if you would like to visit our country, we would be very happy to welcome you and talk more about all these issues.
For the historical background, but as well the investments that you've made through the government treasury, but also through the private public partnerships. We will try and advise that we keep it short because of the time that we've been allocated. We'll move to Dr. Mabratu from Ethiopia, and Ethiopia has been pioneering the health investment platform and has made significant progress in advancing its primary healthcare strategic framework. and indeed primary healthcare investment plan, which is supported through the health investment platform. Could you share how this platform has shaped Ethiopia's approach to mobilizing resources for primary healthcare and resilience?
Thank you. Thank you, Professor Casalo. So, distinguished panelists and also colleagues. It's a very good question that Ethiopia is honored to be a pioneer country. And as we heard in earlier panel that the European Investment Bank with WHO was selected Ethiopia to be a pilot on investment platforms, which are very much tailored to health impact, which was launched by Multilateral Development Bank in WHO in 2023. So main objective was to strengthen healthcare, pandemic preparedness, and the climate resilience. These three things, I think, are major things that we discussed in the last 2 years of our deliberations, 2 days of deliberations. This HIP operates as a multi-stakeholder platform, integrating WHO technical assistance and the financial planning support from the bank. So it is very, very pioneer in its nature of crafting this framework that we worked out. Our government strategic vision is also in the center of this plan. So it's fully embedded within our health sector transformation and investment plan, which Ethiopia usually rolls out for